Hello. Hello. Ah.
Yes, good morning to all the speakers.
Morning.
And Dr. Andreas, I see Dr. Akanksha, Dr. Irina already has come. Dr. Sophia, good morning to all.
Me too.
Yes, ma'am.
Morning.
Good morning.
Morning.
So how was the session yesterday and how was your experience yesterday? We can share a few experiences from your side before the entire session starts. Yes, Dr. Andreas, we'll start with you for now. How was your experience yesterday? You had delivered a wonderful presentation yesterday. Can you hear my voice, Dr. Andrea?
Yes, loud and clear.
Yes, can you please share a few words on how your experience was yesterday?
I think we saw a lot of different topics of the fields of pathology, covering rare entities and rare findings, and also common tumors. We discussed a lot of practical things like the radiographic examination and the gross macro of breast cancer samples after therapy, and also got some anatomical refreshments from the ampulla region, for example. So this is a very broad spectrum, but we do not lose the focus to our clinical works because we had a lot of interesting case reports that are a good example for a thorough diagnostic workup. So it's a very comprehensive and enjoying event.
Yes, thank you so much, Dr. Andreas. And that was actually, yeah, yesterday's discussions, I think, were very insightful and new topics as such, and also some molecular level talks had happened. So that is basically showing from simple basic talk that we had to a wider range of higher studies done also. So a broader spectrum like what you have just stated, all the topics were discovered and explored, and that is very nice. And yes, Dr. Sophia, can we have some few words on yesterday's your experience as well? Can you please share it with us?
Yeah, thank you, Neetu. Thank you, Dr. Andreas. I think after a long period of not being able to go for pathology conferences and interact with colleagues from all over the world, it was really a welcome experience to listen to people from all over Europe and from America, from India, and the range of experiences and the material presented just goes to show show that a lot of excellent work is being done in the field of pathology. Like you said, a lot of molecular-based work, along with classical histopathology, which we should never lose sight of. In the field of IHC and molecular, we mustn't remember how the cells actually look like. And I think if any postgraduates are listening into this talk or to the speakers, I think they would have got a lot of interesting ideas and materials for which to either process or proceed with their thesis or with their fellowship studies. I think it was an excellent academic phase, and I'm looking forward to the same today. I am really looking forward. If I look at the topics, there are some excellent topics which are going to be covered. And all the best to Neetu and Dr. Archana for moderating the sessions and keeping the rapport going. Yeah?
Yes, thank you so much. That was initially handed over by you, Madam Dr. Sophia and Dr. Andreas, who took over the plane yesterday to a much better stand-up position. And today it is our duty to carry on with whatever you people have set high standards for. So thank you so much for hosting and sharing the sessions yesterday. It was a wonderful experience, even listening to the way that different speakers had talked about various topics, as well as even the chairing sessions, the way that they went on smoothly. And yes, Dr. Akanksha, would you like to add a few words on how your experience was on day one of this conference?
Yes, ma'am, it was a great experience. It was a great pleasure to listen to all the very eminent personalities of all over the world. And I am looking forward to learn more and more as much as possible. Thank you.
Yeah, okay, thank you so much. Like what Dr. Akanksha had said, actually, and Dr. Sophia ma'am had stated that this kind of conference, this kind of platform enables various postgraduate residents to come forward and learn something new and get an idea on how, what kind of studies are being done across the world in developed countries and developing countries, to have the overall bird's eye view. I think it is a very good platform, an opportunity given rightly to all of us, particularly in this pandemic COVID times, where it is difficult to go and present ourselves in real.
Yes, absolutely.
So I think this virtual platform is doing the job for us. Yes. Madam Dr. Archana, have you come online? Yes. Looking forward to hear a few words from your end.
Yeah. Hello, Dr. Neetu and Dr. Sophia and Dr. Andreas, who had hosted wonderfully as a chairperson in yesterday's session. And a very warm welcome to all the other participants as well who had joined in this conference today for the morning session as well as for the evening session. So I am Dr. Archana and I will be hosting for the morning session, and Dr. Neetu will be taking up the chairperson responsibility in the afternoon. Well, it was really an interactive and informative session yesterday we had throughout the day, and it was a wonderful experience, starting from the postgraduates and the speakers, keynote speakers, and other doctors who had participated across the globe to update their knowledge and go keep updated in the field of pathology. And during this pandemic, to have this conference, it was a wonderful opportunity for all of us to come on this conference platform to share our knowledge. And this will help us to keep motivated to keep ourselves updated about the field of pathology. And it was really nice to get familiar with the various pathologists across the globe yesterday. And all of the speeches were really informative, and they had a very detailed explanation of their case studies. And in the lunch break as well, we have gone through the posters as well, poster presentations, and they were really interesting. And there were many of the rare cases which I didn't come across during my practice till now. So they were really enlightening to us to get to know even such cases do come we could anticipate such type of cases in our future, in our near practice. And all the best to all of the speakers for today's session. Well, yeah, thank you, Dr. Neetu.
Thank you
Yeah,
so much, Archana.
yeah.
Are we going to start with chairing the sessions? Are you going to take over the chairing now, ma'am?
Well, if we want to proceed, go ahead. Then I would like to
Yeah, I
give
think
my
I will
welcome note.
ask the organizers if we can start with
Yeah,
the
sure.
presentation.
Yeah.
So can we have a few words from Dr. Kelly Elliott if she's available? Is she available? Yes, Dr. Kelly. Okay, we can move on to the next participant. Lopamudra Kakoti, can we have a few words from your end? You're available about how your experience was yesterday? Anyone who would like to add a few words?
Yes.
No.
So all the
Yeah.
posters are available on the official website of the 5th Emirates Pathology Conference. The complete conference session video will be available on YouTube and other broadcasting sources. The certification will be provided to you on December 4th, 2020. So kindly go through the e-posters as well, because they are really interesting, and they are going to enlighten us that we could get familiarized even with that cases as well. It's really a good opportunity to brush up our subject in knowledge in pathology.
Dr. Kelly, can you hear me? Dr. Kelly, good morning.
Sorry, yes, good morning, I can hear you. I had to
Yeah,
step
good
outside, the
morning.
signal
Can
was
we have
terrible.
a few words on how your interaction was yesterday and your experience? Can you just add on a few words to all our speakers who are listening to you now?
Yes, of course. No, I had a very enjoyable event yesterday morning. It was great. A really wide range of cases, and it was lovely to hear from such a broad selection of delegates. I think everybody had a good discussion, and certainly afterwards we had quite active discussion about, especially our cytopathology, and Andreas brought quite a lot of discussion points at the end of the morning session.
Yes. Okay, thank you, Dr. Kelly, for the few words that you have added. Yes, it was very enjoyable. True, that was so true. Yesterday, I had even also seen some new cases which I have never come across in my experience, and how those entities were actually discovered or what kind of investigations were done. That also was very interesting point of view. Yes, thank you.
Okay, if it's okay, I'm gonna hang up and dial back on my work phone. I think the signal will be better. So if I disappear for 2 minutes, that's where I've gone.
Yes, that is fine,
Yeah.
Dr. Kelly.
Sure.
Okay, thank you. See you in a second.
So, Dr. Neetu, shall we start the welcome speech?
Yes,
Because
Dr.
I think
Archana.
it's
Yes,
time,
it
we
is
need to
time
start the
for us
morning
to
session.
start off for today. Yes, you can go ahead, Dr. Archana.
Yeah,
Thank
I think a good number of doctors have
Participants.
already joined.
Yes,
Yes, and hopefully all the morning session participants have already logged in. Yeah.
yes.
So let's go ahead.
Okay.
So welcome all. A very good morning to all of you, and welcome to Emirates Pathology Utilitarian Conference gathering for the year 2020. As we all know that we have successfully completed day one session, and we are looking forward to start today's morning sessions in a short while from now. And definitely these are going to be really informative and interesting sessions. And hope you all had an experienced informative sessions yesterday. So without wasting not much of time, let me introduce to the audience who will be joining us for today's morning session from different countries around the globe. So let me introduce them. So our first speaker for today's morning session would be from the United Kingdom, and the topic that Dr. Ritika Sharma will be presenting for us today is the comparison of autofluorescence technique with other conventional methods in detection of mycobacterial bacilli on fine needle aspiration cytology. And Dr. Ritika Sharma's speech would be followed by Dr. Neetu Vanapalli from India, and she would be talking about a diagnosis lost on cytology, fished out on histology, tubular adenoma, a study of literature, and followed by Dr. Neetu. Dr. Akansha Singh would be delivering a speech from India, and she would be talking on cribriform modular variant of papillary carcinoma thyroid in an old treated case of medulloblastoma, a rare and distinctive case. And after that, we will be having the next speaker, Mr. Maligin Nikita from Russia. And he would be talking about the Integrated Virtual Pathology Museum, use of technology MR, WSI, and 360 product image in medical education. And Dr. Maligin Nikita's speech would be followed by Dr. Sophia Marilyn George, and she would be speaking from Malaysia. And her topic for today's presentation would be stromal osseous metaplasia in recurrent urothelial carcinoma forming an ossified pelvic mass, report of an unusual case. And her speech would be followed by Dr. Alvaro Ibarra from Chile. And his topic for presentation today is ciliated carcinoma associated with human papilloma virus, presentation as cervical metastasis of unknown primary. And the last presenter for today's morning session would be Dr. Zay Leifer from Germany, and he would be talking on lookalikes, a pathologist's challenge, parasite or tumor, a brief literature review and discussion. So this is the brief introduction of our speakers for today's morning session. And hopefully I think that the morning speakers are available right now. And the first speaker for today's morning session presentation would be Dr. Ritika Sharma from the United Kingdom. I hope that Ritika Sharma is available now.
Yes, Dr. Archana.
Well, good morning, Dr. Ritika.
Good morning, Dr. Archana.
Yeah, hope that all the settings are clear for you. Yeah.
Shall I share my screen now?
Yeah, sure. Please go ahead.
Is it visible?
Well, yes, you could do it in the full screen mode, your
Yes.
presentation. Yeah, well, that's good. Yeah.
Shall I start now?
Yes, sure, Dr. Ritika.
Okay. So, good morning to all. And I would like to first thank you for the organizers to arrange such a wonderful conference in this difficult COVID time when we are not able to meet. But this is a virtual platform, so we are able to meet with different pathologists from all over the globe. And this is quite a different but a new thing for all of us. And brief introduction about myself. I am Dr. Ritika Sharma and I did my post-graduation in pathology from India. And currently I am working in UK since simultaneously preparing for my Royal College exams. So thank you for giving me this wonderful opportunity to speak about a small study which I did during my post-graduation. And it would be great to discuss about my study among the eminent pathologists from all over the globe. I'll be discussing some of the salient features of my study. Please feel free to give your suggestions or ask questions. Now, the topic of my study was comparison of autofluorescence technique with other conventional methods in detection of Mycobacterial bacilli on fine needle aspiration cytology in cases of tubercular lymphadenitis. I know the topic is quite huge, but the main gist of my topic is about tuberculosis. So, as we all know, and I think everybody will agree with me that tuberculosis is one of the oldest disease known to mankind, and its evidence is detected even in Egyptian mummies. So it's quite oldest disease, and it remains as a leading cause of death worldwide, especially if we talk about the developing countries like India, tuberculosis remains a major global health problem. Though we have reached a new millennium, but at the dawn of this new millennium, we are still mute to witness the silent yet efficient march of this serious disease, its myriad manifestations, and above all, its unequaled, vicious killing power. Throughout the millennia, tuberculosis has never ever disappeared from the developing world. Though the Western countries, they have been able to have control over this deadly disease, but if we talk about the developing countries, they are still in phase of curing this disease. So, a brief introduction. In the initial part of 20th century, one of the great pathologists has rightly said that as a destroyer of mankind, tuberculosis has no equals. Tuberculosis ranks as the second leading cause of death from an infectious disease worldwide after the human immunodeficiency virus. If we talk about India, where I did my study, India accounts for 1/5 of the world's new tubercular cases and 2/3 of the cases in Southeast Asia, which is a huge number. If we talk about the world, almost 1/3 of the world population is infected with tuberculosis. And in 1993, WHO, they have declared tuberculosis as a global emergency. It remains the single most infectious disease, causing the highest mortality in humans, leading to 3 million deaths annually and about 5 deaths every minute, which is quite a serious thing. If we come on to the most common presentation, we all know the pulmonary tuberculosis is the most common presentation. But it does not mean that it presents only in this form. The extrapulmonary tuberculosis constitutes about 15 to 20% of all cases of tuberculosis. And out of these extrapulmonary manifestations, lymphadenopathy is the most common. Now comes the challenges which pathologists and clinicians have to face in diagnosis of these lymphadenopathy. So one way was to just excise the lymph node and send it for the diagnosis. But we'll all agree that it's quite invasive and not everybody will be happy in going to these invasive techniques. So this has been overcome by the technique called fine needle aspiration cytology, which has an important role in the evaluation of peripheral lymphadenopathy as a non-invasive alternative to excisional biopsy. Now, let me ask you, so who are at risk of tuberculosis? So, everybody here will agree with me that anybody and everybody can be at risk of tuberculosis. It is such a deadly disease, it is such an infectious disease that anybody can get this infection. The list is quite exhaustive. But just to name a few high risk categories, these include the close contacts, means those who are sharing the same household or other enclosed environment of persons known or suspected to have tuberculosis, persons who are infected with human immunodeficiency virus, because those who are having this virus, they are already immunocompromised and have increased risk of contacting tuberculosis. Other high-risk group include those who inject these illicit drugs or other locally identified high-risk substance users, such as cocaine users, healthcare workers like us, and the clinicians who look after high-risk patients. Foreign-born persons, including children, recently arrived from countries that have a high incidence or prevalence of tuberculosis. Now, after discussing about the risk factors or the groups who are at increased risk of tuberculosis, now I would like to discuss briefly about the etiology of tuberculosis. So tuberculosis is caused by Mycobacterium tuberculosis. Now the genus Mycobacterium is included in the family Mycobacteriaceae and the order Actinomycetes. Now this genus consists of non-motile, non-spore-forming aerobic bacilli. They are slightly curved roots showing filamentous branching forms and beading. Now, the special characteristic about this Mycobacterium tuberculosis bacteria is its unusual cell wall structure. When I'm saying that it's unusual cell wall, I want to say that the cell wall of this bacteria contains N-glycosylmuramic acid in lieu of N-acetylmuramic acid and has a very high lipid content. And because of this reason, it is difficult to stain this bacteria with commonly used basic aniline dyes, which we normally use in our lab. Because of its unusual cell wall, high lipid content, this bacteria, it resists decolorization by acidified alcohol after prolonged application of basic fuchsin dye or with heating of this dye. So here comes the challenge that we need to have special stains for this bacteria in order to identify them and make an appropriate diagnosis of tubercular lymphadenitis. Now, as I told you that lymphadenopathy is the most common extrapulmonary manifestation, and for this identification of lymphadenopathy, fine needle aspiration cytology has assumed an important role in its evaluation. Now, diagnosis is mainly based on clinical features, cytomorphological patterns, histopathology, identification of acid-fast bacilli, and isolation of Mycobacterium tuberculosis on culture media. Now, there are various cytological patterns which we can see in the Mycobacterium. So this includes the epithelioid granuloma with necrosis, which means that when we see aspirate and when we stain it and when we see the cytomorphological features, we can have epithelioid granulomas along with necrosis. So in this first picture, I'm sorry for the not so good quality of my pictures, but I'll try to show what I want to show. So basically, the first picture that's showing is a FNAC smear revealing the necrotic background, and in amongst this necrotic background, we can see the lymphocytes, lymphoid cells, and epithelioid cells. The down picture, there are only few lymphocytes and the background is necrotic. Now, the third picture, it shows that cluster of epithelioid cells forming granuloma, which we can see in the another picture, which is the epithelioid cells. They are slightly elongated and different from the round lymphocytes. So as I told you that the cytomorphological patterns of mycobacterial infection can be first epithelioid granuloma with necrosis. So this is the necrotic pattern which I showed. And in the next picture, we can just see that there is a multinucleate giant cell in the background of lymphoid cells. If we see the high power of this picture, Then these epithelioid cells, we can just see how elongated they are and how bigger in size they are as compared to the lymphocytes. Another picture showing the cluster of epithelioid cells forming granuloma. So these are typical elongated slipper-shaped epithelioid cells in the background of small lymphocytes. Here's the another picture showing the granuloma. So the first pattern is epithelioid granuloma with necrosis. Another pattern can be, we can just have the granuloma, epithelioid cells forming granuloma without any necrosis. Like in this picture, we can't see any necrosis. Similarly, in this picture, the necrotic pattern is not so prominent. And the third pattern is necrotic material without epithelioid granuloma, which is shown in this. There is necrotic background, but we are not able to appreciate any epithelioid granuloma. And the fourth pattern is necrotic material with neutrophils without any epithelioid granuloma. Means there is necrosis, there are inflammatory cells, along with lymphocytes, there are neutrophils, but there is no epithelioid granuloma. Now, for the detection of these acid-fast bacilli, we have some conventional methods, which we all know. These are Ziehl-Neelsen staining and the cultivation on Lowenstein-Jensen media. But there are certain other methods besides these conventional methods, which include the fluorochrome staining pattern, there are two types of staining which comes under this fluorescence staining. This is auramine rhodamine stain and autofluorescence on PEP stain. Now, other methods of identification which are performed by the microbiology department include serological method, in which we detect antibodies against the mycobacterial antigen. Then chromatographic methods like thin layer chromatography, gas liquid chromatography, and high performance liquid chromatography. Then the newer methods, molecular methods like DNA hybridization and DNA microarrays, nucleic acid amplification methods like polymerase chain reaction, and the DNA gene expert is also a new method of data identification which was introduced in last few years. Now, after this brief introduction about tuberculosis, its etiology, about the bacteria, now I'll be discussing about my study, which I did. So the main aims and objectives of my study was to study the detection of mycobacteria in lymph node aspirates on autofluorescence and comparison of autofluorescence and other fluorescence staining techniques with conventional methods like Ziehl-Neelsen staining and culture. Now, this study was conducted in the Department of Pathology, Pandit B.D. Sharma PGIMS Rohtak, where I did my post-graduation over a period of 2 years. Now, the study group constituted aspirates from 75 patients of tubercular lymphadenitis or suspicious of tuberculosis. So, informed consent, written consent of all the patient was taken for performing different diagnostic tests. Now, a performa was prepared, and this performa included the relevant information about patients, including their age, gender, duration of disease, systemic symptoms, or what we call as constitutional symptoms of tuberculosis, such as fever, chills, night sweats, and weight loss. Also included in the performa was the significant patient medical history, including history of any malignancy, carcinoma, lymphoma, infections like AIDS, and past history of tuberculosis or contact with tubercular patients. After taking this detailed history and the written consent of the patient, the physical examination of lymph nodes was done, and it was reported, including the size of lymph nodes, the site of lymph nodes, consistency, whether the lymph nodes are tender or non-tender, whether they are discrete, matted, or fixed, in order to just differentiate and to find out at the end of the study that is there any particular pattern of lymph nodes which we can see in tubercular patients, or they can have a wide variations. Now, after physical examination of the lymph nodes, the patient blood sample was taken for routine investigations like hemogram, complete blood picture, ESR, that is erythrocyte sedimentation rate, MON2 test, and chest radiogram. Now, what was the inclusion criteria and exclusion criteria for my study? So, in my study, all males and females of all ages who were suspected of tuberculous lymphadenitis were included, while the patients who were having some malignant conditions or the history or the radiographic imaging were suggestive of some primary metastatic malignancy, they were not included in our study. And also those who in which the sample, FNAC sample, was inadequate were excluded. Now, fine needle aspirations were performed under a sterile aseptic conditions on the suspected lymph nodes using a sterile disposable 23 gauge needles and 20 cc syringes. Now, 4 smears were made from each aspirate. 3 were air-dried smears, and they were stained with Giemsa or Leishman, Ziehl-Neelsen stain, and Oramin-Rodamin stain. And 1 smear was wet fixed for Pathology staining for autofluorescence. The aspirate was also sent to the Department of Microbiology for culture on Lowenstein-Janssen medium. Now, observations which we found on different staining pattern. On Ziehl-Neelsen staining, the smears which were stained by Ziehl-Neelsen method were observed under oil immersion field using light microscopy, and AFP appeared as pink, slightly curved rods 2 to 8 micrometer in diameter against blue background. So this is the acid-fast bacilli, which is we can see as pink beaded filamentous bacilli on Ziehl-Neelsen staining. On Oramin-Rodamin staining, which is a fluorescent stain, the smears stained by this method were observed with low power magnification using fluorescent microscopy. And acid-fast bacilli, they appeared as bright yellow or golden yellow against a dark background. So these were these bacilli. The background was dark, and these small curved bacilli were seen on Oramin-Rodamin staining. On autofluorescence staining, the smears which were stained by Pathology stain, that is the PAP stain, were observed with low power magnification using fluorescent microscopy, and AFP acid-fast bacilli, they appeared as brilliant yellow fluorescent rods, thin and slightly curved, with a uniform length of 2 to 2.7 microns. So there are lots of fluorescent things in this field, but I have taken this picture just to show you that not only the Mycobacterium bacilli fluoresces, there are other things which are known as artifacts. They also fluoresce. But how to differentiate between whether this is acid-fast bacilli or these are the artifacts. So the acid-fast bacilli, these are the small curved ones, and the artifacts, they are the straight, shining things. So the finding, as we all know that while detecting the acid-fast bacilli on Zeal-Nielsen staining, we need to see them under oil immersion, and it's quite a tedious task to identify them. But the only advantage with the auramine, rhodamine, and the autofluorescence staining was that the smears were observed with low power magnification. There was no requirement of oil immersion to visualize these bacteria on these staining methods. The culture was the aspirate was sent to the microbiology department, and on Lowenstein-Jensen media, Mycobacterium, they appears as brown granular colonies called buff, rough, and tough. So this was the culture which we performed in the microbiology lab. This is a negative control with no growth, and these are the pictures which are showing this growth on the Lowenstein-Jensen media. These are the brown granular colonies of Mycobacterium bacilli. Now, taking culture positivity as because the culture is considered to be the gold standard for the detection of mycobacterial bacilli. So taking culture positivity as standard, sensitivity and specificity of different assay methods were calculated. The results were analyzed by using the chi-square test, and p-values were evaluated at the 5% level of significance. Now, this picture, we can see the positive Montu test, which we perform when the patient, first of all, when the patient comes to the clinician who is suspicious of tuberculosis, then the first thing which is done is the Montu test. So what we do in the Montu test, a specified dose of tuberculin antigen is injected into the patient's arm. And if there is a response to that tuberculin antigen in the form of this induration, that means that the patient is having Mycobacterium tuberculosis. Now, some of the salient features which I found in my study, and I found them quite relevant because there are certain things which we think that it is fixed related to tuberculosis, but that's not the case. Mycobacterium tuberculosis causing tuberculosis infection, presenting in different ways and causing the different manifestations which we even did not think about before I performed this study. So first of all, my first picture shows how the cases were distributed according to age. So in my study, it was found that the maximum cases, that is 32%, were in the age group of 30 to 50 years, followed by 28% in the age group of 20 to 30 years, and 21% in the age group of 10 to 20 years. However, if we see the youngest patient in my study was around 1.5 years of age, and the oldest was 70 years. So it was found in my study as well as other studies in the literature which have been performed that tubercular lymphadenitis can affect people of any age, ranging from small children, to adults. My study showed slight late age predisposition. Now, the reason could be attributed by the attendance pattern of the sick patient to the hospital, late presentation of the extrapulmonary symptoms of tubercular lymphadenitis, or maybe just due to low sample size, people from this age group form the representative population and may not represent the whole population. But the main finding which I found from this study was that there is no age group which is spared from tubercular infection. Now, distribution of cases according to the gender showed that female predisposition was seen more in my study, with around 57% patients, female patients affected with tuberculous lymphadenitis as compared to around 42% male patients. The reason for female outnumbering males could be due to difference in the number of patients included in the study and the geographical distribution. Now, as I told you that when I started my study and a performer was prepared in which we took history of the constitutional symptoms like night sweats, fever, cough from the patients who presented with this tuberculous lymphadenitis. So strikingly, the thing we realized that around 70% patients they presented without any constitutional symptoms. Now, the most common reason that tuberculous lymphadenitis may go unrecognized for a longer time because there is absence of constitutional symptoms. And this is quite challenging because if the patient, if these constitutional symptoms are present, then they they ask patient that to go to hospital and to get themselves checked. But if the symptoms are not there, so patients are not able to understand that they are having some disease for which they need treatment. So this is quite a thing which we should consider, that it doesn't mean that if the patient is not having the typical constitutional symptoms of tuberculosis, then these lymphadenitis cannot be due to tuberculosis. This can be due to tuberculosis because tuberculosis can present without these constitutional symptoms. Also, what I realized from my study was that they might be due to the increased awareness of the people, that they come to the hospital as soon as they notice some swelling and do not wait for these symptoms to appear. And this is a good thing because if there is early diagnosis, then the treatment can be started early and that is beneficial for the patients. Now, most of the cases from our study had positive family history or history of contact with tuberculous patients. As you can see, the 70% in 70% of the patients, there was positive history of contact with tuberculous patients. This could be attributed to high rates of transmission in tuberculosis, thus making person living in vicinity of tuberculous patient more susceptible to contract the infection and develop the disease. Now, coming to the sites of lymphadenopathy, in concordance with most of the studies done on tuberculous lymphadenitis, even our study showed the highest involvement of cervical lymph nodes, followed by supraclavicular and submandibular. Now, the reason for the highest uh, involvement of the cervical lymph nodes is because the cervical lymph nodes, they are the first to be drained lymph nodes. Now, a common misconception or understanding from the past which we have is that the tuberculous lymph nodes, they present as in a matted form, but it was not so, which I found in my study. In almost 65% cases, they presented with discrete lymph nodes and not the matted one. Now, when we perform this ESR on the patients with tuberculous lymphadenopathy, so almost all the patients, they have this high ESR level, which indicates that the ESR level is raised in chronic infections like tuberculosis. Now, we also took a sputum sample from the patients who were suspicious to find out the AFP positivity in the sputum. And the strikingly, the almost equal, 48% were showed positive sputum for AFP, and 45% they were negative. So that means that The sputum positivity is there when the patient is having pulmonary tuberculosis. So might be the negative patients were those who were not having the symptoms of pulmonary tuberculosis, or the acid fast bacilli level was so low that it could not be detected. Now, as I showed you the picture of MON2 positivity, so 45% were negative for MON2, while 54% were positive. Now, the reason for all the patients not demonstrating the MON2 positivity, which I realized was due to limitation of the test due to improper technique of administering the tuberculin antigen, or the dose of tuberculin antigen which was administered was not adequate, or the reading of the test was not done by a trained personnel. Now, talking about aspirates, the nature of aspirates on fine needle aspiration cytology. So almost half of the patients, they were having the pus aspirate, and 40% were having the blood mix aspirate, and 4% they were having the cheesy aspirate. Now, according to cytomorphological findings, the different patterns which I told you initially, so around half of the patients, they presented with the most common pattern, that is the necrotizing granulomatous lymphadenitis, meaning there was granuloma as well as the necrosis. Nearly 1/4 of the patients, they presented with only granuloma without necrosis, and little less than this were showing only necrosis. Now, when we compared the AFP detection bacilli with the different methods like Zeal-Nielsen staining, auramine, rhodamine, autofluorescence, and culture on the blood mix aspirate, there were total 33 patients who were having the blood mix aspirate. So what we found out that out of the 33 patients with blood mix aspirate, the ZN staining was positive in 45%, auramine rhodamine in 51%, autofluorescence in 48%, and culture in 63%. So taking culture as the gold standard, the auramine rhodamine was found to be more sensitive, followed by autofluorescence, and the most specific was the ZN staining. Now, out of the 39 patients with pus aspirate on FNAC, ZN staining was positive in 58%, auramine rhodamine in 64%, autofluorescence in 66%, and culture in 74%. Now, sensitivity of auramine rhodamine staining and autofluorescence was found to be highest, while the specificity was still highest with the ZN staining. Now, there were only 3 cheesy patients with having cheesy aspirate, and the sensitivity and specificity of all the staining pattern, be it ZN staining, auramine rhodamine staining, autofluorescence staining, was same, and the specificity was also same with the cheesy aspirate. Now, in the patients with necrotizing lymphadenitis, first we compared the aspirates. Now we are comparing the cytomorphological patterns. So in 17 cases with the necrotizing lymphadenitis, the highest sensitivity was shown with the autofluorescence, followed by auramine rhodamine, followed by ZN staining. With the various methods with the granulomatous, now the cytomorphological pattern was granulomatous. Out of the 19 cases, the highest sensitivity was shown by autofluorescence, followed by auramine rhodamine and ZN staining. In case of necrotizing granulomatous lymphadenitis, which is the most common cytomorphological pattern, the auramine rhodamine was found to be more sensitive, followed by autofluorescence, followed by ZN staining, but still the specificity was highest with the Zeal-Nielsen staining. Now, those patients who were positive for MON2, when they were the AFP detection was done in them, So again, the sensitivity was highest with auramine, rhodomine, and autofluorescence. Those with negative Montu test, the autofluorescence showed little higher as compared to Zn staining and auramine, rhodomine stain. So what we found out from this study was that FNA has become the first line diagnostic technique that is highly sensitive, especially in endemic areas where the mere presence of epithelioid cell granuloma indicates tuberculosis until proven otherwise. Albeit it's not specific, as other opportunistic infections may present with the similar cytomorphological features. So we need to identify these acid-fast bacilli by doing the different staining patterns. We all know that cultivation of tubercle bacilli is the most sensitive method and is considered as the gold standard, but it takes weeks for the tubercle bacilli to grow on these media. And if we have to wait for such a long time, then it will not be good. It will not be in the favor of patients. So we want something which is quick, which is simple, and so that we can make diagnosis easily, and we can start the treatment at an earliest possible time. Conventional Ziehl-Neelsen staining, which we are performing, is simple but demands technical proficiency in staining and experience in identification of organism. Moreover, it's quite tedious to just scan the slide for the acid-fast bacilli. The superiority of the fluorescent stains like auramine, rhodomine for the diagnosis of tuberculosis has been well recognized in decreasing the runtime for sample examination, because as I told you earlier also that we need to examine them under the low power, and if they are present then we can just see them fluorescing or as the golden yellow bacilli. So the runtime is decreased. However, nothing comes without any with all the advantages. It has also disadvantage that these dyes are unstable and they use expensive fluorescence reagents. Moreover, these dyes being carcinogenic cause problems to the health workers who are employed in its usage. However, unlike the auramine, rhodomine staining, autofluorescence method, they require just the pap stained smears, and thus no carcinogenic dyes are required. So that is in one sense better as compared to the auramine, rhodomine stain. Now, but the problem lies with this fluorescent staining is that the high cost and the short half-life of the mercury vapor lamp has limited the availability of fluorescence microscopy and healthcare systems with constrained financial resources. The recent development of light-emitting diode provides a cheap and reliable light source. Thus, it was observed in my study that although fluorescent stains were found to be more sensitive, but when specificity was considered, which is an important factor to be taken into consideration, the conventional Ziehl-Neelsen staining was found to be the most specific. So what I concluded, and I think you all will also agree, that this study found that sensitivity was auramine rhodomine was maximum, followed by autofluorescence and least with Ziehl-Neelsen. However, specificity was found to be maximum with Ziehl-Neelsen stain and least with autofluorescence. Our study showed only marginal difference in sensitivity between the fluorescent stains and conventional methods. Hence, no single staining method is sufficient for definite diagnosis. However, fluorescent stains, they definitely add as an adjunct to Zn stain and culture in definitive diagnosis of tubercular lymphadenitis. Now, the take-home message is that if we want to have early diagnosis of tubercular lymphadenitis, especially in the fine needle aspiration cytology samples, so In adjunct to the Zeal-Nelson staining, if possible, we should also do the fluorescent stains like auramine rhodamin and autofluorescent using the PEP stain smears, so that they can add to the diagnosis, and the diagnosis can be made at an early stage. Also, no single staining pattern is 100% diagnostic, so we have to take in consideration that we have to combine these different staining methods if we want to have a definitive diagnosis. Also, the presentation can be, the tuberculosis can present in any way, can present without any symptoms, just like lymph nodes, or can present with all the symptoms. So we have to broaden our knowledge that this is a deadly disease. We have to identify it early, and we have to make an early diagnosis so that the patients can be cured early and will not be able to transmit this disease to other. So these are the references which I used while during my study. I would like to thank you all for the patient hearing, and if you have any questions, please, you can ask.
Thank you, Dr. Ritika, for a wonderful presentation. As we all are aware that tuberculosis is endemic in India, and Dr. Ritika has done an exhaustive study on this, and she has evaluated very nicely on the tuberculosis demography, and also she has enlightened us about the detection of the Mycobacterial bacilli by one of the superior techniques like autofluorescence technique, apart from the conventional methods. And uh, she also had, through her study, conveyed to us that autofluorescence technique had provided the platform which picked up the bacilli sensitively, but always Zeden staining was more specific according to her study. And it was good to know that through her study, especially for the postgraduates and for the trainees, that autofluorescence techniques help us to visualize the Mycobacteria bacilli as bright yellow fluorescence rods. And in short, thank you, Dr. Ritika, for a wonderful presentation. And we do appreciate the time you took in preparing this presentation and participating in the conference effectively. So if there are any questions for Dr. Ritika or any suggestions, kindly please go ahead.
Can I ask a question? Sorry.
Yeah, well, sure. Dr. Kelly?
Hi. Yes, I really enjoyed your TV chat. It's quite not a brand new thing to us, perhaps in the UK, but certainly increasing. And I just wondered, do you find the yield with auramine or ZN or even autofluorescence as good in your patients who are maybe immunosuppressed, who don't have a strong caseating granulomatous response? We see quite a lot of that in our community where people are immunosuppressed and their granulomatous inflammation isn't as necrotic, perhaps. And do you think there's a best way for us to look for bacilli in that
I would like
setting?
to say, I would like to thank you, Kelly, for asking me questions. So I would like to add that we usually start with the Zeden staining in order to first identify the acid-fast bacilli. But yes, you're right. If the patient is having the caseous aspirate or the necrotic cheesy aspirate, so the acid-fast bacilli will be easily seen if we just do the fluorescence staining like auramine rhodamin or the autofluorescence by staining with the PAP stain. So they will just appear as the bright yellow, and we'll not have to just spend a lot of time in order to visualize by doing the Zeden staining and then looking for them in the oil immersion. So it will shorten our time and these acidified bacilli will appear more bright yellow and they'll be easily picked, shortening the run time and will be beneficial for saving our time.
Okay, that's helpful. Thank you.
Thank you.
Well, Dr. Ritika, thank you for answering Dr. Kelly's question. So, are there any other doctors who could go ahead with the questions? All right. So, shall we move on to our next speaker for today in the morning session, Dr. Neetu from India? Well, I hope that Dr. Neetu is ready with her presentation.
Yes, Dr. Archana, I am ready with my presentation.
Yeah,
Thank you
that's
so
good.
much.
That's appreciated.
Should I go ahead?
Well, yes, sure.
Yes. Okay, let me share my screen and yes. Yes. Is my presentation visible?
Yes, yes.
Yes.
And
Okay.
you're audible as well.
Okay.
Kindly go ahead.
Yes. Thank you, Dr. Archana. Good morning to one and all. And I am going to just give a brief introduction about myself. I am assistant professor. I'm Dr. Neetu, working with Apollo Hospitals in Hyderabad, India. And I would like to present or bring forward this topic today in front of you all people, only because this topic being presented as a case report is just to emphasize the fact that a small benign lesion can be masked by a predominant component, which is shadowing the smaller component, and which is not very rare in our daily practice, but it can also make a difference to the main diagnostic, treatment, and prognostic implications in the patient. So I have chosen this topic as a case report. So a few words on the abstract. The tubular adenomas of breast. The title of my presentation is a tubular adenoma of breast, which was missed on cytology, but we got it on our histopathology gold standard and its study of literature. Yes, moving back to the abstract. The tubular adenomas are pure benign epithelial tumors of the breast, as we all know, along with fibroadenomas. So here we report a case of a 18-year-old female who has reported to the Department of Surgery with 1 month history of bilateral breast lumps. When this patient was referred to our Department of Pathology for fine needle aspiration procedure, the smears had shown a picture of bilateral fibroadenoma. The ultrasound findings also were consistent with fibroadenoma picture. Whereas the excision of this bilateral breast lumps had histologic findings which were concordant with tubular adenoma with a bilateral fibroadenoma. So starting with the introduction of the case report, an 18-year-old female was reported to the Department of Surgery with 1 month history of bilateral breast lumps. When this patient was referred to our Department of Pathology, the physical examination of the right breast lump was a well-defined, mobile, a non-tender lump with no skin and with no skin changes and nipple discharge, located in the upper outer quadrant, measuring 6 by 4 centimeter. Whereas the contralateral breast, that is, the left breast, had a lump which showed features similar like in the right breast, that is, a well-defined, mobile, non-tender lump was also seen in this breast, but located in the upper inner quadrant, measuring 2 by 1 centimeter. A fine needle aspiration had yielded a diagnosis of bilateral fibroadenoma, which was later followed by surgical excision of these breast lumps. So to our surprise, we were taken aback when we had seen some of the lesion hidden there. That is, the histopathology report had concluded a tubular adenoma of the breast with intracanalicular fibroadenoma in the right breast and a fibroadenoma in the left breast. her post-operative course was uneventful. So here comes the sonographic appearance as the slide that is put in display in front of all of you. This sonographic appearance of the fibroadenoma, which is showing a ovoid smooth muscle mass with a narrow antero-posterior diameter than its transverse diameter. As pathologists, we should also be knowing how to give importance to the clues that are given on the radiographic examination, because along with the clinical details, the radiographic examination findings can also bring our way closer to the diagnosis of what we can give on histopathology. So moving on to the cytologic details. The cytology, the fine needle aspirate smears were moderately cellular, composed of cohesive clumps of bland appearing ductal epithelial cells with bare nuclei and occasional stromal fragments in the background, which was given as fibroadenoma of bilateral breast lumps. So the figure shown is in this, as you can see, the figure 2, which is showing the high power view of the FNAC smear fine needle aspirate, showing a tubule composed of epithelial balls in the naked nuclei background. But this tubule configuration was only seen as a retrospective when we looked back into the slides, but we had initially given this as fibroadenoma. So on macroscopy, that is on gross, we received 2 soft tissue masses, and the larger soft tissue mass was solid, homogeneous, whitish appearing mass with smooth surface appearing, measuring approximately 6.5 by 4 by 2 centimeter, that is seen in this figure. This is the gross image of the larger lump what we had got. And now moving back to the smaller soft tissue mass, the soft tissue mass, the other soft tissue mass was showing similar features like in the large mass and measuring 2 by 1 centimeter. And when we had seen the microscopy of these nodules, we had seen that the larger nodular mass did show features of tubular adenoma in the larger nodule and features of intracanaliccular fibroadenoma in the adjacent breast tissue of the same nodule. And whereas the smaller nodular mass revealed a fibroadenoma picture. So as I have discussed, this is the gross photograph of the larger lump, which was quite big, smooth surface, and gray-white also to be seen, and solid and fleshy. And in this figure, we can see a fine needle aspirate cytological smear with the few bare nuclei in the background. There were no stromal fragments in this, but there were this tubular configuration arrangement of the epithelial cells. And the subsequent figure, that is figure number 3, shows a low power view of hematoxylin and eosin stained image, which shows a intracanaliccular fibroadenoma and a tubular adenoma. Like we can see in this picture, I have magnified it. The intracanaliccular component of the fibroadenoma is enclosing the tubular adenoma component. And this is the higher power of the hematoxylin eosin stained image, which shows a uniformly packed tubules, which are lined by a single layer of epithelial cells with attenuation of the myoepithelial cells. So moving on to the discussion part of this entity, clinically painless, they are well circumscribed lesions which are freely mobile are usually considered as fibroadenomas. That is lumpy, bumpy breasts. So this is usually fibroadenomas like what we all know. So breast adenomas has a classification. They are divided into true adenomas, nipple adenomas, and fibroadenomas according to Hertel et al. The true adenomas are again divided into tubular, lactating, apocrine, ductal, and pleomorphic adenomas. So, the tubular adenoma and fibroadenoma of the breast together comprises only 4% of the benign breast lesions and 11% of the breast adenomas. According to Majorano and Albrizio's study, tubular adenoma and fibroadenoma are histologically related with a predominant stromal tissue in the fibroadenoma, whereas ductular proliferation seen in tubular adenoma. According to Orell, cytologic smears include uniform tubules arranged in three-dimensional epithelial balls in a background of naked nuclei, but no stromal fragments. So whatever the salient features, the positive features are looked upon, it is equally important to look at the negative findings as well to rule out differentials. A giant tubular adenoma of the breast was reported in a patient with Maffucci's syndrome in one of the articles. So what is Maffucci syndrome? I would like to just talk a few words on Maffucci syndrome. Maffucci syndrome, let me remind you. Maffucci syndrome is seen associated with giant tubular adenomas of breast. They are congenital, non-hereditary, mesodermal dysplasias with multiple enchondromas and vascular lesions. So, here are a few additional pointers as to how we can name any lesion as a tubular adenoma and when to call it as a fibroadenoma. Tubular adenoma, a few historic points. Tubular adenoma was first described in 1968. Different workers reported that 90% of patients with tubular adenoma was seen usually in reproductive age group of women. Even pregnant women had shown this tubular adenoma growth. So usually it is seen below 40 years. The size range of tubular adenomas varies anywhere between 1 to 7.5 centimeters. Clinically, these tumors are painless, freely mobile, circumscribed lesions which resemble fibroadenoma, thus making preoperative diagnosis very difficult because in the most of these cases, the clinical findings and imaging features resemble a fibroadenoma. Few researchers proposed that the pattern of dense punctuate or irregular microcalcifications without cast-like or branching forms that are tightly grouped within mass. Few of the pointers indicate this as tubular adenoma finding on fibroadenoma. Majority of these lesions in young patients, they simulate a fibroadenoma without any diagnostic calcification. Therefore, tubular adenoma cannot be differentiated from other benign breast diseases on radiologic examination. Tavasoli et al. Called a nodule as tubular adenoma only if 1 centimeter in size or if it was smaller and encapsulated. Domato et al. Reported a case of synchronous recurrence of tubular adenoma with a component of ductal invasive breast cancer. So it is very important to even find the lesion masked by the predominant component because it can have a focus of the invasive component, which can be dangerous for the patient perspective. Moving on to the microscopic images. Here we see, these are the images of the tubular adenoma, which have tubular shaped glands, usually they are uniform, with a sparse intervening stroma. On immunohistochemistry, IHC, the P63 focal positivity, P63 and calponin are usually the markers for myoepithelial cells. So the P63 and the calponin, that is the images seen in C and D labeled here, they are stained positive. This indicates a tubular adenoma, that is attenuated myoepithelial cells stain P63 and calponin positive, and the epithelial component is also there. So tubular and adenoma has few differentials which can cross our minds at the time of diagnosis. First entity is sclerosing adenosis. Now, what is sclerosing adenosis? It has proliferating tubules which are usually lined by two cell types that are elongated and also may acquire spindle-shaped myoid features. On immunohistochemistry, IHC, these come out to be P63, smooth muscle actin, and calponin positive. Presence of the basement membrane around these tubules, type 4 collagen is usually seen deposited as a basement membrane. These can be stained with per-acidic that is PAS stains, per-acidic Schiff positive stains can come out positive on this to show us the type 4 collagen. The next entity that can come as a worrisome differential, that can be microglandular adenosis. Microglandular adenosis also shows small uniform glands with open lumina containing some eosinophilic secretions like what is there inside this photograph. So these have a irregular fashion of distribution within the fibrous tissue. The myoepithelial layer is usually absent for microglandular adenosis, ruling out the tubular adenoma. Only benign, the microglandular adenosis is the only benign epithelial breast lesion which is devoid of myoepithelial cells. Now moving on to the immunohistochemistry panel of microglandular adenosis. Here we see that there is a pancytokeratin positive around the tubules, that is the epithelial cell component being positive. And the second image in this slide showing the smooth muscle actin negativity around the tubules. So that shows that there indicates that myoepithelial cells being absent. So this differential gets ruled out. So I would like to conclude that the clinical features and imaging studies of tubular adenoma, they resemble fibroadenoma, thus making preoperative diagnosis for the clinician, that is the surgeon, and for the pathologist to make this lesion tough. To avoid it, surgical excision plays an important role in making the right diagnosis of this benign epithelial lesion. Through this case report, it is clearly implied that diagnosis made on fine needle aspiration is only a tentative one, and it has to be supported and validated by a gold standard histopathological examination. So these are my references, as we can see in the last slide. And thank you so much. I'm open to any questions concerning my topic.
Well, thank you, Dr. Neetu, for an outstanding presentation from your side. As we all know that it is quite common in our usual practice to miss certain cases on cytology, especially when there is a lot of cytomorphology overlap, but they can be reliably caught on histopathology examination and then uh, tallying them with the
With gold
IHC,
standard.
IHC markers. And today, Dr. Neetu had contributed through her presentation about one of such a case, that is tubular adenoma. And she had spoken really well about the tubular adenoma in detail, and she has also discussed wonderfully through her beautiful H&D pictures and distinct IHC slides where we were able to appreciate the IHC staining as well. And she has also enlightened us about the differentials for the tubular adenoma. That was really nice. And finally, thank you, Dr. Neetu, for making your presentation really interesting. It was pleasure to have you on this platform for all of us and sharing your knowledge on this platform. Thank you once again, Dr. Neetu. Well, now the platform is open for the other participants and the other speakers who wants to give any suggestions or any questions or any advices for Dr. Neetu. Well, I hope that as of now, there are no questions for Dr. Neetu. So shall we go ahead with the next participant in our conference? So that is going to be Dr. Akansha Singh from India. So I hope that Dr. Akansha is ready with her presentation.
Yes, ma'am, I'm ready with my presentation. Good morning to
Well,
all of you.
Kindly go ahead. Yes, you're audible and clear.
Yes, I'm sharing
Thank
my
you.
screen. Is it visible to everyone?
Yes, yes.
Yes. Thank you and welcome to all of you in the 5th Emirates Pathology Conference. I'm Dr. Akansha Singh from King George's Medical University, Lucknow, India. I am presenting a case report on the topic Cribriform morula variant of papillary carcinoma in an old treated case of medulloblastoma, a rare and distinctive case. An 18-year-old female presented with painless swelling in the anterior aspect of neck, which was increasing in size for the past 1 year. There was no history of fever or weight loss or loss of appetite, and there was no any significant family history. Patient was diagnosed as a case of medulloblastoma in 2010 and underwent treatment for the same till 2013. She has received multiple cycles of chemotherapy and radiotherapy as treatment. She underwent routine blood and biochemical investigations, FNAC of the anterior neck swelling, and CCT of face and neck and upper thoracic region. All the blood tests were within normal limits, except serum thyroid levels, as they were deranged. You can see all the three serum free T3, free T4, and serum TSH levels all are deranged. In the CCT, thyroid gland was found to be bulky. Multiple well-defined nodular lesions were studied throughout the thyroid parenchyma, with largest measuring 23 into 22 into 18 mm, left lobe measuring 32 into 32, and isthmus measures 24 into 20 into 17 mm. The thyroid capsule was well intact and no extrathyroidal extension was found, and there was no any significant tracheal compression was noted. And there was also no significant cervical and mediastinal lymphadenopathy. Patient was diagnosed as case of papillary thyroid carcinoma, Bethesda category 6 on FNAC. Then the patient got operated and underwent total thyroidectomy with bilateral cervical neck dissection, and the specimen was sent to department to our department of pathology. We received a total thyroidectomy specimen weighing 25.3 grams, comprising of right lobe measuring 3.5 into 2 into 1.5 centimeters, isthmus measuring 2 into 1 centimeter, and left lobe measuring 4.5 into 3 into 2 centimeters. The outer surface of the specimen was encapsulated, bossylated with areas of congestion, and grossly no extracapsular and extrathyroidal extension was noted. The cut surface of the right lobe, left lobe, and isthmus showed grayish-white solid growth involving whole of the parenchyma of both lobes as well as the isthmus. The cut surface of this growth shows numerous papillary excrescences. Parathyroid glands were also identified, measuring 0.8 into 0.7 into 0.6 at the lower end of the right lobe. Now coming to the microscopy, This was the low power image. In this image, you can see at the bottom of the right side, there's the normal thyroid tissue, while in left side, all the parenchyma is covered with the, is replaced by the thyroid, all the tumor cells. This is the high power view in which you can see the cribriform pattern. This is a more enhanced view. You can easily see the individual nuclear morphology. In PTC, in conventional PTC, you will see nuclear overlapping, nuclear elongation, and nuclear grooving with orphan NEI nuclei. But in this case, CMV PTC, you will not find the typical nuclear features what we usually find in normal conventional PTC. Now coming to the immunohistochemistry, what we applied in our case, it was EMA and CK19 thyroglobulin synaptophysin. We applied EMA so as to rule out the epithelial malignancy. CK19 is helpful in ruling out whether it's a follicular variant of PTC versus follicular adenoma. Then for determining the any thyroid tissue, it's thyroglobulin is used, and for differentiating it with neuroendocrine tumors, we use synaptophysin. All the markers came out to be negative, and we also applied Ki67 in the hotspot areas. It was about 50 to 55%. Now, as total thyroidectomy was done, the tumor focality was unifocal, with involving all the left lobe, right lobe, as well as thymus, which measuring or total tumor size was 6.5 units 3 into 2 centimeters. The final diagnosis was made as papillary carcinoma thyroid, cribriform mural variant, with there is no extrathyroid extension and only one lymph node was identified with no regional any metastasis. The pathological stage that we gave was PT3A and no MX. T3A means the tumor size is more than 4 centimeters, limited to the thyroid only. So the final diagnosis was made on histomorphology, and it was consistent with papillary thyroid carcinoma, cribriform morella variant without extrathyroid extension, and parathyroidedema was also identified. Now I'd like to say a few words about papillary carcinoma thyroid. As it is, thyroid carcinoma comprises of approximately 1% of all cancers and accounts for about 0.2% of cancer deaths. Most of the carcinomas are of papillary type. It can occur at any age and mostly diagnosed in the 5th and 3rd decade. Women are more affected than men in the ratio 2:1 to 4:1. Now the etiological factors. These are the various etiological factors. Iodine plays a very important role, as you can see in India, in iodine deficient areas, as it is iodine, few areas are iodine deficient, we will see most of the tumors are of follicular type. But in the iodine sufficient or iodine excess areas, like in South America, you can see it most common carcinoma is papillary carcinoma. Now the external radiation also plays important role. Some autoimmune disease like Graves' disease is also responsible. Then hormonal and reproductive, females are more prone than males for having papillary carcinoma thyroid. Some genetic syndromes are involved like APC, then HNPCC Cowden syndromes, and follicular adenoma and parathyroidenoma are also responsible, because we have seen that when they were earlier already in a patient is already thyroid or adenoma is present, it can later on convert into PTC also, if not treated on time. Now I would like to discuss a few words about CMV PTC. As the name indicates, this variant is characterized by the presence of cribriform pattern of growth and the morular formations. It develops in a sporadic form or an extrathyroidal intestinal component of the familial adenomatous polyposis syndrome, of which it may be the initial clinical manifestation. It is seen almost exclusively in female, present as multifocal tumors with a cribriform solid or spindle cell growth pattern. This rare variant of PTC can occur in 1 to 2% of patients with familial adenomatous polyposis. All cases show APC germline mutation, and some all cases also show RET or PTC activation. This cribriform morular variant papillary carcinoma are often encapsulated with an intimate admixture of cribriform, follicular, papillary, trabecular, and solid pattern of growth. Round squamoid molar structures are a characteristic finding. Intraluminal colloid is scanty or absent altogether, with invasion of the tumor capsule or a vessel is common. Sporadic cases are usually solitary, while those associated with familial adenomatous polyposis often multifocal. The neoplastic cell nuclei are not particularly clear but exhibit variable amount of grooves and cedar inclusions in the morules. However, neoplastic cells have optically clear nuclei. Thyroglobulin is often weakly expressed and TTF1 is variable positive within the tumor. Nuclear immunoreactivity for beta-catenin, the hallmark of WNT pathway, activation is the rule. WNT signaling is activated in the familial tumors because of the germline loss of function mutations of APC gene, and in the sporadic ones because of the somatic APC mutations or due to somatic mutations in the exon 3 of the beta-catenin gene that stabilizes the beta-catenin protein, preventing its degradation and promoting its accumulation in the nucleus. Now I would like to share a few words about medulloblastoma. Medulloblastoma is the most common CNS embryonal tumor of childhood and second only to pilocytic astrocytoma of all intracranial neoplasms. Surgical excision combined with radiochemotherapy is the treatment therapy. Irradiation is a well-known risk factor for development of the benign and malignant thyroid tumors. Children are more exposed due to increased sensitivity of the thyroid gland to the carcinogenic effect of ionizing radiations. So, at last, in the conclusion, the thyroid gland is highly sensitive to the harmful effects of ionizing radiations. Hypothyroidism is the most frequent dysfunction, followed by Graves' disease, secondary ophthalmopathy, and autoimmune thyroiditis. To conclude, patients with CMV-PTC have a distinct clinical, pathological, and molecular profiles when compared to conventional papillary thyroid carcinoma. These are my references, and special thanks to my respected faculty, Dr. Chanchal Rana ma'am and Professor Suresh Babu sir. Thank you, everyone.
Thank you, Dr. Akanksha, for presenting such a rare, distinctive case of cribriform modular variant of papillary carcinoma thyroid in a known case of medulloblastoma. And I can say that, well, I have not yet come across this variant in my practice till now. So it was really interesting for me and hopefully for all the participants as well, because this is quite a rare case which you have presented today. So thank you for that. And you have also enlightened us about this variant in detail, along with H&D pictures, as well as the different appropriate IHC markers for this variant to confirm it. And it was a pleasure to listen to you today, your speech through the today's topic of yours. And we truly appreciate your participation in this digital conference. Once again, thank you, Dr. Akanksha.
Thank you, ma'am.
Well, now the platform is open for any questions for Dr. Akanksha, any suggestions? Well, I don't see any questions coming up for you, Dr. Akanksha.
Okay, ma'am.
Well, once again, thank you, Dr. Akanksha. So let's move on ahead with our morning session speakers. And for our next speaker is going to be Malyugin Nikita from Russia.
Yes, do you hear me well?
Well, good morning, Dr. Nikita.
Good morning. Is I hearing well?
Yes. Can you please share your screen in full screen? Yes, you're audible and clear as well.
Okay, now we can start.
Yeah, thank you. Please go ahead.
Thanks. Hello, my name is Malugin Nikita. I am the 5th year student of Pirogov Russian National Research University in Moscow. And today I will talk about the concept of a digital medical museum. First of all, I would like to talk about my team. Here's Ekaterina Tanka and Nikita Strela. They're 6-year students of the Faculty of Medicine and Biophysics, and active participant of the Students' Scientific Society of Medical Cybernetics. Kush Daria, a 6-year student of Pediatric Facility, Deputy Head of the Student Society Scientific of Pathological Anatomy, and me, Malugin Nikita, I am the Head of Student Scientific Society of Pathological Anatomy in my university. And our scientific director of the project is Dmitry Zhakota. He is associative professor of Department of Pathological Anatomy in our university. Daria and I selected materials and scan objects, and Nikita Strela and Ekaterina Tanka support the technical part, develop a website, and optimize the medical images for integration into the project. Demonstration materials are especially important in studying of medicine. Traditional demo is limited by number of students and the viewing time. It becomes problematic to use the existing gross archives and equipment for teaching students because of the difficulties in replacement them in case of damage or loss. Also, due to the epidemiological situation, more and more students begin to study remotely. We want to create interactive content to expand didactic opportunities and increase the accessibility of education materials for students. The optimal solution to the problem is the packages of education and didactic materials. We also want to preserve the historical heritage. Many of the museum pieces were made over 100 years ago. According to the Russian legalization, now it's problematic to use tissues and organs for preparation of the samples. As object for digitization were used gross and histological archives. Subject photography technology was chosen to obtain digital copies of gross pathology. To digitize histological slides, a 3D stack panoramic MIDI histological scanner and motorized microscope were used. VSI allows to scan of entire glass slide with an output of an image file that is digitized reproduction of the glass slide. It's especially important for education. We can create unified education courses for different groups of students. For modern slide, we use automatic digital slide scanner. Today, stack panoramic media. Older slides are slightly thicker. Most of the slides made in the last century are over 1.25 millimeter thick and are not suitable for modern scanner. For such archival specimens, it's easier to use motorized microscope. For subject shooting, we use the camera with a tripod, uniformly rotating motorized stand, 3 light sources, and a light box. The technology consists in making serial photographs of the preparation, which rotates eventually on the stand. Then images are made in special software. Toshiba Accelerate Vintage Atlas and Toshiba Aquilion Prime were used to obtain CT and MRI images. Now I would like to demonstrate our test build. You can use the QR code to view it for your own. So the main page presents cases sorted by nosology. Also, on the left side, there is a search, categories, and labels for easy navigation. For example, consider the case of pulmonary tuberculosis. First, the theoretical part arises, in which the main definitions and the short summary of the lesson are indicated. Next comes gross sample. It can be viewed by details by rotating around its axis and zooming in on area of interest. Next comes the interactive MRI. It shows different levels of macro slides, we discussed it earlier. We plan to add pictures of clinical cases to this section for compare with amusing specimens. This will significantly increase the didactic value of the resource. Finally, moving to the virtual slide made in using WSI technology, it's possible to create annotation and given task. To answer, you need to take a square market. Yep. To answer, you need to take a square market and highlight the area that is being asked in the question. If it's a test question, provide then select the one you need from the list. This system can be integrated into electronic lesson journal. Below the tags that allow you to immediately go to the related content on the selection pathology or body area. We believe that such technology will help solve the problem of preserving rare museum specimens and will provide students at all medical universities with access to visual aids and didactic materials. This will improve the quality of education in a distance format. And thanks for your attention.
Well, thank you, Dr. Nikita. Thank you, Dr. Nikita, for sharing your objectives to expand the availability of educational material and creating resources for distance education and digitization. Thank you for putting your insights into the topic, which most of us are unaware of. And it was really a good experience to go through the virtual pathology museum through your presentation. Thank you. Thank you, Dr. Nikita.
Thank you.
Yeah. So are there any questions for Dr. Nikita or any clarifications which any of the participants want to have?
Yes, please. If he has a moment, I wouldn't mind asking a question.
Well, please go ahead, Dr. Kelly.
Hi, yes, we are just about to embark on a change to a digital pathology platform in my trust here in the UK, and I wondered whether you scanned your slides at ×20 or ×40 magnification, or if you had particular specimen types that you perhaps scanned at higher magnifications.
We scan all slides at 20.
All at 20?
Yep.
And do you handle lymphoma or anything like that that's a bit more, some people would argue, for ×40?
Can you please repeat the question?
Do you handle lymphoma cases? I know in some parts of the world they would suggest ×40 magnification for lymphoma.
All slides are for students, and this is more about education, and it's like the basic pathology.
Right, so you wouldn't have lymphomas amongst that case set that you're scanning then? Sorry, would your cases include lymphoma or lymph nodes, even benign ones?
Not yet.
No. Okay, that's fine. Thank you. That's very helpful.
Thank you.
Thank you, Dr. Nikita, for clarifying Dr. Kelly's doubt. Well, are there any other questions from any of the participants or speakers?
Oh, yes, I have a couple of questions.
All right.
Nikita,
Yes,
Dr. Nikita, thank you for this impressive presentation. Well, I would like to know more about the compatibility of your technology, and I explain you the reason why I'm asking. During the last year and the year before, I built a very large cytology atlas with about 500 cases. And we planned this atlas as an open project. And what we are doing right now, we are bargaining with some companies about publishing. And this is a very tough business. and because they require huge money sums to publish this and make it open access. And so my basic question is this compatible with images, for example, that have already been scanned at that high magnification? And could you imagine joining a project where you handle about 500, 800, or 1,000 images at high resolution?
Now we're doing this project on the base now of our university, and we have some supplies from it. And we want to scan all slides from our own. We don't want to use the slide from another destination, and we want to firstly we want to do it for our university, like educational program firstly, but then we will try to do it for another research area.
We've got the same intention, of course. However, one basic motive of global pathology is, of course, sharing of cases. So, but to cut a long story short, I'm quite open-minded about that, and I will be happy that you publish your contact data, because maybe we can talk in detail about that, because I find this very interesting. And we all see that digital pathology is an emerging point in our pathology culture. And therefore, I think it's very useful to cooperate in open access publishing, because what we do not want is to pay for our own work to be published. We want to share this knowledge so everybody can be a part of it. So I would be very happy if your contact data would be available.
Okay, I will send you my contact. Thank you very much.
Thank you, Dr. Nikita, for clearing Dr. Andreas' doubt. And Dr. Andreas will be receiving the details of Dr. Nikita through his email. And it is really fascinating for us to know that the field of pathology has taken a lot of advanced technology, the digitization, and a lot of recent advances are taking place. And through this conference, it's really enlightening for us to know the recent advances in the field of pathology. Thank you, Dr. Nikita.
Dr. Archana, can I just ask a question?
If you don't mind? Go ahead, Dr. Sophia.
Yeah, thank you so much. I would just like to know what imaging software and whole slide imaging platform is Dr. Andreas and Dr. Kelly using, because we have just started whole slide imaging at our private center. And while we scan all the slides at 20x, we do scan small round cell tumors and lymphomas with immunohistochemistry at 40x. However, we are facing a lot of challenges regarding storage of data and its prompt retrieval. And I wanted to know if the systems that they were using encompassed or helped more efficient storage of data. Because as we know, each individual digital slide is a lot of memory. So could they provide some insights into that?
Thank you, Dr. Sophia, for posting your question. So I hope that Dr. Nikita and Dr. Andreas are available to answer Dr. Sophia's question, please.
Yes, of course. You might remember the slides you've seen at my presentation yesterday. And to provide this slide, we used the EasyZoom platform. And we scanned it with our Aperio scanner, which we have in our department. I do have to check the details, because usually I'm just using this platform. but I do not know the details of storage. Of course, as you rightly said, storage might be a problem with a high volume of data. But right now I can tell you the software I used was the Easy Zoom software, and the scanning was done by the Aspiration scanner.
Okay. We are also using Aspiration scanner, but I think we would like to also look into the Easy Zoom software as well, because it looks very effective and very presentable, as seen in your presentation. Mr. Nikita, any thoughts on storage of data? Because if you digitize the entire system, it is obviously going to create quite a huge virtual database, considering the fact that pathology has so many specimens. What would you suggest?
Now we're using our university server for handling all the slides. But I don't know what we will do if we will have more than 5,000 slides like this.
Sorry. Yeah, can I just add? We were quite fortunate in that we had our digital platform built specifically. So it was Roche, obviously the Swiss company, who we currently work with our immuno platforms as well, and then the company Sectra, who look after our radiologists, and their reporting platform have designed a Sectra Plus. So it's become an integrated system now that we can have all of our patients' imaging, both pathology, gross and micro, as well as their radiology, all on one system. So that's we've been very fortunate to have this purpose-built setup.
Thank you, Dr. Kelly.
All right. So, well, thank you for the inputs provided by Dr. Nikita, Dr. Andreas, Dr. Sophia, and also Dr. Kelly. And are there any more questions or clarifications or any inputs which other speakers want to share? All right. So shall we move on ahead with our next presenter for today in the morning session? And it is Dr. Sophia Marilyn George from Malaysia. And she would be presenting on the topic stromal osseous metaplasia in recurrent urothelial carcinomas forming an ossified pelvic mass, a report of an unusual case. I hope that Dr. Sophia is ready with her presentation.
Yes.
Well, thank you, Dr. Sophia. You're clear in your presentation and you're audible as well.
Thank you. Dr. Archana, okay, I would just like to give a warm welcome to everyone attending the morning session, and thank you to the EPUCJ for giving me this opportunity to present this case, which is very rare for me. I will be talking about a rare case of recurrent carcinoma presenting as an ossified mass. I would like to thank my co-contributors in this, Dr. P.M. Tanikuchalam, Dr. Leong Menlong from Penang, who gave us this very interesting case, and Dr. Rina Rahayu Mohammed Zin from PPUKM Malaysia. I would first like to take everybody on a virtual tour of Malaysia, because I think with the current climate, everybody's travel plans have been a bit scuttled. Malaysia is this beautiful country which is located near the tropics. We do not have anything close to a winter, but we do have some wonderful biodiversity and nature here. From the peaks of Mount Kinabalu to the tea gardens of Cameron Highlands, and a wide variety of endemic species, including the Rafflesia flower and the proboscis monkey. I'm sure that if anyone comes here, it would be a visual feast for their eyes to experience this wonderful multi-ethnic and biodiverse country. I'm proud to represent my laboratory, Clinipath Pathology, which is one of the premier pathologies private laboratories in Malaysia, in the capital city of Kuala Lumpur. We deal with an average of 20,000 histopathology specimens every year. And we were the first laboratory in public as well as private sector to start digital pathology with whole slide imaging using the Aspiration software, the Aspiration platform. And while it has been a wonderful journey, we are, of course, looking forward to further more information and knowledge regarding this platform. I would also like to thank my contributors at UKM, University Kebangsaan Malaysia. This university was started in 1972. It is the National University of Malaysia, specially established for the promotion of postgraduate and specialist studies and ranked 35 in Asia. It is my great honor to be associated with my peers and mentors from UKM. Thank you. I would like to start to talk about this topic where we come across tumors which have a different or divergent differentiation. And while they are commonly seen in some other subtypes of tumors, in urothelial tumors, they are extremely rare. So to come across a urothelial tumor with cartilaginous and osseous transformation is in itself not a common entity. This component can either be malignant or it can be benign. Now, if it is malignant, it commonly occurs as a mixed epithelial and mesenchymal tumor with sarcomatous transformation. We sometimes call it a sarcomatoid carcinoma, and rarely they may have pure mesenchymal differentiation as well. The latter, where the osseous and the cartilaginous component is benign, has been given this terminology called as stromal osseous metaplasia, or SOM, which is associated with the malignant epithelial component, but the stromal component is completely benign. This is rare. A literature search found about 13 cases occurring in primary urothelial tumors and 7 in metastatic tumors. To add to this list, I would like to present an additional case of a recurrent urothelial carcinoma with an unusual presentation. I would like to highlight at the outset that the complex features of this case were compounded by the fact that this patient had visited about 3 or 4 different centers and had different biopsies done at different centers. Therefore, for us to actually get a comprehensive view of her histopathology and her clinical picture was very challenging. We only received the initial history as patient is a known case of tumor and has presented with abdominal pain and heaviness for 5 months. On receiving the specimen, we realized it had a reniform shape but looked nothing like a kidney. Then on digging further, we tried to trace back her previous reports and her history, and we found that she was a known case of urothelial carcinoma of the renal pelvis. She had undergone a nephrectomy with a bladder cuff excision in the year of 2016 and was treated with chemotherapy and radiotherapy regimens at another center. When the CT scan was performed by the radiologist, he noted that there was a lobulated, heterogeneously enhancing mass in the right renal bed and upper abdominal pelvis, which was quite large, about 8.9 centimeters by 9.8 centimeters by 11 centimeters. This mass, in addition to forming a large space-occupying lesion, also involved the adjacent right psoas and quadratus lumborum muscles with destruction of the right transverse process and the L5 vertebral pedicle. There were smaller, tiny nodules which were noted in the left lobe of the liver and in the basis of the right and left lungs, which he considered as compatible with metastasis, considering her previous history of urothelial carcinoma. So she presented, and the surgeon decided to go ahead to do an explorative laparotomy and remove this mass. On tracing her previous reports, we found a report of a biopsy of the upper calyx of the renal pelvis, which was performed in early 2016, which was diagnosed as grade 2 transitional urothelial cell carcinoma, followed by the surgery, which was a right nephroureterectomy. This specimen was an R0 resection and showed a grade 2 transitional cell carcinoma with widespread invasion of the lamina propria of the renal pelvis. Foci infiltrated the muscularis propria of the pelvis, the peripelvic adipose tissue, and the renal medulla. Foci of lymphovascular invasion were noted in the specimen. However, lymph nodes were not submitted. The tumor deposits did not breach the capsule of the kidney and did not extend into the perinephric fat. The predominant pattern of the tumor was in solid sheets and nests with an occasional configuration of papillae. Foci of necrosis were noted along with scattered mitotic figures. It was considered as a stage 3 tumor with an R0 resection as per the previous histopathological report. Following that, the patient received chemotherapy and radiotherapy and was kept on regular follow-up. When she presented in early 2020 with the mass, we were quite perplexed to see this huge space-occupying mass, which was completely bony. It just looked like a mass of bone. It had a lot of tags of fat tissue which were there at the periphery, and it I would like to show that there were a few areas of hemorrhage, a few cystic areas which were noted, but predominantly it was this dense mass of calcified bone, which was extremely difficult to cut. So it weighed 506 grams. The fat was plastered over the exterior surface, and it looked exactly almost like the shape of a kidney. It was very reniform. The total measurement was 132 by 98 by 72 millimeters, and cut section showed a completely ossified bony mass with no grossly visible soft areas. The initial sections taken were a complete transection of one cut surface, and they revealed predominantly mature trabecular bone separated by benign, loosely arranged filamentous edematous connective tissue and adipocytes. All the sections, about 14 sections, showed the same picture. When we looked at the mature trabecular bone and the higher power, they showed benign osteoblasts which rimmed the trabeculae with a few osteoclasts noted at the periphery. There was no evidence of neoplastic osteoid, no evidence of a filiform osteoid, which was noted, and all the lacunae contained benign osteocytes. No cartilaginous component was noted on the initial sections. In addition to this, the intervening stroma showed a patchy foci of necrosis, a few abundant chronic inflammatory cells, and admixed foamy macrophages with foreign body giant cells and cholesterol clefts. I would like to show the low power view, which showed extensive areas of these benign bony trabeculae, which were separated by this edematous, very loose stroma and patchy foci of inflammation. The peripheral adipose tissue, which was plastered to the surface of the tumor, did not appear to be infiltrated. Now, as we go further, extensive ossified bony trabeculae with a few cholesterol clefts in between and scattered inflammatory cells. Now, I'm sure if we saw this focus in a post-chemotherapy specimen, we would be thinking that definitely there must be a residual tumor lurking somewhere. As soon as we saw these areas, we decided to sample more and more sections, and thankfully, we managed to find scattered, isolated clusters of malignant epithelial cells noted amidst the bone. Now, these cells were polygonal to round with moderate eosinophilic cytoplasm, fairly pleomorphic nuclei with irregular nuclear membranes and coarse nuclear chromatin with mitosis. Occasional atypical mitosis were also identified. Now, a few cells also showed a vacuolated and degenerated appearance. No glandular or squamoid features were seen. The stromal component was examined very carefully to look for areas of sarcomatous change. However, we could not find any sarcomatous change in the sections sampled. I would like to show the high power view of these areas, which shows these clusters of tumor cells, which with no distinctive pattern, no glandular or squamoid appearance, and fairly pleomorphic nuclei with coarse chromatin, occasional mitosis, which was scattered within the cells, and a lot of edema and extravasated RBCs in the adjacent tissue. Several foamy macrophages noted in between. Another area lurking in between this benign stromal tissue, which highlighted a similar island of tumor cells. It took an extensive search to find these epithelial islands, but they confirmed our diagnosis. We finally diagnosed it as a high-grade urothelial carcinoma occurring in a post-nephrectomy patient with extensive stromal osseous metaplasia. And we started looking for literature to find if these cases have been commonly reported. It was found that these cases are exclusively reported in urinary bladder tumors and metastasis from the urinary bladder. The first reported bladder tumor with a similar cartilaginous trauma was as early as 1856 by Ordonez. This was followed by quite an extensive series of cases studied by Lilian Esipan, who subdivided the urothelial tumors with the stromal components into those tumors who had sarcomatous stroma with overt features of mitosis, pleomorphism, and mitotic and atypia, and those tumors where the component was totally benign, which was considered to be due to metaplasia. Now, this subset of tumors are rare, with about 13 cases reported in primary tumors and 7 in metastatic tumors. All cases have been reported mostly in the urinary bladder. In our institute, this was the first time that we were coming across this pattern, and we were quite curious as to find out its etiopathogenesis and whether we could see it in other types of tumors. The literature search shows that the mean age range is 65 years, range of 3 to 85 years with a male predominance. Our case was a female who was 63 years old. Here, I would like to talk about some of the cases which have been reported, which are very interesting. The youngest case is in a 3-year-old boy. This child presented with hematuria and on a cystoscopic examination was found to have a high-grade papillary urothelial carcinoma, which by itself is extremely rare in this age group. On sampling, there was a central nidus of osseous bone which was noted within this tumor. Another point which was noted in the literature search was that several cases were associated with prior procedures. For example, if it is in the urinary bladder, they were associated with past history of cauterization. There was one case which occurred in a case of prostatic adenocarcinoma with a bladder tumor. The prostatic tumor was treated with leuprorelin. A few cases, including the cases reported by S.E. Pang, post-cystectomy, post-TURP, and chemotherapy and radiotherapy. Now, I would like to highlight this seminal article, which is written on bony and cartilaginous tumors of the urinary bladder, which has an extensive description of urinary bladder tumors in adults, which contain either bone or cartilage. And a few very interesting hypotheses have been put forth regarding their etiopathogenesis, which I shall deal with later. Embryonal tumors or mixed tumors, teratomas, were not considered as they were clearly unrelated to the tumors under discussion. Another article which talks about these tumors was by Robert Young and John N. Abel, which talked about unusual forms of carcinoma of the urinary bladder. This article deals with diverse microscopic appearances of all bladder carcinomas and talks about less common but most troublesome diagnostically are variants in which the cells are spindle-shaped or sarcomatoid, form small cysts, or differentiate towards trophoblasts. In other variants, the stroma has unusual features that may lead to diagnostic difficulty. These are carcinomas with pseudosarcomatous stroma, osseous or cartilaginous metaplasia, or osteoclastic type giant cells. I have not dealt in detail with the primary bladder carcinomas, as I find our case fitted more with the metastatic tumors. I would just like to show this table, which shows the vast variety of locations and types of metastasis in SOM. Now, for example, the first case, which was reported by Cons, JS, and all, the metastatic deposit was in the abdominal wall, which occurred 4 years after a history of bladder carcinoma. This patient had a predominantly well-differentiated papillary urothelial carcinoma with stromal osseous metaplasia. The second case developed metastasis in the supraclavicular region, the left tibia and left femur, 2 years after radiotherapy and cystectomy for bladder carcinoma. Now, this is interesting because the sight of a bone, a long bone, can definitely give rise to a diagnostic confusion or difficulty, especially in the presence of these characteristic histological features. This was diagnosed as a metastatic papillary urothelial carcinoma with stromal osseous metaplasia. The third case, again in the bone, 14 months after the primary in the bladder. The fourth case in the left tibia. The fifth case, right femur, bilateral tibiae. The sixth was a nodal metastasis. And what was interesting about this case is the patient had a radical cystoprostectomy with lymph node dissection done. The primary tumor did not show evidence of the stromal osseous metaplasia, but this was noted only in the nodal metastasis, which occurred at that time, with a scanty foci of tumor. The seventh case, case of nodal metastasis, as well as in the right retroperitoneum, which is a bit similar to our case. A poorly differentiated tumor with small foci of stromal osseous metaplasia. There was no definite correlation between the grade of tumor, as all grades of tumor were noted with this histopathological feature. So what would be the possible etiopathogenesis? The article by Pang et al. Talks about the presence of scar tissue. Now, we do know that scar tissue has a propensity to metamorphose or have metaplasia into various other mesenchymal components. So they propose that the presence of scar tissue due to either a previous surgery or therapeutic modalities. For example, one of the cases had leuprorelin injection. This could contribute to creating an environment for metaplasia. increasing local concentrations of alkaline phosphatase and proliferation of fibroblasts. In fact, in 1931, there was a very interesting study done by Huggins et al., where they actually put urothelial epithelium into an environment, in vitro, of course, and studied what minerals can be secreted by urothelium. And they found that there was an increase in the amount of calcium as well as phosphates in the medium, as well as an increased local concentration of alkaline phosphatase, which could definitely contribute to the presence or the development of ossification. This, in association to the proliferation of fibroblasts, act in a sensitive medium, in the fact that factors like bone morphogenetic proteins like BMP1B and BMP2, which are members of transforming growth factor TGF-beta superfamily, act to stimulate these fibroblasts. These stromal mesenchymal cells transform into osteoblasts, which then result in osteoblastic metaplasia. Another hypothesis also states that there can be other transcription factors like OCT3x4, SOX2, c-MYC, and KLF4, which can generate these pluripotent stem cells which stimulate the process of osteogenesis. And of course, there's also theory which says that the tumor itself can produce a clone which differentiates towards osteoblasts. So the conditions which are considered necessary to develop this picture were hypothesized as the presence of a precursor, in this case, the tumor or the urothelial epithelium or the urothelial carcinoma, and inducing agents, for example, the transforming growth factor family or transmissible factors, and a permissive environment. Excuse me. I would like to emphasize here that the presence of the bony component does not change the therapeutic outcome. The therapeutic outcome depends on the epithelial component, which incorporates the grade of the primary tumor, the stage of the tumor at presentation, including metastasis, and muscle invasion. I would like to conclude with the following points to emphasize that urothelial carcinoma recurrence presenting as a calcified mass with extensive osseous metaplasia is extremely rare. These cases have been reported in the context of usually urinary bladder tumors. Our case is rare in one, it is in a female. It has occurred in post-primary renal pelvic carcinoma and has occurred in the retroperitoneum. These ossified tumors can pose a diagnostic difficulty, especially in the lack of previous history. In our case, the patient came to us without any previous radiological findings or the previous histopathology. And it was really a diagnostic conundrum for us to find out why this tumor is ossified and what could be the primary. Similarly, for the radiologist, it is a diagnostic difficulty because these masses are heterogeneous on scanning and can mimic other tumors which can be present in that area. Another point I would like to emphasize is the role of extensive sampling. As we know, most tumors require extensive sampling, especially if they have heterogeneous areas. So if in the first look you do not see your primary tumor, please look and look again. And definitely, I am sure we'll find the residual focus of carcinoma lurking somewhere in between these bony trabeculae. Why do we need to look more extensively at this tumor? This is because metaplastic bone needs to be differentiated from malignant stromal differentiation, which can occur in sarcomatoid carcinoma. This malignant entity portends a poorer prognosis for the patient. In cases with history of radiotherapy, an extraskeletal radiation-induced osteosarcoma, which is extremely rare as well, also must be excluded, especially in the previous cases where the metastasis in the tibia and the femur showed this picture. A malignant osteosarcomatous proliferation must be excluded on histopathology. I would like to present my references. Most of the references include this very detailed article by Lilian S. Ipang, which has extensive descriptions of these tumors in the urinary bladder. And, excuse me, this article by Young and Abel, which talks about unusual forms of carcinoma in the urinary bladder. Other than that, most of the other references are mostly single and rare cases which have been reported either on radiology or on histopathology. These are further references about these rare cases. Thank you so much. To summarize, I would like to say that we did not do immunohistochemistry in this case because the patient was not able to pay for the immunohistochemistry workup. However, an extensive and thorough search for the primary tumor with morphology and detailed chasing and workup of the previous history and radiology really helped us for the diagnosis. I thank you so much for your patient hearing. I am open to any questions.
Well, thank you, Dr. Sophia, for presenting such a rare, interesting case from uropathology section. It was really beautiful to look at your histopathology images, H&E stain sections. And the platform is open for any questions to Dr. Sophia. Well, I had like two clarifications, Dr. Sophia. Like the first one was regarding IHC. So in the end, you have mentioned that the patient couldn't afford financially for the IHC markers. So, well, I had that in my mind to ask you, like whether did you go ahead with the IHC markers? So, well, you have cleared that. And the second was, my clarification was like have you considered the sarcomatoid urothelial carcinoma as the prime differential diagnosis? Because they do show a lot of heterologous differentiation consisting of, it could be rhabdomyosarcomatous differentiation, or it could be osteosarcomatous transformation, or it could be chondrosarcomatous differentiation, or sometimes other different elements. So, yeah.
Yeah, thank you, Dr. Archana, for that question. Actually, when we first saw this case, our first impression was we have to look for the malignant component. So we did an exhaustive search, I think about 25 plus sections we examined. And our first impression was, why is there no malignant stroma? And why is the epithelial component not associated with any malignant stroma? Because there was a clear-cut demarcation between the epithelial component and a clear-cut demarcation between the spindle cell component. A detailed search, even for the mitosis and the atypia, was mostly in the epithelial islands. And I believe if it was a sarcomatoid carcinoma, characteristic morphology and spindle-shaped cells would definitely give us a clue as to the process. We could not find any other heterologous elements as well. We could not find cartilage. We couldn't find a muscle. We couldn't find, all we found was benign bone and this edematous stroma in between. A point about the immunohistochemistry. Normally, immunohistochemistry, we would normally do a CK7, CK20, and a GATA3.
Yeah.
Yes, and that would definitely help us in the diagnosis. But an interesting point that I found in all the literature was that a lot of them didn't do immunohistochemistry because the histology was characteristic.
Okay.
The histology was papillary urothelial carcinomas, and
Yeah.
the morphology was quite distinctive, which wasn't really a problem for morphological diagnosis. In this case, we would definitely have gone ahead with an entire panel of CK7, 20, and GATA3. Yes, especially if we found a bit more prominent epithelial component. But I think with the characteristic history and the fact that the previous nephrectomy had lymphovascular invasion, I think it really helped to contribute to our diagnosis, which ended up being a morphological diagnosis.
Right. All right. Yeah. Thank you. Thank you, Dr. Sophia, for clarifying me. So are there any other participants who want to have any suggestions for Dr. Sophia, or any questions or any other clarifications? Well, I don't see any questions posted in the chat box as well. Well, thank you, Dr. Sophia, for so generously volunteering to deliver your speech on this platform today. Thank you.
Thank you.
Yeah. Well, shall we move ahead with our other morning speakers today? And next, it is going to be Dr. Alvaro Ibarra from Chile. I hope Dr. Alvaro Ibarra is ready with his presentation. And the topic, yeah. Good morning, Dr. Alvaro Ibarra.
Good morning and good evening for you.
Yeah, kindly go ahead.
I got a great pleasure to share my with all of you.
Can you slightly increase your volume?
Excuse me?
Can you slightly increase your volume?
Okay.
Yeah.
If you can see my presentation?
Yes, sir. Yes, sir. Please go ahead, sir.
Okay. Okay. Thank you. Cilium is a small organelle extending from plasma cell membrane. Provides a hub for concentration of transmembrane receptor. These receptors transmit signal from soluble factors, regulate cell growth, mechanosensory cues provided by flow or extracellular matrix. Ciliation is regulated by cell cycle. Most cells in solid tissue are ciliated. Cancerous transformation induce significant changes in ciliation. Most cancer cells lose cilia. Changes in cancer cell ciliations are driven by core oncogenic pathways. Ciliation is both influenced by targeted cancer therapies and linked to therapeutic resistance. May influence cancer cell metabolism and stem cell identity. Traditionally, the presence of cilia has been considered characteristic of cell maturity, defining benignity. Rare cases of malignant neoplasms may include them. In ultrastructural study, it is common for isolated tumoral elements to have cilia. Henriksson and Kempson from Stanford in 1983 put on the top this theme, and they cited previous reference about the topic with descriptions of Sommer, Lebow, and Scully in well-differentiated cancer in pancreas, bronchiolo-alveolar cancer in lung, and borderline tumors in ovary, respectively. In the bottom, the article of Henriksson and Kempson, they found 10 cases with prominent ciliary differentiation in 400 cases, especially in well-differentiated endometrioid carcinoma. Another author demonstrate the same. In the cervix, another author. In ovary, newly Scully and two others authors. In testicle, in stomach from 1991 by Rubio, esophagus, Rubio, Kanamoto, Yamasaki, and in the last two reference in multidifferential carcinomas with several kinds of differentiation, included neuroendocrine and glandular and ciliated carcinoma. In pancreas, lung, and ciliated mucoepidermoid carcinoma is one of the types of neoplasia which can differentiate to ciliated form. For example, in stomach, salivary gland, and thyroid. Lung ciliated muconodular papillary tumor is very rare neoplasia, benign, typically in around 70 years, like solitary nodule in the gray majority in lower lobes in subpleural situation and small in diameter. Ciliated adenoquamous carcinoma, a human papilloma virus associated tumors, is a head and neck tumor, HPV related, with primaries frequently found in palatine tonsil and base of tongue. In about 50% of the cases, the diagnosis is made in lymphadenopathy in neck with tumor of a now primary site. They are squamous non-keratinizing carcinoma with cystic change, gland formation, mucin production, and cilia in tumor cells. This picture illustrated lymph node cervical metastasis in a salivary gland carcinoma related with HPV. Is from an article of Bishop where they shows characteristic rearrangement genetic in this type of neoplasm. At the top left side, the rest of the lymph node parenchyma, a tumor with cystic glandular spaces, mucin production, and at the bottom at right, ciliated cells. In contrast to usual adenosquamous carcinoma, often the neoplasms related with HPV have lower grade cytonuclear features, P16 positive, and in situ hybridization for high-risk HPV DNA. In the differential diagnosis, we have usual adenosquamous carcinoma, but they have moderate to high grade, and it is not related to HPV. And mucoepidermoid carcinoma with non-keratinizing, intermediate, and mucous component, and characteristic genetic rearrangement. We have strong evidence of metaplastic change in the production of ciliated cells. In the stomach, it's seen in older patients, greater in antropyloric mucosa with intestinal metaplasia. In Hong Kong, they have found in 44 of gastrectomies specimens. Higher in patients with adenocarcinoma versus benign pathology, around 50% versus 40 or lesser percent. In 5% in the Atlantic Basin, and almost 30% in the Pacific Basin. In the stomach, the association of ciliated cell with intestinal carcinoma is higher than with diffuse carcinoma, 9 versus 3%, and 43 versus 16% in Atlantic and Pacific basins. In esophagus, combined with Barrett. Our case, a man, 39 years old patient, operated 2 years ago in another institution. In another institution for cervical metastasis of HPV-related ciliated carcinoma, 4.5 in higher diameter. No primary cancer was found in his study. 2 months ago, a new metastasis, bigger 4 centimeters, was resected in our hospital, performing in that opportunity a right cervical dissection with another 36 negative lymph nodes. Palatine tonsils and adenoids were removed, and a biopsy of oral mucosa, base of tongue, was taken, and no malignancy was found. The metastasis had macroscopic cystic necrotic appearance, the typical aspect of this type of tumor. Low magnification of our case with big cystic spaces with secretion or detritus, similar in macroscopy that we can see in another cyst of cervical region. Limited by especially cylindrical epithelia, and in the top of left side, squamous epithelia with more magnification, the columnar epithelia with clearly ciliation, and with immersion high power, the ciliation is very clear. The squamous component, very low grade in the other parts of the lining of the cyst. Our case is an HPV-related carcinoma with presentation as cervical metastasis of and now primary. Characteristic macroscopic and histological aspect for this entity. A tumor fundamentally cystic with Ki 67 greater than for benign lesion. A strong and diffuse positivity for P16 immunohistochemistry, and with positivity for HPV type 16 with RT-PCR multiplex. At the left, the strong positivity with P16 immuno, and the right side, Ki67, more positive with a great score, not seen in benign lesions. Differential diagnosis of cystic neck lesions. Several pathologies can debut like cystic lesions, especially branchial cleft cyst. The most important differential diagnosis with our pathology, with ciliated carcinoma related with HPV. In lateral position in the neck. Thyroglossal duct disease with central localization. Of course, metastatic papillary thyroid carcinoma with typically endometriosic-like fluid, very exceptional heterotopia-associated carcinoma, dermoid and or ceratoid cyst, and lymphangioma, hemangioma. But the most important in the differential diagnosis is the first in the slide, metastatic squamous cell carcinoma. When this tumor has moderately or poorly differentiated features, is not a problem. But when it is a very well differentiated neoplasm, like our case, the related carcinoma associated with HPV, we need to take a lot of care in the interpretation of this kind of lesion. Nowadays is really an epidemic of head and neck carcinoma related with HPV. A lot of famous people, actors, politicians, etc., we know that they suffer of this kind of neoplasm. It's really an epidemic with significant increase in this anatomic region. All the cases of oropharyngeal carcinomas, we need to make P16 determination and then typification for HPV class. Most or these tumors have oropharyngeal primaries. Half of them debut with metastasis in cervical nodes of expansive growth, usually cystic necrotic. They are non-keratinizing squamous carcinoma with mild atypia. Sometimes exceptional features such as glandular differentiation and ciliated cells that can favor misdiagnosis. The P16 expression and high-risk viral typing are the clues to confirm the diagnosis. HPV-related ciliated carcinoma should be considered in the differential diagnosis of well-differentiated squamous lesions of the oropharyngeal cavity and at the cervical level with non-neoplastic cyst. Difficult diagnosis in cytology, and of course, in frozen sections. Our patient is being treated with a radiotherapy protocol for primary neoplasia of unknown origin. These tumors are added to the list of neoplasms that defy the dogma that ciliated epithelium always equates a benign process. Thank you so much for your warm attention. The best regards from Chile.
Well, thank you, Dr. Alvaro. Thank you, Dr. Alvaro, for putting your insights into the topic for today. And it was a pleasure to listen to your speech today. And we truly appreciate your patient participation in this virtual digital conference.
Thank you.
Well, so are there any questions to Dr. Alvaro from
Yes,
any of the participants?
Dr. Archana, ma'am, I would like to ask a question to Dr. Alvaro.
Sure, go ahead.
Dr. Alvaro, is it the ciliated mucoepidermoid carcinoma that you have mentioned in your presentation? Is it a molecular based diagnosis that we are talking about, or on histopathology you have any kind of clue that this is a HPV related ciliated carcinoma?
Probably for presentation in medical literature to describe this type of lesion, probably we need molecular support. But in the day practice, we can do the diagnosis without problems. Mucoepidermoid carcinoma shows us the three characteristic components: squamous, intermediate, and gland differentiation. And usually is lesser cystic in pattern versus ciliated carcinoma that has also different components, but in these tumors, the squamous component is always non-keratinizing without intermediate cellular component and with macroscopic characteristic pattern, very large cystic spaces, and of course the profuse presence of ciliated cells. Ciliated cells are more common in this entity, and in the mucoepidermoid carcinoma is yet more exceptional.
Okay. Thank you, sir. Thank you. That was a wonderful presentation given by Dr. Alvaro. Thank you so much.
Thank you.
My question is answered.
Thank you, Dr. Alvaro, for answering Dr. Neetu's question. Any more questions to Dr. Alvaro? Well, I understand that Dr. Neetu had also a question for Dr. Sophia.
Yes,
Is
I
it
did
so?
have a question. Yes.
Yeah,
The
I hope.
one question was answered by the same question that you had posed regarding the IHC panel for
Yes, yeah.
that particular malignancy, what it would be if it was done and why it was not done in the first place. And yes, if Dr. Sophia ma'am is available, I wanted to ask another question about unusual forms of CA of urinary bladder that she had actually posted an article, and she had referred to this article. What are the other unusual forms of CA of urinary bladder that she had come across through her practice so far, apart from this topic that she had presented?
Thank you so much,
Yeah.
Dr. Neetu. We've actually experienced more of the garden variety of urothelial carcinomas. So for our experience, I think we had a couple of cases of sarcomatoid carcinoma. We have seen nested variant of urothelial carcinomas. And we had a case of trophoblastic cells in a carcinoma. However, we were unable to prove it on immunohistochemistry, so we ended up giving it as a descriptive report. So I can't really conclusively claim that as one of the variants that we saw. Otherwise, even in Malaysia, the routine practice is to see urothelial carcinomas of various grades. Squamous carcinoma is extremely rare. I have perhaps seen one anecdotal case in the 8 years I have been here. And of course, we had a case of urachal carcinoma. So these rare cases, of course, the important thing is to keep an eye out for them and to extensively sample the bladder, because often these may be lurking behind adjacent to the primary tumor. And in small biopsies as well, especially in biopsies which have an undifferentiated morphology, of course, a well-researched and careful panel of immunohistochemistry can exclude these other rare variants of carcinomas occurring in the bladder. Actually, the latest WHO also has no longer included stromal osseous metaplasia and the variants in the classification. It directly lumps everything together under sarcomatoid carcinoma, and all these are considered as descriptive enablers for urothelial tumors, not considered as separate categories as well. But it's an interesting histopathology to just come across to spice up your everyday reporting life.
Thank you, ma'am. That answered my question.
Thank you, Neetu. Thank you, Dr. Archana.
Thank you, Dr. Sophia. So yes, actually, coming to Dr. Sophia, back to you, regarding the IHC, and I remember you had mentioned that the patient was a female and she was 63-year-old, if I'm not wrong. So before looking into the actual histopathology slides, my thinking would be opening up to the female genital system as well. I mean, the
Yes, that's true.
endometrium, cervix, all the adnex, they can have the transitional epithelial differentiation, which could mimic like a urothelial carcinoma, and that could even show a differentiation into the stromal elements, like what you have mentioned. So my view actually, my thought process went into that way, since your patient was a female and around 63-year-old. But yes, as you have clarified through your images, yes, they do depict the urothelial carcinoma with the stromal things. And well, yes, the other differentiation into RMS or the osteosarcomatous component or chondrosarcoma, as you have not found any foci of the cartilage or the malignant bone, well, that could exclude that components. Well, yes.
And
really
also
interesting.
this patient had a very well done imaging. We didn't have the images, but her uterus, ovaries were all absolutely normal. So that also contributed to the fact. But if the tumor was more down in the pelvis, I would definitely have considered an ovarian tumor first.
Yes, well. Yeah. Thank you, Dr. Sophia. And thank you, Dr. Neetu. So, any other questions to any other speakers for the morning presentators? Either to Dr. Ritika or Dr. Neetu or Dr. Akanksha or Dr. Nikita or Dr. Sophia and Dr. Alvaro, from any other participants? So as of now, I don't hear any questions from any of the participants. Shall we move ahead with our next participant? That would be the last speaker from today's morning session. And it is Dr. Zeev Leifer from Germany. I hope that Dr. Zeev is ready with his presentation.
Hello.
Yeah.
Can you all hear me? Can you
morning.
see me? Good morning.
Yes, you are audible. Can you please share your screen, please?
Of course, I will. How do I? Okay. Can you see my screen?
Yes, sir. Please go ahead, Dr. Zeev. Thank you.
All right, then welcome, and thank you so much for giving me and my team this opportunity to talk to you. I want to say hi all around the world, as I see this is a very, very diverse group, a very international group. So probably not enough to say good morning, but also good afternoon and good evening. So I would like to take this last opportunity of the morning session to talk to you about semi-automated digital quantification methods of hormone receptors, ER/PR, and proliferation index markers, Ki-67, in invasive carcinoma of the breast. What I want to is give you a sort of key presentation into a historical review, where we are right now in the field and what the future potential can hold. I'd like to introduce myself to you. My name is David, and I'm a biologist, and I work at a company called MindPeak that I want to also briefly introduce to you. Our mission here in MindPeak is to make clinical routine diagnostics easier for pathologists, for you, with the help of artificial intelligence. We are an AI-driven company, software company based in Hamburg, Germany. It's a beautiful city. I would invite you, everybody, to come visit us here. We have 25 employees that have together 15 years of experience in AI, with many partners we are fortunate enough to work with. And I want to take this opportunity of this talk to give you, who are really experienced clinical pathologists, the opportunity to have a look into this quite new field of computer-assisted clinical pathology, and give you an outlook as to what you can maybe expect and what are the challenges right now that we are facing in this field. As you may or may not know, and this is also one of the top motivations for us to be in this field, the field of pathology, depending on where you are in the world right now, is facing some very disruptive changes, and it's undergoing some very monumental shifts. And on the one hand, what we see and what others see is the emergence of many new cancer cases. Of course, this is linked to the increase in population all over the world. And over the past 10 years, and the numbers show a significant increase of up to 28% in cancer case occurrence worldwide. Another statistic that really got us into this field is that the complexity of cases, not only the amount of cases, but the complexity of cases seems to be rapidly increasing, with newer diagnostic tools and the need for very fine specific treatments to be applied very specifically. The amount of slides per case that the pathologist would encounter is also increasing. This is from a study done by the University of Heidelberg in Germany, where they measured the amount of slides per case and registered over the last 15 years a 44% increase in the amount of work for the doctor. And on the contrary to that, maybe this is also something that, depending on your geography, are witnessing, is that depending on where you are, the number of active pathologists is not matching the rising tasks and the rising intensity and workload that they have to face. For example, in the United States, in a study conducted where they measured the number of active pathologists over the last 10, 15 years, they noticed a drop of 18% in the number of pathologists, while on the same page, you have an increase in the amount of cancer patients. You have an increase in the amount of intensity that the pathologist has to work on. And these are really the key driving factors that got us into working in this field, and where we want to tackle the problems and assist you, the doctors, the pathologists, the experts, into doing your work as good as possible for the benefit of the patient. So over the recent decades, since these trends have emerged, one of the key helpers that were identified is digitization. And on the one hand, this means the use of digital slide scanners in laboratories that help to get away from the physical microscopical slides and move on to digitized slides, and together with the second aspect being image management systems like PathoZoom that allow files to be shared across borders without physical limitations easily, to encourage the collaboration between different experts to share knowledge. This has been really a key driver to tackle these problems, is to be able to overcome these physical barriers and to work as good as possible on these cases digitally. But these two things together are not really enough to tackle the immense problems we are facing at the moment. And this is why around 20 years ago, we saw the emergence of computer-assisted vision tasks, where we use computer programs, where we develop software protocols to assist, again, you, the experts, in one of your most manually and labor-intense tasks, which is the manual assessment of stainings, of images. And one of those early approaches is called the classical computer vision. And they relied on handcrafted descriptors, being features of cells that describe their morphology and their appearance. One of the examples I would have here is if the doctor wants to assess the quality of the cell marked in red, what the computer vision would have is these descriptors, for example, the color, size, and shape of a cell that it would assess. And you would have to input manually at first that a color brown, meaning positivity, in this case towards progesterone receptor, a size of, let's say, around 10 micrometers, and a shape that is somewhat irregular to what you would expect in the beginning, would lead you to a diagnosis. In this case, it's a PR positive tumor cell. And with cases that are fairly straightforward, that are easier, so to say, in this case, you would be right. And in this case, the classical computer vision could already help you form a diagnosis in some cases. But of course, there's limitations, and especially limitations to the approach of classical computer vision. The main problem here is that these features that we have to design and define don't really generalize well on edge cases and novel tasks. Meaning these features, they work very well in an organized environment when examples look more or less the same and just have to be run through a basic algorithm. But with more complex vision tasks, like the assessment of mitotic figures in H&E slides, this can get really difficult really fast. On the one hand, you see examples from mitotic figures, and on the right, examples for artifacts or structures that you would normally not like to have in the category of mitotic figures. And in these cases, the computer vision approach of comparing the morphology, comparing the size or the shape fails, because the key to solving these problems rely more on a more general approach, a more abstract analysis of the surrounding areas, for example. Another limitation of this classical computer vision is the use of different clones and different antibodies within different laboratories. In the example of PD-L1 non-small lung cancer, some labs or some approaches require using a clone SP263 that has a very intense border staining, very intense membrane staining, whereas the 22C3 clone is significantly weaker in the expression on the membrane positivity. That means already here, having a generalized approach to assessing the color and the shape would fail again, because the inherent quality of these two stainings are completely different. So the key problems here really are with the automated analysis using classical computer vision is that you have a huge variety in data, meaning tissue quality, every patient is different, every tissue quality is different. You have different scanners and microscope operating in the laboratories, and of course, staining procedures, staining protocols and antibodies vary so much between laboratories that a standardized approach for all of these using classical computer vision is impossible to achieve. And this results really in a lack of robustness of these applications, meaning you have solutions that might apply for a very specific set of data, a very easy or clear set of data that it has been optimized for from the beginning. And maybe this could be that you would make an application for one laboratory and it could work there. But the problem is that you have no general application possible through this. And for each and every solution that you want to apply, you'd have to go back and redefine these descriptors and redefine the features to fit exactly the purpose they have to show for. And this is really limiting in the for the professionals, for the pathologists, but especially limiting for the programmers that work on these sets, because they have to do the same thing over and over and never achieve true generalization. So what's the solution? The solution in this case is called deep learning, and it's something that you may or may not have heard. It's fairly recent, and what deep learning means really is learning from examples. And one of the most well-known approaches of this deep learning is in the search for self-driving vehicles. And the approach here is that in the beginning, you have a lot of example images, a lot of data of cars and roads and road signs, and you give it to these very complex, very adaptable deep learning algorithms that are modeled to work very similar to the brain itself, where you have different nodes, different nerves or neurons firing with each other and forming one coherent output in the end. And the output in the case of self-driving vehicles, of course, would be the automatic recognition of the environment and the fast and secure adaptation of behavior on the road. Now, this is all very theoretical. Let's jump in. The breakthrough in deep learning really happened in 2012. Beforehand, all we had were these classical computer vision algorithms and a way to assess their efficiency and to assess their accuracy. It's a so-called ImageNet, which was a set of images that each and every sorting algorithm, visual sorting algorithm, was trained on. And this included, for example, cars, animals, and buildings, and everything you will see in the environment, and that would be very important, and also but also very tricky for a computer to understand and to categorize. And with these classical computer vision approaches, there very quickly was a threshold where the quality wasn't improving at all, no matter how much work they were putting into. So in the end, they always ended up at an error rate of 25%, 26%. And of course, as you may know, this is not acceptable at all in a medical or in a clinical environment where really the smallest things have an impact on the survival and of the benefits to the patient. But in 2012, with the development of these and the discovery really of these neural networks, of these deep learning algorithms, and also fast hardware, so faster CPUs and graphic cards, they were able to crack this barrier of the 26% error rate. And in that short period of time, really, were able to get incredible results in terms of the error rate. It dropped from 26% only 10 years ago to under 5%, even 2% with these neural networks, which really shows the powerful capabilities of these networks in terms of learning and abstracting from the tasks. Okay, but as we are not really working in the convertible or in the tiger space, but in the pathology space, let's see what this means for digital pathology. At first, this means that with some of the initial problems that we face with the computer vision, we can actually now deal with these, meaning because the neural network develops its own complex internal rules and that don't have to be set by the programmer beforehand without even knowing how it's going to look like in the clinical routine. But now it's the algorithm itself that teaches itself what is important and what to look for. Some of the problems that we had in the beginning with the differentiation between mitosis and not mitosis are now possible to task, because the complex internal rules it teaches it to look beyond just the color and shape and size of a cell, but also the surrounding and the context and everything that up to now differentiates the computer from you, the professionals that have all this experience. So does this say we have mission accomplished and everything is good to go and basically I'm out of work? No, of course not. I mean, using the deep learning algorithms we have until now, we can already try and assist you in your work and already try and have a positive impact on your work and overall on the clinical outcome to the patient. I mean, you might say, okay, let's go, give me the program and let me start working. Let me actually reduce the time I have to spend on cases. But of course, there's still problems that we have to tackle and still difficult tasks. Right now, what we are working on in the AI industry applied to pathology is that we have these standard deep learning models that I introduced to you in the beginning that were initially developed to detect cars and trees and everything that the self-driving car has to find out on the street. But really, these networks are not specifically made for cars. They're just really good at abstracting information, at learning and improving on tasks until you have a good outcome. So that is the one side. The other side is that you have a controlled data set, and what that means, I will show you in the want to show you now. One of the biggest problems that we are still facing up until now, and that will probably never go away in terms of the problem itself, are variance is the variance in slide preparation. Meaning, as I mentioned before, every lab does it differently, every tissue is somehow differently, and in the end, when you have a look at 6 examples from 6 different labs, you get 6 completely different results in terms of the color spectrums, in terms of the quality of the fixation protocols in terms of how the tissue is preserved. So this, if you think about what the computer has to achieve on these examples, to grasp the difference and to still try and make meaningful results out of these very different examples is really the key challenge. And this is something that we, as, let's say, technicians, really marvel when observing the pathologists and when observing how good the human brain and the human capabilities are of abstracting information, and how applying knowledge from one example can really benefit in the analysis of the other examples. I mean, the things we have to teach the computers right now are some things that the human brain is just really good at doing. So, of course, we don't not only have a variance in slide preparation, but also variances in digitization. I mentioned earlier the use of digital slide scanners, and every scanner is different. They all use different cameras and lighting conditions, which means you end up again with very, very different results, where maybe as a person, as a pathologist, you can work on all three examples and very quickly get an overview and be able to analyze the situation. But again, for the computer, this is really hard and requires a very methodological approach to this problem. So how do we do it? Or let's say, not only how do we do it, but just to clarify again of how difficult this is and how amazing it is that the pathologists are able to do this. Pathology and clinical pathology sits right at the very top of task difficulty. For some stainings, for some cancers, it takes years and decades to perfect the approach to analyzing the samples and analyzing the stainings. But also for us, it sits right at the top of how hard it is to get meaningful and significant data to work on these AI-assisted solutions. Right now, one of the key limitations of even deep learning is these cases that involve using a lot of context information. One of these examples is when looking at progesterone positivity in mama tissue. On the right, you have an example of a cluster of tumor cells. Some are PR positive, some are PR negative. And on the left, you have an example of a PR positive benign glandular structure. And without the full picture and without the knowledge of having seen these examples for tens and hundreds of times, it's really hard, again, also going back to these descriptive factors, to differentiate these cells just based on their color or their morphology, because they all look big and they all look round and they are all activated in some sort. So here is really one of the key challenges still for the deep learning, to differentiate why one is the malignant structure that you have to detect and one is the benign glandular structure that you want to ignore, basically, or definitely, or at least want to treat differently and not detect as a tumor cell. So let me guide you a little bit as to how we try and approach these problems. Our deep learning architecture that we developed is called a fully convolutional neural network. And well, again, the digital pathology, as it being a very difficult field for machine learning, we are trying to tackle it with pre-made architectures, and we found that this is not only enough to be able to tackle the high variance in data, but inspired by how the pathologists work, we devised our own custom architecture, which we call FocusNet. It focuses on the cell level details on the one hand, meaning it observes single cellular structures, but it also focuses on the context in another pathway, similar to how the pathologist would actually tackle this project. So, but tackling again the issue of comparing two cells that are completely different cells but maybe look similar. This approach can help you to get a combined output and really get the most out of your results and the most accurate results. Again, so combining information about the cell morphology, but also the structural morphology of the tissue and of the context. Looking at the shape and color and the other information contained in the images, the neural network learns itself to associate cell organizations, in this case, to make more abstract groups, which then help in classifying them correctly. In this case, instead of just looking at color, shape, and size, what the AI would do is look at the relative organization of the adjacent cells and using this form its own diagnosis, giving you the output that this is in fact a benign glandular structure that is hormone receptor positive. All right. The way we constructed this network architecture, meaning it's a fully convolutional neural network, that means it is possible to handle input images of any size. This means that you can select small areas to analyze on demand, or we can use the same network to pre-compute all the results in the whole slide image and then show the results already once the slide is open. So again, being able to adapt to as good as possible to the clinical routine that you face in the laboratory, being able to analyze just a small cluster of cells or the whole slide to get the diagnosis that you need and that you want for the patient outcome. So our approach, what we kind of do differently in terms of constructing these networks, is that we value data diversity always over data quantity, meaning the AI is trained on a data set from always different scanners, different laboratories, and all the different staining procedures that we can get our hands on. And we always select and rate our new data to improve the AI based on those diversity criteria. So we believe that it would be better to have 10 very diverse examples than 1,000 ones that are quite similar. So the amount of learning you can get out of the diversity is really important. When approaching the training for a neural network, there are two basic approaches. So one being supervised learning, which means that when providing the data to the network, you also provide labels. In this case, it's shown and illustrated as class 1 and class 2. So you have, in the beginning, you have clusters of data, and you want to have a network that can actually make a sense out of these clusters of data. So what you give it to train are annotated, are these annotations, meaning you give it class 1 and class 2, and based on these annotations, it can form the diagnosis that these are in fact two very different clusters, and it can then try and move the knowledge that it acquired on this case onto all the other cases that you feed or that you want to train on. The other approach that is commonly used is referred to as unsupervised learning, meaning you omit all the labels entirely and also and only model the data itself and let the network figure out itself common structures in your data to represent which data points are similar and which ones are dissimilar. Of course, in unsupervised training, it's essential to guide the network towards learning proper representation by using a proper loss function and the right augmentations. Here's an example of different images. A neural network could detect similar tumor areas and associate them to being similar to each other while finding other areas which are dissimilar. It would look like this. In this case, the green areas are found to be matching and similar, and the red areas are further away in the representative space, so dissimilar. And without the need for labels, without the need for any annotations, these are already very significant informations that the network can teach itself based on the diversification of data that are given as an input. So what we do differently in this case is we have also supervised learning, which means that we train with labels, as I said. And in the case of this pathology application is we have an image, and all the cells that we're going to recognize in the end, or that we want the AI to recognize itself, are labeled, are giving labels like tumor negative, tumor positive. We have immune cells and benign cells, all the different cells that the AI has to recognize in the tissue to then learn from that and give you the outcome. For example, inputting an image and you want to have the proportion score of positive tumor cells in this given area. And this is something that can be achieved very, very, very good through the supervised learning and through providing annotations done by trained experts, and inputting those in the network. What we kind of want to do is combine these two approaches and get, let's say, the best of both worlds. So we combine the supervised with the unsupervised in a form of semi-supervised manner. And on the one side, and from the supervised learning, this helps us a lot to, this helps our AI a lot to find a robust initialization on the data, and alleviating also problems that are associated with label ambiguity that are associated with the supervised learning. And then the supervised learning, on the other hand, picks up on these pre-learned features and refines the AI, especially in very difficult cases, to achieve then the high percentages of accuracy. The goal in the end, of course, is to get a product for the clinical routine that works just the way you want it and you need it. And for example, that could be then the analysis of big patches and the analysis of positive tumor cells, negative tumor cells, proportion scores, but also an analysis of benign structures. So really a product that fits the clinical routine where it has to perform best, and where also the biggest impact on in terms of increasing accuracy and reducing time and cost can be made. We are quite proud, actually, to have released our first product called Breast IHC, which passed the German laboratory accreditation test with a high accuracy of 96%. Right now we have one of the largest clinical studies in progress, and are aiming to receive our CE-IVD clearance within the beginning of next year. And I've been talking a lot to you, so I would actually like to take the opportunity and give you a demonstration as to how this could look like applied to in a digitized laboratory environment. So I hope the sharing of the screen still works now. I will switch over to our AI console and would like to demonstrate what I've talked to you about. So the single cell quantification of receptor markers and proliferation indexes on some live images. And of course, I want to show you not how it works 6 times on the same images, but really, let me refresh here briefly, how it performs when we have 4 different images from 4 different stainers and 4 different scanners. So let's jump into the first example. This is an image of a Ki-67 staining. And what we can do now is select our region of interest. In this case, I would go into this tumor cluster here and just zoom in, find an area that we are interested in. Then we select the analysis type as this is a Ki-67 sample, I would select the Ki-67 algorithm, and now just click and drag to select my region of interest that I want to quantify. And now the AI is actually in real time analyzing this image, and after some seconds, giving us a quantification of these single cells. On the left side, you can see the number of positive tumor cells. You can see the number of negative tumor cells. It outputs the positivity score for this area. And also the positivity threshold is something that, of course, you can still work with. But let's zoom in first and inspect the result. So what the AI, or what the task of the AI in this application is, on the one hand, to detect all significant tumor structures and label them accordingly as either negative or positive, and also, and most importantly, to avoid and ignore most non-tumorous structures. And in this example, we can see here that it labeled in yellow all the negative tumor cells, and in red the positive tumor cells, and it was able to ignore, for example, this non-tumorous structure, and also here. And but then if you, for example, let's say, if you want to look at a different example, we can move back to the gallery. So if you imagine in a digitized lab environment, this is where you would have all your cases that you would have to evaluate in the given time, and that you would have to, let's say, in a day. And you can easily switch between them at all times. Okay, going into the next example. Again, this is a completely different scanner and stainer, and the colors already look quite different to previously. This is again a Ki-67 example. I would select the Ki-67 algorithm, draw my region of interest, and after some seconds of analysis, we would get our result. In this case, we have a positivity of around 40%, with roughly 100 cells analyzed. Again, you can zoom in and review your examples. And again, the goal here was to get the most of the tumor structures that you would like to analyze while avoiding the non-tumorous structures. Okay, let's check out another example. This is the red background is always, for example, a Philips machine. So again, selecting an area, selecting the algorithm you want to use for your analysis, and selecting your region of interest. After a very brief calculation time, now we have analyzed 370 cells. We got a positivity score of 18, and we can now zoom in to inspect the results. And you can see that there seems to be also some image artifacts here, but it looks like the machine was able to deal with that quite robustly. Also showing the benefits of using the deep learning with which performs much better on these problematic cases in comparison to the classical approaches. Now in here, for example, you could argue that some of the cells that have been analyzed as negative, you would maybe say that they're actually positive. And of course, this tool is only being supposed to assist you in your diagnosis, so you still have the possibilities to adjust a little bit the results. So what we have here on the left side is a slider for the positivity threshold that we can use to adjust a little bit, and we can adjust it to just the right point where these two cells that we thought were positive but were initially classified as negative are now positive. And it would also now apply the same threshold to the cells in the region of interest that also were maybe initially negative, but that also would have to be classified as positive, adjusted now our threshold to these images. Okay, I would like to show you one more example. Now in this case, moving here, let's say we don't want to analyze such a small region, but rather the whole area here. What we can do is, again, just selecting our algorithm. And let's now draw a really big region of interest. Of course, this is going to take a little bit longer because the images have to be sent through the servers, and depending on where you are and how good your internet connection is, this actually takes some time. The analysis by the AI of the image actually doesn't take that long, but it's really the sending the image to the servers that takes a lot of time. And I hope that the servers in this case will be able to manage. Oh, there seems to be an error. Maybe because I selected a lot of white area around accidentally. Hoping this time the server is able to get the results. But okay, so there seems to be a problem with probably the internet connection. Then let's go further in the presentation. I would actually go back to my slides. So this was, let's say, this was our demonstration for fully digitalized laboratory. But let's say you don't happen to be working in a fully digital environment yet. We also have a solution that lets you use artificial intelligence just with your microscope camera or your smartphone. It's called Web IHC. And you can use it by simply creating an account on our website. Actually, let's check it out ourselves. This is the platform. I will log out briefly so you can see how it looks like. You can always create an account. It's free. The first month, you can just upload your data and see for yourself the results. And quickly log in here. And how it works is you just have to drag and drop or copy and paste your images from the microscope and your smartphone in here. It works best, as a recommendation, it works best for images that have a 20x resolution. And of course, the better the image quality in terms of using good lighting conditions, the better is the result. I can also show you some examples that we have on here. Some Chi-67 demo examples. Again, just as in the previous demonstration, you can see here how it analyzes on a single cell level a whole region of interest that we input in the beginning. On the left-hand side, we get the results, the amount of positive tumor cells and negative tumor cells. And this is really what I wanted to show you in the previous example where the servers, where the results couldn't be transmitted or the image couldn't be uploaded, is that you can not only analyze, let's say, a couple of hundred cells, but really 1,000 to 2,000, so thousands of cells. And again, it gives you the amount of positive cells, negative cells, and the proliferation score based on these numbers. You can again use a slider to toggle the positivity threshold. I can try this out in this example. So based on if you want to adjust it maybe to fit your diagnosis on this image. What you can also do is do it individually for specific target cells. For example, if you think that this cell should actually be a positive tumor cell, just click on it and it turns positive. This one also, probably because I readjusted the positivity threshold. So these actually all tumor. And let's say a cell, you think a cell was maybe missed, that should be included. Let's say this one here that is hiding between the other tumor cell. You could just click on the area and a new annotation appears. So now you have analyzed your image, you have analyzed 1,500 cells and get a proliferation score of 38.6% that you can use then in your further on diagnosis. You can download your image, you can download all the annotations to share it with your colleagues, to use it in a presentation, or to further collaborate with your colleagues on the patient. It's really simple. Just download, and there you go. Let's check out another example together. These ones are I can show you, and you can already again see that the quality in the images is varying very much. And this one seems to be a lot worse actually than the previous example. Again, it analyzes within seconds the image that you input here, that you upload and copy. It gives you the amount of positive cells, negative tumor cells, proliferation score. You can adjust it, you can add, and it's really refined to be a tool that is helping you as good as possible in your daily routine in analyzing these Ki-67 proliferation scores. Let's have a look at it. One last example. And again, this is something that you are invited to try out yourself. You can always register and try it out for 1 month, even with your own data. Again, it works pretty fast, within seconds, and you can always adjust to your liking, basically, to get the perfect results. Okay. That would conclude my demonstration and my presentation to you. I'm fortunate, or we're fortunate, to have a very amazing team here in Hamburg with us, of very brilliant minded people that are working together and tackling these difficult problems. We have some of the best data science people and experts in the field of pathology working with us, advising us. So we're very thankful to be given this opportunity. I would like to conclude the presentation by saying, please get in touch with us. We would really like to collaborate with you, see what types of data you maybe have that are very interesting, and we're always looking to build collaborations all over the world. Get in touch via email, or just write us through our website or on LinkedIn. I would be happy to meet you. And yeah, thank you so much for your attention. Thank you for joining this call, and also thank you to the organizers for giving us the opportunity to present here. And I'm very much open to receiving questions from you now. So thank you very much.
Thank you, Dr. David Mudler, for speaking on behalf of Dr. Khalid Daifala from Germany. For the information for the participants, Dr. David Mudler is the product specialist at MindPeak. It has been a pleasure to have you amongst us here in this conference, sir. And it is also good to know that MindPeak automates microscopical and pathological analysis with deep learning and artificial intelligence. Until recently, we are using the conventional light microscope. It has been the standard practice for the pathologist for examining the histopathology slides. However, digitization definitely affects the pathology workflow. And through Dr. David Mudler's speech, we understood that by the use of computers, this could be really helpful when it is difficult for the human brain to process so much of information, thereby freeing the pathologists, their valuable time that can be used by us to provide the correct diagnosis to the patient. So it was really a pleasure for us to hear you, sir. And thank you for making this topic really interesting and inspiring for pathologists. And it is really a wonderful thing to have you amongst us, sir.
Thank you very much.
And
Likewise.
last but not the least, sir, it is a great achievement from your side that you have passed the German lab accreditation test with 96% accuracy, as far as I had gone through your presentation. That's a really great achievement, sir.
Yeah, we're very happy on that one also.
Yeah. Thank you, sir. So are there any questions to Dr. David? From any of the participants?
Maybe questions, but also I would be open to hearing your experiences of digitization. How far are you in your labs and in your current practices? And have you made maybe initial experiences with digitized labs and AI software?
So, sir, actually, I have a small doubt. Like in the last pictures, in the last images that you have zoomed up and shown us, so what is the percentage of like false positivity? Like, for example, you have shown the Ki-67 index. So how far is it precise?
Thanks for the question. This is actually, I would say, one of the most difficult ones to answer, because this depends the most on the quality of the image and the quality of the data. So we kind of showed with the German laboratory accreditation test that under some circumstances we are able to achieve the let's say correct diagnosis by 96%, meaning we still have 4% left to improve, and 4% where we are encountering false positives and false negatives. So this is what we are aiming for, is to get rid of these last percents. But of course, as I showed you some of the examples where you end up with a very difficult lighting conditions, very difficult tissue conditions, sometimes the rate of these false positives can still be higher than what we managed to achieve in this one test. And this is why the data variety, having the data variety, is so important to get these really, really difficult cases. Sometimes, yeah, you have, it really depends on what you're dealing with, but on the overall, we are already, at least when the products that we have already deployed, we are able to get it down to 3-4%, those remaining false positives.
Okay. Yeah. Okay. Thank you, sir.
Thank you.
May I ask a question?
Yeah, sure.
Sure.
Yes, wonderful presentation. I think the way to go for the future, it was an excellent presentation of all your material, and the slides, the way you spotlighted them and highlighted the calculation by the algorithm was excellent. I have two queries. One is, how do you calculate the error rate, and how did you bring it down to 2.5%? And the second question is, are your algorithms available for application across the board to other digital platforms? For example, if we use the website and access MindPeak for your immunohistochemistry AI platform, for example, either for Ki-67 or ER, how sure are you that it's going to work? Do we have to do anything else, do some specific processing, or what are your recommendations for that?
So maybe I would get to the second question first. In terms of recommendations, so far it has been mostly proven on in terms of the magnification on a 20x, and in the end, I think that refers to in the digitized environment, we often focus on microns per pixel or micrometers per pixel. That would mean that you have a resolution of 0.25 microns per pixel. So this is the magnification, the image settings where it actually performs best so far, and that we would always recommend of using. But there is at least a layer in the neural network that tries to tackle this by guessing. So if we don't have the information as to what magnification we are using, we have a layer that tries to guess it by itself. But again, using a magnification of 20x is definitely recommended. And of course, also having the best possible quality of tissue in your case to use for the analysis is also beneficial. But we are, I think, confident enough to say that it will work with acceptable accuracy on most, if not all, of the qualities that can be supplied in this case. So maybe only as a hard recommendation. So you can definitely use it and even try it out. And if you think that there's something maybe not perfectly working, it could even be helpful to get in touch with us so we can find out find out the reason for that. But I mean, as those deep learning or the neural networks were initially developed as driver assistants in the self-driving cars, here it's basically the same principle. It's used as a driving assistant. So our goal is not really to get rid of the pathologist, because we can strive to, but we can never really emulate so far the accuracy and all the experience that you as a professional bring to the table. So our goal is to be in the beginning a sort of like a driver assistant, like a assistant in your car that tells you, look at this area, this could be an area of interest, and maybe this is an example of a positive tumor cell, maybe this is an example of a negative tumor cell, to in the end make the diagnosis more quicker, especially in terms of the time you have to spend, because this is where a lot of the improvements can be done, tackling those charges. And now I've talked so much, I'm sorry, could you please pose the first question again? I would like
yes,
to...
how do you calculate the error rate, and how did you bring it down to 2.5%?
So this error rate that I showed on the slide, this is from a different network. This is historically at the time being one of the best neural networks available on this task, and how they were able to bring it down to 2.5%. This is an interesting question, because on the one hand, I can tell you that it heavily relies on the input data that you use, but also on the complexity of the neural network. So just as the brain gets more complex from a simple organism to a cat or dog and then to a human, also these neural networks kind of increase in complexity. They have more layers, they have more individual nodes that communicate with each other. So I think this is how they were able to bring it down. But then if you look in detail, there's this phenomenon called the black box. If you want to look in detail how the AI performed on the solution, it's really it's really hard to it kind of operates like a black box. So it kind of operates like a self-enclosed organism, like a network that we can help and guide along the right way. But all the individual decisions that lead to an improved example, we can try and abstract maybe. But it's very, very complex to actually decode as to what made it better and what not. I would have to ask one of our data scientists probably to answer that question best.
So maybe I can say something about it. Hi, my name's Felix. I'm one of the founders of MyPeak. And just to make clear again, this chart that had the decreasing error rate to 2.5% in the ImageNet dataset, that was not our software. So that was general. That was the general decrease of error of the AI community that reached it through application of deep learning. We only measure against pathologists, and in the case of the ring trial, in the German ring trial, there was a panel of pathologists, and we don't know the details, unfortunately, but it's for each lab the same. There's a panel of pathologists, and you send your slides in, your analyzed slides, the results of the slides, and it gets compared to this pathologist's panel, and it gets sorted into classes, and the classes are starting at 0%, that's class 1, and then depending on the tumor entity, smaller than 1%, and also the staining, I think that it's 1 to 10% in the ER and PR case, and 10 to, I'm not 100% sure, but it has at least different buckets, and we are trying to meet those buckets in this case. So that is how the test is performed. And this is our network, yeah, but not the ImageNet chart. And concerning your first question, when you use our online software, that is a research use only product that you can use to get assistance. And you cannot be 100% sure that what the network outputs is correct, because we cannot control what you put in. It's just too much possibility of variance that you put in. And so it's a little bit of self-serving, trying out yourself. This is different when we come to the whole slide imaging environment, where we set it up for you and where we control the data and make sure that there's a quality assurance on the data, and then also an improved result.
Thank you.
Thank you, Dr. Felix. Yeah, so are there any more clarifications or questions that could be asked to Dr. David?
Well,
from any other participants?
I've got a brief outlook question. So, you
Yes,
know, pathologists are very practical people, because pathology and practical begins with a P. And when I get a biopsy, I take a look at it, I take the immunohistochemical stains, and then I count in my mind, and then I write the score down. That's the usual routine. So, and my question is, could you outline a possible future implementation, just a tool, how to serve in the characteristical pathological setting? We've got a microscope, we've got a camera, we've got a data system. And how would you bridge this gap between the microscope camera, and a diagnostic data system that we are usually in our daily routine?
Felix, I would guess that, yeah, please.
Yeah, maybe you mean the gap to the laboratory information system, or which gap are you referring to, Dr. Lübke?
So right now, I can take a photo, I can put it on a USB stick, I can put it into my computer, and then I would do it by myself, but I think this is a very important gap between the microscope and the software. And we have a lot of different data systems in pathology, including patients' data and photographic data and microscope data. And because this, in my mind, is the most practical next step to make this a tool that you can use every day.
Right. So, I think one step is already solved, and that is if you connect your microscope's camera directly to the computer. And you see through the microscope camera, then you can directly grab that image and paste it into the website and read what comes out of it and copy that into the report. If you have it on the same computer, you could do a copy paste of the result on the left-hand side. And there's an extra window that shows the report in a way that you can copy paste it. And then you have some of the hurdles of this workflow gone. Any further integration, so if you want to have it even more fluent integrated in your workflow, it kind of requires then a whole slide setting, I would say. Yeah. Does that make sense to you?
Yeah, it bridges one gap, the gap between the microscope and the calculation, but you will never find a computer that is open accessible for you, and which is completely combined to your patient's data, because usually those two data systems are separated.
So you mean you have, so if you're using one computer, and in this computer you have for example, your laboratory information system open, then you could take from the browser the result and just copy paste it again into your other system. So that would be the way to work with it then, I would say.
One threshold is that the laboratory computer system has usually something like a firewall or security systems, but it's not possible to exchange patient data with the outside. So this is just a security threshold,
sure.
And it's very difficult to overcome this. So more practical would be just a tool which can be which harmonizes with your own data system.
So in the whole slide setting, everything is harmonized, of course. So everything is connected. You connect your image management system to the AI and to the laboratory information system, and via different APIs, information is exchanged. In this web browser session, there is the beauty of it is that there is no integration needed, that you can use it right away. And as long as you have both programs open on one PC, you don't need access to the laboratory information system and the patient data, as you're using all Windows tools like screenshotting and like copy and pasting. That only is a difficulty if you have two computers, of course. If you have two computers, one runs the laboratory information system and the other runs the website, then then you have this breach. But if it's on one computer, you can just use as described. You have a field in your laboratory information system where you usually write your report in, and you can just copy and paste text from somewhere else in it. The website doesn't access any patient data. It just receives an image from you that you grab somewhere else and upload.
Okay, well, maybe
try it out. I mean, maybe that's also then that explains itself maybe a little bit once you try it out.
Yeah, well, this will be the what would be the consequence. I would just try to open the browser in the laboratory system and see if it works. So that's what I will do.
Exactly.
I would actually post the link. I hope this works. I would post the link in the group chat because, of course, copying from the slide is a little bit difficult. So I hope you can use the link and see for yourself.
Thank you.
So are there any more participants who would like to clear their doubts? Any more clarifications or questions? We shall surely make a note of your link provided by Mr. David. Any more questions? So thank you, Mr. David and Mr. Felix, for putting your insights into today's topic, where most of them are unaware of, and we shall surely update ourselves. And thank you, sir, for generously volunteering to deliver your speech on this platform today.
Thank you for having us.
Thank you.
Yes, thank you for that opportunity. Thank you.
you.
Thank
So I think we had a really interesting and inspiring morning sessions today from different speakers from various parts of the world. And it was really nice to share the knowledge. And it's good to keep update ourselves of the recent advances that are happening in the field of pathology. And thank you, the audience, for a patient listening. And hopefully we are coming back after lunch, and I'm looking forward to see you all after the lunch break. So let's have a lunch break for now. Thank you.
thank you. Hello. Hello. Am I audible?
We can hear you.
Yes.
Yeah.
Okay. Okay. So, should we start the session, afternoon session?
Hi.
Sehr guter Zeitpunkt. Ja, fantastisch. Bis gleich. Tschüss.
Ist das gut?
Good afternoon to
Good afternoon.
everyone. Yes. So, we are resuming our session of sharing and learning our knowledge through our presentations. And I call upon our next speaker, the first speaker in the afternoon session. Without further waiting and ado, I shall call upon Dr. Lopa Mudra Kakoti from India. And her topic for today is significance of pattern of invasion in tongue squamous cell carcinoma in Northeast India Regional Cancer Center. It looks like a very interesting presentation. Looking forward to your presentation. The stage is all for you, Dr. Lopa. Dr. Lopa, I think I can't hear Dr. Lopa. Dr. Lopa, can you please unmute yourself? Dr. Lopa? Can you please unmute yourself so that all our speakers can hear you? Yes, Dr. Lopa, we can't hear you. Okay. You can restart and present after Dr. Beatrice. So since we are not able to hear Dr. Lopamudra Kakoti's audio, we shall move on to our next keynote speaker and get back to Dr. Lopa after Madam Beatrice Hornberg's speech. So I call upon our keynote speaker, Dr. Beatrice Hornberg from Brazil, for her extensive talk. Yes, madam, this stage is all for you.
Can I share my screen?
Yes, please do share your screen now, madam.
It's okay. Right. Everybody
Yes, your
see?
screen is visible and you are also audible. We can
Great.
start, madam.
Thank you very much. This is a great opportunity for me to speak with as a keynote, and I'm very thankful for all of that. And thank you for your patience for the next minutes. Actually, this is more as a sharing experience than actually a lecture. I believe that congresses are a great opportunity for us to share experiences, talk about ideas, and see what's next in our specialty. Well, I will talk a little bit about me. I am an anatomical pathologist. I live in Joinville, Santa Catarina, Brazil, and I own a laboratory called CDEP. It's anatomical pathology laboratory only. It's not clinical pathology. And it is a College of American laboratory accreditation program accredited for now 20 years. So we have significant experience in quality control this far. I am starting a consulting firm. It's startup, Starker Life. And I work with the Brazilian Society of Pathology as a member of the accreditation program. Actually, I was the author, and now these documents are really growing. It's really beautiful to see. We have around 53 labs subscribed to the program and 20 or something accredited. And I am also a leader inspector for CAP and the lab program and for the Brazilian program. I work also as an expert in quality pathology laboratory for City Cancer Challenge Foundation, which is sponsored, my part is sponsored by the American Society for Clinical Pathology. This is a very interesting foundation, and I will share a little bit about it later. So let's go on. Talking about challenges, right? Well, this is a great challenge. What? Horse rate? This is a pathology congress, right? Yes, but we will talk a little bit what happens in a racehorse. Anything can happen, and there is a huge investment. I believe in many countries there is it's something that's tradition, right? Well, let's go. Facts about horse races. As I told you, anything can happen and bring serious consequences. Like a horse can fall and broke a leg, a jockey can seriously be injured, and all of these have a great impact on the lives of the horse, the lives of the jockey, the lives of the teams, and everything. So, what about the race? Why we do that? We have to have a preparedness, a specific preparedness, like our laboratories. We have to have a preparedness for our exams. We have a trained personnel. We have facilities that must be well kept. We need information here about the race, about the teams, the other teams, the best horses in the tracks, and so on and so forth. The reason we do that, it's the investment we made. We made investment in the horse, in the team, everything. The adrenaline of the victory, the prize that we expect with it all. For us pathologists, the investment is also huge in training and everything. And the prize we have it's a mix of our income and also the rewarding of being pathologists, being able to help our patients. And the other good reason for having a horse team is the reproduction of the champion. And we as well want to reproduce our ideas, want to make a school of with other pathologists and keep our specialty growing. The result, we have an expectation, the prize, what would be the end of the race, and so on. Sometimes it's a huge work that we have to put in, And sometimes the reality is not the one that we expect. Something can happen. And also the future is unpredictable, but it's a challenge, as I told you. The life is a race, and we cannot control what happens in a horse race. However, we can control some of the outcomes of our cancer patients. The consequences, considering still the injuries in the horse race. We have an incidence of 13 events per 1,000 starts, resulting in 2.9 deaths. That would be 117 deaths in 544 events. Most of the injuries of bone, usually broken legs, tendons and ligaments, other soft tissues injuries, and respiratory injuries, mostly lung hemorrhage due to excessive workout during the race. And one curious fact is that 70% of bone injuries will lead the horse to horse death. It's really impactful on those races, and is a significant impact on the sport. However, we have cancer burden on society that it's much more, considering especially cervical cancer, which occurs in some countries as a first cause of death, and in a very age range of productive women, mothers, spouses, workers. So that's something we have to consider during all this. Okay, how can we control that? The race against cancer is really the one we pathologists must help our patients win. But it's really interesting because we are always very focused on our microscope, on our labs. But coming to an open vision of waiting times in cancer, as is a target of 62 days for the NHS in United Kingdom. This target must be reached, considering our side, by calling our doctors, because we pathologists have a huge data bank to allow us to reach the doctors. We must look out for our patients. Whenever calling the doctors fails, we look for our patient. This is really important. And ask for authority support. Here about cancer screening policies and complete patients' records and other equivalent documents in the health system. So having a waiting time from the time of diagnosis of the disease until the installment of treatment of 62 days would be really the ideal. However, in countries of the low and middle income in the world, this target is really difficult to achieve, mostly because some health systems are very, very fragmented, and also because logistics is very difficult for some countries. But considering the timeline of uterine cervix cancer, according to GlobalCan, the number of cervical cancer cases worldwide will increase, right? And it's clear by the timeline, this is a fact. This year, in some countries, the cervical cancer is the fourth cause of death. In some countries in LMIC, it's the first and second cause of death in women. By 2055, WHO, the World Health Organization, predicts that in the only developed countries, we will have we will have here 4 cases per 100,000 women. But in low-income countries, this rate will be approach around the end of the 21st century. So this is a long way to go. But talking a little bit about the active search of patients, which goal is decrease the cancer waiting times and decrease cancer incidence and deaths. So regarding the country, each country will set screening policies that will be the base for setting the lab LIS, Laboratory Information System. These policies obviously will vary from country to country and even within the same country. Like some regions will have one kind of policy and others will have another kind. The system. Set the laboratory information system to look for patients suspicious or confirmed cancer. This is automatic search, right? After detecting those patients, we will send message forms, emails, anything regarding those cases, and we will alert our doctors. And whenever doctors are not available to us, we need to try to reach at any cost the patients directly. But I will talk a little bit about that. How we do that? Okay, it's very difficult because all of us have a super full agenda, and actually we are really focused and concerned in release timely, accurate, and correct reports, right? This is really, we can see it as another burden, but actually, if you look at it as a quality control characteristic, you will have a very interesting database to work with along the way. I will show. So, active search of cancer patients. It's a method for screening patients with suspected or confirmed cancers. Using the LIS databank to monitor cases and alert the doctors of waiting times. It is based on local national policies for cancer screening. I did not detail this, policy here because it's something that it's national, but we can talk about that later in the presentation or after when you can ask questions. So during the last 5 years, we had in our laboratory an average of 80,000 cases of cervical cytology per year. So it's kind of a plateau here, right? But this year from January 1st to September 30, we had only 33,000 years. Here in this part, we will have around 6,500 cases per month. And this year we had half of it. So this is the effect of the pandemic in our laboratory, because most of the elective surgeries and the medical offices, clinics, and so they were closed for a long time here in Brazil. And also patients, they are not going to the offices, they are avoiding. And now we have a second wave of the COVID-19 in our city here, but in many parts of Brazil. I believe in Europe, there are another wave of COVID too. So the impact is really interesting to watch. At one point in our laboratory, we had 75% less of the exams that we usually have. The characteristic of our laboratory is that we assist half of the public system and half of the private system in my city, which is about 80% of all the population is assisted by our laboratory. So, considering the public and private system, we had a total of 598 cases in 2016, about 900 cases in 2017. 419 in 2018. And here is a very interesting observation too. We had almost 2,000 here, an increase that is really interesting because it usually is related to the kind of population that we are assisting. In 2019, we always have the October pink, which is, I believe it's in all of the world or some countries, at least here in South America. The October pink usually is a campaign that we alert women to seek for medical attention and to go to the medical services for their annual Pap smear. Here in Brazil, we still have more conventional cervical cytology, little bit of liquid-based, and very little of DNA HPV testing. And here is also a very interesting case because we have half of the cases and almost 3% of them are suspected or confirmed cancer cases. Probably because patients are delaying to the last minute to go to the doctors, and some patients will really have delay in their treatment, in their detection of disease. And another fact is that it's a personal opinion here. Because of the less cases that are going to health services, doctors and nurses have more time to examine more properly the patients. Here in the public system, we have a very heavy burden of the number of patients per day that can be and are attended by doctors. So sometimes the cases are really huge in number, with about 15 minutes sometimes per each case. So it's really, really less. This is just a reasoning here. Well, considering the Bethesda system category, what was the number of cases by each category? So 600,000 atypia of undetermined significance, squamous atypia, 82 cases only of glandular cell atypia. Here, squamous cell atypia cannot exclude high-grade intraepithelial squamous lesion. Here, low-grade squamous intraepithelial lesions, and here, high-grade squamous intraepithelial lesion or more. In this category, we have 612 cases of pure HSIL, 55 cases of invasive squamous cell carcinoma, and 40 cases of adenocarcinoma, with 31 with other kinds of neoplasia. So far we have very nice indicator about how our population behaves in terms of having of incidence of cancer, right? This is certainly will vary for according to the population. In the south of Brazil, we have more resources and more accessibility to the healthcare system by the patients. In regions like Northeast and North, it's very difficult for patients to access the health system. And also the health system is very fragmented. Here in the South, a little bit better than in the other regions. South and Southeast is really the most resourceful regions of the country. Okay, how we reach our doctors? After the system sorted out the patients that need to be monitored, we send this kind of form to the doctors, with the patient's name and a whole bunch of patients' identification, the diagnosis, and here this is a characteristic of of Brazil, because we have so many similar names and equal names actually, that the name of the mother is one indicator of unique identification of the patient. So this is a law here that in every form, every data, health data, we have to have the mother's name. Well, according then to the follow-up of the patient alternatives, we ask here the doctors to check one or two or more alternatives if applied. So whenever the test is going to another or went to another laboratory, we will ask if there was an accordance. If there was not an accordance with our diagnosis, we try to get information on what lab was the test sent and what was the diagnosis. Fortunately, here in my city, we have a very nice relationship with other pathologists, and it's really easy to get these other results. If the patient is already in clinical follow-up, but without an actual test, if the patient is already treating the disease, or if the doctor lost the follow-up of the patient. And then here we ask the phone number, at least the last phone number or address available to the doctor. Then he or she can write any other observation about the patient. The doctor's name, the sign, and the date. Here is really something that we like to go further, because it's really easy to stay in our lab and focus on our cases. But whenever we reach outside the lab, we can learn something new and reach more patients. So surprisingly, we have a very nice rate of doctor engagement in this program. In the last 5 years, we had 82.7% of forms returned to our lab and 70+.3 forms that were not returned. And we will explore this a little in a bit. Right. The index of cases solved due to clinical follow-up, due the form, right? The doctor responded the form and sent back to the laboratory. So this was more than 70% of cases, and 27% of cases we do not have a clinical follow-up. What this means that 25% of the cases were solved automatically by the laboratory information system. How? The system detected in a given span time another exam for the patient. That means that at least the doctor is following her up, right? It's something due to that. The other 2% of that 27 cases are the cases that we had to contact the patient directly. Considering the very start of the program here in our laboratory, that was in January 2000 to September 2020. So we have more than 1 million tests with 8,000 cases of suspected and diagnostic of cancer, more than 7,000 cytological atypia and low-grade intraepithelial lesions, high-grade and cancer. And here we had 33% solved automatically, like I explained before. 66.4 needed contact with the doctors with the active search form, and only 4% needed contact with patients. So this program is very effective. And the result is solving case, the rate of solved case from all this time is more than 90%. Some cases here probably are because the patients moved address and didn't return to any of the doctors available in our system, or change cities or countries. But how we engage doctors to return these forms? First, logistics. Every time we, here in Brazil, some regions, we have to collect cases and deliver reports in the clinics and hospitals and so on and so forth. So the logistics is provided by the laboratory. In some areas, the patients already take the specimens to their preferred lab. So logistics is one thing. The doctors do not have to worry about going after the patients, because we will deliver reports, and with the delivering of reports, some forms at a given office. Statistics. When having stats about their cases, the doctors like to have their historical or their cases sent to the same lab, which is good because we can really take care of the patients, right? And I will talk about it a little bit further. And another thing is shared responsibility. Doctors do not need to worry all the time when their patients will return or if their patients will return, because we will help them to monitor the cases. So we can put these three reasons to engage doctors to our program. But how about authorities to create cancer policies? Here is something that we have some trouble. First of all, we have to show them that the cost benefit of preventing cancer is cheaper than costly treatment. We already know that, but sometimes we need to show numbers, right? And another thing, dialogue. Technical approach combined with cost benefit, and try to open a door with authorities and dialogue with them about the need to create policies so that we can base our screening system. And the global perspective. WHO, the World Health Organization, Union International for Cancer Control, and City Cancer Challenge are some of the foundations that are really concerned with the future of non-communicable diseases globally. And these entities this foundation sometimes can gather external investments in some countries, and this will persuade authorities to create policies for screening and cancer treatment, right? So, continuing, cost benefit. Whenever an initiative is implemented, it has to have an increment of strategy rate complementation between less than 1 to 3 times the gross domestic product in a country. Whenever this extra money expended to implement a new strategy goes beyond this gross domestic product, probably it's not a good strategy, or it's not a viable strategy. Sometimes the strategy is really good. But what is really the cost of cancer? First, I will have to say that here in Brazil, as it is a huge country, we have already this fragmented system. Gathering data about the cost of cancer, about the cost of policies and so on is really, really difficult. Our system still do not have an integrated fashion so that the institution can share data. So that's something that you will see. It's very complicated together, but still, in one study from May 2014 to July 2016, where a microcosting study were made in one region, and here they use mathematical models to estimate the amount of burden or investment for the whole country. But we see here that the direct medical cost, and I will explore this a little bit later, is what is the heavy side of these expenditures. But what are the non-medical costs? In an interview, that would be two-way transportations for patients, food, and accommodations. Usually we have cancer centers that are reference centers for some regions, and then the patients have to go there from another city. So this location, accommodation, and food are expenditures that must be included in this situation that wouldn't otherwise be made by these patients. The indirect costs are related to human capital, which encloses number of non-working days per capita income, formal and informal jobs that these patients had. Here, they interview the patients to see if these patients, and in this study, would have formal or informal jobs. Social welfare and wages. So this would be the impact of cancer burden of the human capital. And an estimate annual cost per patient of $2,219 per patient, right, per year. It seems not a lot, but whenever you think in a population base of millions, that is a quite significant burden, right? Sorry. Talking about the direct medical cost, we will have here hospitalization, radiotherapy, outpatient chemotherapy, imaging studies, laboratory tests, and surgery. You see, laboratory tests are really non-significant considering all the expenses that cancer demands, right? And radiotherapy would be the most expensive in the treatment. This is for the perspective of the payer, right? What the public system are paying to the institutions that work for them, for the public system. And here, if you see the side of the institution itself, the cost is really bigger. And one thing here with the cost of chemotherapy and other resources, and here in Brazil, we have some, I don't know if the name would be in English, judicialization or something, that the patient recurred to the judge or the law system in order to get the treatment needed, like new drugs or such. And there is a huge, huge amount of money that is spent with these kind of patients. It's something about $5,000 million in this kind of burden. So 1 year of invasive cervical carcinoma treatment for the Brazilian population covered only by the public healthcare system, which is the Sistema Único de Saúde, is the acronym in Portuguese for the healthcare system, which assists 75% of the total population, would be 25 million, almost $26 million. And another interesting fact is the low and middle income countries will nowadays have almost 90%, 85% of the global population, and will have 61.3 new cancer cases globally. However, it will only spend 60.2% in financials with cancer. So this count here, this sum will never go to the end for the poor countries or the low and middle income countries. But what about the cost of prevention? Here, another thing is that it's difficult to calculate the burden of treatment and the cost or investment, so to speak, in prevention, because there are not official studies about that, only segmented studies in some regions, in some institutions. Still, the PEP test here in Brazil is the one that predominates face the other kinds of tests. Still, we have, it's already an implemented program having screening by PEP tests, and the cost per test would be $11, almost $12. The cost per case would be per year would be $6,207, and it's negative here because this is the whole cost of the initiative when it costs that per year, and there is no reason to consider this an increment once it is already implemented. However, liquid-based cytology needs an increment of $10,150, almost to $200. HPV DNA test would be hybrid capture, which is better in sensitivity and better in accuracy, although more expensive and will have a huge impact. PEP tests and DNA tests showed here in our country to be 97% sensitivity and 0.8 accuracy, and here it's a reasonable amount of incremental in the system. So we still see that even if it is in 1 year for 10,000 women, the long-term gains of this kind of testing will be better in due time, in middle and for, so to speak, long and middle term price terms of evolution of cancer cases. What about the cost of the active search per year? This is also an estimate that we have. We had to have 20 hours programming, and really it costs here in 1 year, and then the maintenance and something like that would be $352. We have, because of the system is totally automated, we have only 24 hours per year of our quality managed to collect the data and coordinate the distribution of forms with our collecting and delivering samples and report system. And it costs, this hour cost 1,600 reais. And the 24 hours deliveries, as well as papering and so on, so far almost $1,000, and the cost would be around $3,000. And here is because the logistics that we have is already implemented. So the active search cost is really, really low incremental to our system, right? Okay. But how we can dialogue with our authorities and show it all? Okay, we already know the costs. We have to open the doors. How we do that? With local medical association, with community councils, political association, we try to gather people and see the benefits and the costs of cancer and cancer prevention, and so on and so forth. Sometimes it works better in the local aspect than in the country aspect, but it's needed. Global perspective, returning here to the investment. How can these foundations help? Well, WHO has a global plan in turning cervical cancer a rare disease and is gathering fundings in order to do that. So it's one thing. Another thing, UICC also can gather fundings for cancer research and control and invest in countries and in worthy initiatives. And here I will talk a little bit about the City Cancer Challenge Foundation, which is actually a spin of the UICC. It was created within the UICC because the proposal here was to try to control cancer in a more local expert. So City Cancer, or CCAN, manages to create strategies to approach political and technical parties to the same table and help to develop sustainable cancer control initiatives at cities level. Like today, I believe CCAN has around 10 cities. The 4 key learning cities were Asunción in Paraguay, Cali in Colombia, Yangon in Myanmar, and Kumasi in Ghana. I work with the team in Asunción, and regarding the political aspect, Paraguay did not have a cancer policy written until 2018, so until 2 years ago. And another gain was that we could, working with the laboratories closely and trying to approach with the authorities to implement a regulation in order to provide a uniformity of working within the lab. So to guarantee a minimum of quality control for these labs in Asunción and diminishing of the turnaround time, of the time for release the report. So this here can be a huge force in assisting and helping our authorities to implement cancer policies. But considering that we cannot reach them, they won't open the door to us. The system, the active search of patients, like I described to you, is politician proof. It will work regardless of the policies, because still we can use the TBS system to make the categories, and we can still use international waiting times as the one reference for our establishing of criteria for automatization of the search. Okay, but what is the game for pathology laboratories? Here is something that I believe everyone is very curious about. Legal safety. This is one thing that I will share with you. Years ago, we had a legal suit for one patient that felt that herself was unassisted by her doctor and by the health system. So she sued her doctors, she sued our laboratory, and we would have to pay a legal amount of money in order to set an agreement. But when we had our hearing with the judge and our technical director, Dr. Bacilli, which was one of the person that idealized this active search, he explained all the program to the judge, and the judge immediately ruled us out of the whole suit. So it was only for the doctor. So this can really save a lot of money and a lot of headache. Another thing, quality systems, laboratory systems that work with quality control can improve that earnings in 2 ways. One, improving processes and diminishing costs, right? Another, sharing costs with other entities and trying to show the importance of quality control for insurance companies. And we already have one or two policies here in Brazil that pays a little bit more to laboratories that have established quality control systems. Benchmarking within laboratories is very important. Like what we are doing here, we can do with our laboratories in our countries, in our cities, and try to make things better for everyone. Another thing is interlaboratory networking, and I will explode this a little bit. What is important to have an interlaboratory, or the advantage to have an interlaboratory networking? To have external quality control. How? Today, we have some government, some health system that demands for proficiency testing. It's very expensive to have regular proficiency testing in some settings, right? Especially in low-income countries. So what we propose here is that laboratories can share samples and diagnoses. So you send your specimens to another lab without the diagnosis. The labs read the slides and provides their diagnosis, and then we compare and see what are the discrepancies and why they had occurred. And then set trainings or whatever is necessary in order to improve the laboratory. Another thing is vocational specializations and test directions. What does that mean? Some laboratories are run by 2 or 3 pathologists that sometimes receive very little, for instance, hematopathology cases. So if we have a network of laboratories, we can send these cases to a partner laboratory and have them accurately read instead of losing time studying something that we are not very familiar with. And on the other hand, the other laboratory can send cases to us for the same reason. And especially in these days that digital pathology is evolving so quickly, is very interesting to do that and very feasible. Sorry. Another thing, vacancy coverings. Sometimes laboratories will have, as I told you, 1 or 2 pathologists, and when one of them are on vacation, his vacation, and the network can cover that. Contingency plans, broken appliances, lack of human resources. So you understand, we can interchange resources and make a better work of what we have. And another thing is create a body of negotiations with suppliers for better prices and for insurance companies for better payment. So it's very interesting, the advantage that we can here. So we are competitors, yes, but we can compete in a friendly manner and even potentialize our capacities. We are only 1% of pathologists considering all the other specialties worldwide. Cancer cases are increasing. We are extremely needed. So we need to find innovative ways to work with partnerships, to work with colleagues in order to improve our performance and deliver the needed care to our patients. So we have actually the key to start the change. We are almost done here. These are the take-home messages that I believe it's worth sharing. So considering all the results we have, the pathology laboratory is a key element regarding the care for cancer patients. Yeah, we have the screening, right? We have the analytical phase when we have the delivering of our diagnosis and reports. And also we have the post-analytical phase when we already delivered our reports, but we are still monitoring patients in order to detect them for their treatment when needed. Well, and since the lab has the basic data of patients and diagnosis, it's important to use these resources to reach the patients suspected of cancer and also to share it with authorities. So specific policies can be made regarding local aspects. Considering that the rate of suspicious cases are really low compared to the total of tests of a given lab, there are many ways to carry out this initiative. It can be manual or by phone or automated. You can all have a spreadsheet and read the spreadsheet and set aside the case every month. So there's many ways that we can implement this. However, the role of the governments at any level represented by the health and sanitary authority or equivalent health surveillance system or sort is to ensure that all relevant data are completed in the medical records, in the health system records, that the other doctors that send samples to us they have the conscience to complete the medical request properly. It's, I don't know, probably this is a huge aspect in many countries, not only here in Brazil. And so lab can act properly and really fast with more efficacy regarding the contact of patients. And another step to this system is to insert other types of tests and criteria. For instance, if we have first biopsies with a cancer diagnosis and no other test, positive tests of like breast cancer, prostate, gastrointestinal, other, whatever, we can set the criteria and make it a post-analytical aspect of our care for our patients and go after them. So I really think that is, as a race horse is a challenge, and we know that a horse can really cost between $1,000 and $35 million, we have to consider some facts about human lives. That anything can happen, yes, and bring consequences. However, we have the power or some power of control some facts of life by preventing disease. And the price of a horse is huge. But what to say the price of a human life, a mother, a spouse, a worker? So I believe we have here our share of commitment to help these patients and to decrease the cancer burden and doing our share of responsibility. Thank you for your patience. And please, if you want, I'm free for questions.
Thank you so much, Dr. Beatrice Hornberg, on enlightening us and giving us excellent coverage on this vast cost effectiveness of preventing cancer topic, and making us or making all the speakers, participants in this program even understand to that level of laboratory safety and all the measures that can be taken. And I had got a lot of inputs as well after listening to your, I'm sure that the other participants also would have got their inputs as well. It was a well-detailed and systematic organized presentation with good statistic figures as well, madam. And I have also liked the way that the cost of prevention, the cost benefits, and the cost of active search per year has made a lot of difference on reducing or cutting down the number of cancer patients, which other countries can also follow the same concept like your country is following. And so with this, I would like to open the talk, the speech. If anyone else would like to add and ask some questions to Dr. Beatrice Hornberg, madam, yes, it is open for others to ask questions, please. Anyone who is interested. I don't see any messages in the chat room as to anybody wanting to ask any questions.
Okay.
That was a wonderful speech once again. Thank you so much, Dr. Beatrice, ma'am.
Thank you. It was an honor to share this experience. And really, this networking of laboratories is something that's maybe a topic, but I believe will bring many advantage to all of us as pathology, because working better, working united, will really makes us stronger and better health providers, so to speak.
Yes.
Thank you very much. Yes.
Thank you. A stronger community, a pathology community, it would be.
Yeah, I believe in that.
Okay, madam. Thank you so much. And yes, anybody else to ask questions? As of now, I don't see anybody wanting to ask any questions. So I would like to call upon our next speaker, Dr. Lopamudra Kakoti from India. Yes, the podium is all yours.
Good evening and good afternoon. Am I audible?
Yes, you're audible. You can share your screen as well.
Thank you. Sorry for my technical trouble.
Yes, your screen is visible, Dr. Lopa. You can go ahead.
Okay. So I'm Dr. Lopamudra from the assistant professor at Dr. B. Borua Cancer Institute, which is a regional cancer center in Northeast India, Assam. And I'm going to present my small pilot study, Significance of Pattern of Invasion in Cancer, a pilot study in tongue cancers. As we all know that invasion and metastasis are the hallmarks of cancer, both being intimately related process. And pattern of invasion refers to the manner in which cancer infiltrates tissue at the tumor host interface. Pattern of invasion, it got clinical significance other than depicting the malignancy, is that they prognosticate the cancer disease process. And for decades, it has been debated and discussed about the pattern of invasions because it might give inputs to the clinical decision making and treatment decision making. But lastly or lately, it has been gaining its focus when the term epithelial mesenchymal transition has been put forward by E.D. Hay in 1995. What is epithelial mesenchymal transition? This refers to the mechanism whereby tumor cells detach from the main mass and gain motility. This process involves various molecular and cellular mechanisms, broadly defining reduction or complete loss of intracellular adhesion molecules, ultimately gain of function of motility, enabling structural proteins. So this is a schematic diagram I have taken from article by Mr. M. Bryan, where he is showing the different molecular mechanisms happening at the infiltrative edge, like increased proliferation, increased cell migration and angiogenesis, whereas decreased cell-cell adhesions or differentiation at the infiltrative edge cells. And there are random immune responses going around to ultimately evade from the immune response by the tumor cells. Based on this complex molecular and morphological studies, two types of tumor cell migrations have been found: collective or group migrations and single or individual cell migrations. Collective or group cell migration is nothing but when group of cells interconnected by adhesion molecules move freely into stroma, whereas single cell migration, single cell moves into stroma. In the again, these single cell migration are divided into amoeboid and mesenchymal. Migration type depends on the tissue microenvironment and molecular changes in the tumor cells. Single cell migrations in the mesenchymal type cells acquire mesenchymal property of fibroblast-like cells, and they transform themselves into like a spindle cells. Amoeboid movement, amoeboid type of movement is the most primitive and the efficient migration cell pattern when the other migration patterns has been blocked or inhibited. This movement is seen, this amoeboid movement is seen mainly in the circulating tumor cells, and it is not appreciated in the histomorphology. Collective or group migrations has been recently gaining more importance as the terminology has been described as tumor budding, where tumor cells acquire different or distinct patterns like tubular, acinar, trabecular, strips, solid, or even in singles. Based on this molecular idea, researchers have been studying the edge of the tumor, and specific patterns have been described in different tumors, particularly in those arising from the prostate, bladder, head and neck, endometrium, or colon. Even there are several scoring system has been also validated in based on these patterns in different specific organ specific cancers. Most studies have correlated the pattern of invasion with risk of metastasis in regional lymph nodes in the early stages of the cancer. There is a, it is worthwhile mentioning that there is a strong correlation between infiltrating tumor edge and resistance to therapy. It is said that tumor cells in the infiltrating edge are not dividing, rather they are transforming into mesenchymal cells by acquiring some of the mesenchymal property. This collective type of tumor migrations renders the tumor cells chemo insensitive and radios resistance. The underlying molecular changes lend credence to these observations. Ultimately, the main observation is leading cells at the infiltrating edge express anti-apoptotic genes and also induce synthesis of ABC family protein responsible for efflux of chemotherapeutic drugs out of the cells. So with this molecular idea, we like to see the significance of pattern of invasion in head and neck cancers. As we know that squamous cell carcinoma is the most common cancers in the head and neck regions. And as per the Globocant, it stood the second most common cancers, and India, especially the Northeast India, has beared the most of the bulk of the tumor from the head and neck region. So this is the this most common cancers, though this is the most common cancers, but there has been many factors which is determining the treatment properties, and actually the outcome of the disease is not same for the same stage of the patient. So people have tried to stratify this common cancers into low risk and high risk groups, especially in the early stage. So this attempts has been started or introduced since 1920, when Broders have tried to formulate grading for based on the whole tumor morphology into well, moderate, or poorly differentiated. But because of its poor prognostic value and lack of reproducibility, underscoring the need for more complex grading systems. So with this evolutions, the important milestones comes when M. Bryan has started speaking about the, instead of grading whole tumor morphology, we can concentrate on grading of invasive cell edge because it carries the more prognosis and helps in determining the treatment. Bryan has formulated multifactorial parameter where pattern of invasion is one of them, and he has described 4 patterns. I'll be describing in the later stage. And along with, after a few years, Bransween-Jansler, he has introduced one more pattern along with the other 4 patterns which has been described by the Bryan. So overall 4 patterns has been identified. So with the evolution, these are the few articles of old 1992, 1989. So from this evolution till today, when AJCC or CAP or International Collaboration of Cancer Reporting Dataset describes pattern of invasion 3 types: cohesive, non-cohesive, dispersed pattern of invasion. Cohesive is defined as the broad sheets of cancer cells or tumor nest more than 15 cells, whereas non-cohesives are group of cells or fewer than 15 cells, or even in single infiltrating tumor cells. The various multifactorial grading systems as described by Branswin, Bryans, Almangush, or Jacobson, etc., they are based basically on these parameters: nuclear pleomorphism, mitotic index, lymphocytic response, tumor growth pattern, tumor thickness, degree of keratinization, depth of invasion, and pattern of invasion. There was ultimately a general agreement is that most useful prognostic information can be deduced from the invasive front of the tumor, where the deepest and presumably most aggressive cells reside. So based on this basic idea, we plan to study the prognostic significance of pattern of invasion and other pathological parameters in oral tongue squamous cell carcinoma.
Dr. Lopa, can I interrupt you? Can you please go a little bit slower?
Okay, ma'am. Okay.
A bit slower, because the participants need to understand every word that you speak.
Okay.
Thank you.
Should I go back? Should I go back?
Yes, if you can restart, or just at least from the second to third slide, you can go a bit slower.
Okay. So I have been talking about the pattern of invasion. It started with the concept of epithelial mesenchymal. It started gaining the importance when the concept of epithelial mesenchymal transition has been put forward by E.D. Haley in 1995. So epithelial mesenchymal transition refers to the mechanism whereby tumor cells detach from the main mass and gain motility. This process involves various molecular and cellular mechanisms, ultimately to make the cells complete loss of intracellular adhesion molecules and gain of function of motility enabling structural proteins. So this is a schematic diagram taken from M. Bryan, which has depicted the several types of events going at the infiltrating age: increased proliferation, decreased differentiation, decreased cell-cell adhesion, increased cell migrating molecules, increased proteolysis, and increased angiogenesis. And immune response also play a good role. Ultimately, the tumor cells try to evade from the immune response. Based on this complex molecular and morphological studies, two types of tumor cell has been found: collective or group migration, single or individual cell migration. Collecting or group migration is when the group of cells interconnected by adhesion molecules moves, whereas single cell migrations when individual cell migrate freely through the stroma. Ultimately, migration type depends on tissue microenvironment and molecular changes in tumor cells. So here the picture depicting single cell and migration and collective or group cell migration. Single cells again divided into amoeboid and mesenchymal. So mesenchymal type is a single cell is single cell migration, where single cell can acquire either mesenchymal type or amoeboid movement. Mesenchymal type movement migrations where tumor cells acquire the property of mesenchymal cells like fibroblast-like cells, so they can transform into a spindle cell-like morphology. Whereas amoeboid movement is the most primitive and efficient migration pattern, and this is the last resort for tumor cells to migrate when the other methods of migration have been inhibited or blocked. This movement is seen mainly in the circulating tumor cells, this amoeboid movement, and is not appreciated in histomorphology. Collecting or group migration has been gaining popularity when a term tumor budding has been assigned to describe this collecting migration pattern. Tumor cells in this collective migration pattern acquire different shapes like tubular, acinar, trabecular, strips, solid or in single. Based on this molecular idea, researchers have been studying the infiltrative edge of tumor, and the specific patterns has been described in many tumors like prostate, bladder, head and neck, endometrium or colon. Several scoring systems also have been validated. on these patterns in different organ-specific cancers, as we know that is in Gleason pattern in prostate. Most studies have correlated the pattern of invasion with risk of metastasis in regional lymph nodes in many of the cancers. And there is a strong relationship found between the infiltrating tumor edge and resistance to therapy also. It is said that, hypothesized that tumor cells in the infiltrating edge are not dividing, rather they're transforming into mesenchymal cells by acquiring mesenchymal property. This collective type of tumor migration renders the tumor cells chemoinsensitive and radioresistant. The underlying molecular changes lend credence to these observations. The leading cells at the infiltrative edge express anti-apoptotic genes and also induce synthesis of ABC family protein responsible for efflux of chemotherapeutic drugs out of the cells. So with this basic idea of how the cell migrate, we want to see the invasion significance of pattern of invasion in head and neck cancers. Head and neck cancers, squamous cell is the most common ones. As the Globocon says, it is the second most common cancers worldwide. And India, especially the Northeast India, bears the most bulk of the cancer is from head and neck areas, head and neck squamous cell carcinoma. And it is seen that in head and neck cancers, it is the most common this thing, there is not much evolution of prognostic factors in the head and neck cancers, and there is a study in the Korean papers where it is said that in the same stage, especially the early stage cancers, a few subset of patients show a good prognosis, whereas some set of patients come with a recurrence in very early stages where no adjuvant therapy is required. So in that case, when they have gone and seen, again reviewed the slides, they understood that pattern of those recurrent cases, pattern of invasion was worst pattern. And that pattern of invasions, those who has come in the recurrence, they have showed those worst patterns. Actually, they are supposed to be added on the adjuvant treatment instead of only surgery. So there has been many attempts since decade to prognosticate the disease. It started since 1920 when brooders tried to prognosticate the squamous cell carcinoma based on the grading of differentiation into well, moderate, or poorly differentiation based on the whole tumor morphology. But because of the poor reproducibility and poor prognostic value, it was not accepted, or it did not gain much popularity. And there was slow evaluation of in this area. But at one more important milestone is during 1989 or 91, when Brian M. et al. Has found that instead of grading whole morphology of the tumor, if you grade at invasive cell edge cells, it will carry a more prognostic significance and it will help in the treatment decision making. Brian's have formulated multifactorial scoring system, and those scoring systems I'll be showing in the next slides, where he has included pattern of invasion is one of the factor for deciding the prognosis of the patient. So he has described 4 patterns. In the long run, after a few years, Branswin Gansler, he has introduced one more type added on the Brian's 4 patterns. So overall, totally 4 patterns has been described in the past. So Brian's have described, these are the 4 formula: degree of keratinization, nuclear polymorphism, number of mitosis, pattern of invasion, lymphoplasmacytic infiltrate. Pattern of invasion, he has given pushing, well differentiated infiltrating tumor, and infiltrating solid. Type 2 is infiltrating solid cords, bands, or strands. Type 3 is small groups or cords of infiltrating cells more than 15. And type 4 is marked or widespread cellular dissociation in small groups or in single cell less than 15 cells. So since 1920, there is a slow evolution in the pattern of invasion, and ultimately now AJCC, CAP, or even the International Cancer Collaboration Reporting data set describe 3 patterns of invasion. They are cohesive, non-cohesive, and dispersed. Cohesive is defined broad sheets of tumor cells or tumor nest more than 15 cells across, whereas non-cohesive is tumor cells fewer than 15 cells or single infiltrating tumor cells. Dispersed is when individual cells more than 1 millimeter from the main tumor. The various multifactorial, which I have already described, Brines have introduced, like similar to Brines, Branswin, Gansler, Elmans, Anort, Jacobson, etc. et al. Also describe several multifactorial grading systems. The based on these parameters: nuclear pleomorphism, mitotic index, lymphocytic response, tumor growth pattern, tumor thickness, degree of keratinization, depth of invasion, and pattern of invasion. There was general agreement that the most useful prognostic information can be deduced from the invasive front of the tumor, where the deepest and presumably more aggressive cells reside. Based on this basic idea or background, we wanted to do a pilot study to see the prognostic significance of pattern of invasion and other pathological parameters, especially depth of invasion, perineural invasion, lymph node status in oral tongue squamous cell carcinoma. So our study was a retrospective one, and we have archived paraffin embedded blocks from 80 patients with oral tongue squamous cell carcinoma, search between January 2015 to December 2017. We included all primary tongue cancer cases, and we excluded any patients receiving preoperative chemo or radiotherapy, residual and recurrent cases. All sections were taken from surgical resected specimen, not the true cut ones. All the blocks, all slides were taken, and hematoxylin and eosin stain were used to study the morphology of the tumor by two qualified pathologists using the same microscope without any prior knowledge of each patient's clinical details. A set of criteria has been formulated as follows. All the sections of the tumor were evaluated microscopically by two pathologists. Maximum depth of infiltration was calculated microscopically under 40x and would be taken for consideration. The pattern of invasion was taken for consideration in the section of maximum depth of thickness at its infiltrating edge, following the criteria set by Branswin, Gansler et al. Under high power. Extratumoral angiolymphatic invasion, as mentioned in the CAP guidelines, was not taken into consideration as WPO of 5 in this study. When the opinions of the two evaluators differed, selecting the sections or maximum depth of invasion, consensus was reached by discussion. Tumor differentiation grading was done using Brodler's grading, like well differentiated, moderately, and poorly differentiated. Variables like depth of invasion, lymph node infiltration, and perineural invasion and pattern of invasion were evaluated. Depth of invasion was measured from the base of the normal epithelium to the deepest point of invasive tumor edge. Tumor pattern of invasion, we followed Branswin Gansler's. I have already showed. Brines has described this 4 pattern: pushing, finger-like, large separate islands, more than 15 cell island. Type 4 is small tumor island, 15 cells or fewer per island. Type 5 is tumor satellite, when more than 1 millimeter from the main tumor or next closest satellite. There are a few pictures from our patients. This is the pattern 2. Pattern type 2 pattern, a finger-like pushing pattern. This is the type 3, islands of tumor at the periphery, larger than 15 cell island. These are the pattern 4, where we could see tumor strands or small clusters or single or islands composed of 15 cells or less. Pattern 5 is when tumor satellite is present more than 1 millimeter, more than equal to 1 millimeter apart from the main mass. Statistical analysis was done. Frequency tables of demographic and clinico-pathological parameters were established. Kaplan-Meier plot was constructed to show the survival outcomes and compared using long rank test. P-value less than 0.5 was considered to be statistically significant. From our result, our mean age group was 40, and we have seen more than 80% of the patients were above 40 years. We saw male preponderance over female with a ratio of 2.5:1. Mean follow-up period was 35 months, ranging from 1 to 60 months. Out of the 80 patients, 18 patients died of oral tongue cancers because of the recurrence, whereas 40 were alive at the end of the follow-up period, while remaining 22 patients were lost to follow-up. While assessing the grading, we have found maximum 85% of the cases of our cases were well differentiated, 12% were almost moderately, and 2.5% were poorly differentiated. We have divided the tumor depth of infiltration into 3 groups: less than equal to 5, more than 5 to 10 millimeter, and more than 10 millimeter. And we found maximum of our cases fall into this 5 to 10 millimeter group. Amongst the different patterns we have seen, most commonly is pattern 3, that is almost around 50%, followed by pattern 2 in 32%, pattern 4 13%, and the least pattern was pattern 5. Pattern 1 was not seen in our study. Most patients were in stage 2, followed by stage 3 and 4. Least common was stage 1. Perineural invasion and lymph node metastasis were seen in 38.7%, where recurrence occurred in 22.5% of the patients. The overall survival of the patients in our patients of oral tongue squamous cell carcinoma at the end of 1 year, 3 and 5 year was 90%, 92.9%, 58.5 to 50.5% respectively. Depth of infiltration, perineural invasion, nodal metastasis, and pattern of invasion correlate well with the overall survival in patients with oral tongue squamous cell carcinoma. However, no statistical significance was seen. When compared pattern of invasion with other parameters, there is an inverse relation between a pattern of invasion with tumor stage and recurrence. However, it did not show strong statistical association. When we compared pattern of invasion with other parameters, we found a strong statistical significant association between pattern of invasion with perineural infiltration and lymph node metastasis. So we tried to assess the effectiveness of pattern of invasion and other clinical pathological parameter predicting mortality and prognostic significance. When we have seen that our patients' overall survival started decreasing from the 1st year to 5th year, almost 5 years. So the similar finding was a similar reduction in 5-year survival has been reported by Spiro et al. In their study. We did not find any statistically significant relationship amongst the depth of infiltration, pattern of invasion, lymph node metastasis, and perineural invasion with the patient survival. But in the literature, studies have shown there is a good significant prognostic value of depth of infiltration and pattern of invasion. We did not get it statistically significant, maybe because our study has a small sample size, and in literature, most of the studies have included the early stage T1 and T2, but we have included almost all the stages T1 to T4. Most of the cases in the present study were well differentiated, and no association of differentiation with the was found. Similar findings were observed by Nadef et al., and they concluded that 5 patterns of invasion could serve as an individual prognostic marker irrespective of histologic differentiation of the tumor. Different patterns of invasion have been reported for squamous cell carcinoma of different sites like skin, head and neck, and uterine cervical SCC. However, whatever the pattern, the high-grade dissociated tumor cells at the invasive front has been reported to be a prognostic value for different types of cancers. Several studies have previously confirmed that the relationship of unfavorable pattern of invasion with poor prognosis in oral squamous cell carcinoma. Brian's have already, I've already mentioned, Brian have found that instead of grading the whole tumor, invasive front tumor grading is more important. in study by Hirima et al. Showed that pattern of invasion is an independent factor in low stage of oral squamous cell. NADAF also have found 5 pattern of invasion could serve as an individual prognostic marker in the histologic differentiation of the tumor. Almangas et al. Has also found tumor budding or depth of invasion and worst pattern of invasion were evaluated and significant correlation prognostic implications in early stages of tongue cancers. In our study, it was observed that recurrence was, excuse me, recurrence was most common in pattern 3 followed by pattern 4, and there were no recurrences in pattern 2. We have very less cases of pattern 5, and most of the pattern 5 cases were lost to follow up. There was inverse relationship between POI, pattern of invasion, with tumor stage and recurrence, but no statistical association was found, probably because of the smaller size and many of the patients of highest pattern of invasion being lost to follow up. Similarly, similar to our study, Monterio LS et al. Reported that pattern of spread in oral cancer show little or no relation to clinical stages presentation. Another study by Odell et al. Also showed that prognostic significance of invasive front grading and close correlation between pattern of invasion and metastasis, as well as recurrence of the disease, supporting our study also. We have found that lymph node metastasis and perineural infiltration has strong correlation with worse pattern of invasion, and it was statistically significant. PNI was most commonly seen in 66.7% cases of pattern 5, followed by
Dr. Lopa,
Yes.
Dr. Lopa, if I may excuse you, you need to finish your presentation. This is the time for you to be finishing it. This is the time we can allot for your presentation. And if you can add a few more lines to be winded up quickly.
Yeah, it is the last slide. This is
I
the
can
last
give
slide.
you 1 more minute for this.
Okay. Several studies also support the association between pattern of invasion and lymph node metastasis. However, we have not found any studies showing association of PNI with pattern of invasion. Hence, we feel the need for further studies to substantiate this strong association. Ultimately, to conclude, we observed that most aggressive cells of the tumor reside at the invasive front of the tumor and show poor prognosis. And present study concluded that pattern of invasion 4 and 5 is significantly associated with number of lymph node mets and perineural infiltration. Hence, it can be used as an independent histopathologic prognostic parameter in oral squamous cell tongue cancers. Finally, further tumor-specific studies are needed to offer more future insights into the nuances of the pattern of invasion in solid tumors and their clinical implications. Thank you.
Okay, so thank you so much, Dr. Lopa. And that was a wonderful work that you had done on your pilot study in tongue, and to assess the pattern of invasion, and about whatever findings that you have come across. The findings that you had come across through your study had enlightened and emphasized on many more points that we can look for as well in our daily practice. Thank you so much, Dr. Lopa. And yes, the podium is open for any questions. If any participants would like to ask any questions, you're free to ask Dr. Lopa. Yes, any questions? As of now, I don't see any questions in the chat room as well. And so, having said this, I would call upon our next keynote speaker, Professor Shala Masood from United States of America, and her wonderful topic on breast pathology. Yes, Professor Shala Masood, can we have you? Are
Okay, can you hear me?
Yes, we can hear you. Yes.
Great. Do you have my slides?
No.
Okay.
You need to share the screen.
Okay, we will do that.
Yeah. Yes, we can see the presentation right now, and we can also hear you.
Great.
You can go on.
All right, thank you for inviting me to this wonderful conference. And what I'm going to do today is talk about borderline breast disease, an entity to minimize errors in overdiagnosis of low-grade ductal carcinoma in situ in breast pathology. So the concept is, and the plan is, to highlight the challenges associated with diagnosis of atypical proliferative lesions in breast pathology, and to discuss the critical need for changing trend in diagnosis and management of these entities. So I'd like to start with the question of why there is such an emphasis on atypical proliferative breast lesions these days. And the reason is very simple. Screening mammography and image-detected biopsy have increased the diagnosis of atypical proliferative breast lesions and ductal carcinoma in situ. A majority of the lesions these days are being detected by screening mammography or other breast imaging. And along the line of that, localizing devices have been practically used very frequently, and they end up to provide us with these small, little tiny fragments of core needle biopsy, where we can make the morphologic diagnosis of cancer. And of course, there are sufficient amount of material that we can use to assess the status of breast biomarkers, such as estrogen and progesterone receptors, HER2 oncogene, as well as Ki67. So the trend of the diagnosis has changed, and the way that we are really diagnosing lesions have become different. The facts that we need to remember is that the distinction between atypical ductal hyperplasia and low-grade DCIS has remained a diagnostic challenge. And this problem commonly leads to overdiagnosis and overtreatment. And when that happens, naturally, there are more expenses as well as there are more patient anxiety. And we will talk about that in length over examples of the cases. And there's also evidence these days that's suggesting that low-grade ductal carcinoma in situ may not need cancer therapy. And that is an interesting concept, it's still controversial, but something to keep in mind. Now, let me begin with the story of atypical ductal hyperplasia. Where have we come from? We know that women who have a history of benign breast disease experience higher incidence of breast cancer. And fibrocystic change includes the spectrum of changes ranging from physiologic alterations all the way to features that approximate that of in situ lesions. And of course, previously, all of these entities were collectively called so-called fibrocystic disease. And this naturally, resulted in a concept that started with the very highly cited study by Dr. Dupont and Page in 1985. What these investigators did, they went ahead and looked at retrospectively all the cases on surgical biopsy that has been called fibrocystic change. And then what they did, they classified them based on the morphological features seen in each entity, and they provided us with a new way of diagnosing benign breast disease, meaning that the entire concept of fibrocystic change practically consisted of non-proliferative breast disease, proliferative breast disease without atypia, and proliferative breast disease with atypia. And these are the entities that practically sort of compromise of the diagnosis that is being made as non-proliferative breast disease. Cyst, mild hyperplasia, simple fibroadenoma, papillary apocrine changes, Proliferative breast disease without atypia consisted of complex fibroadenoma, moderate florid hyperplasia, florid disclosing adenosis, and intradactyl papilloma. And proliferative breast disease with atypia were including atypical ductal hyperplasia, atypical lobular hyperplasia, hagitoid extension to extralobular duct, radical scar with atypia, and multiple papilloma syndrome. Therefore, this classification brought a sort of different spectrum of changes and sort of changed the pattern of how we diagnose cases these days in breast pathology. The term fibrocystic disease was basically abandoned, and the term of fibrocystic condition or fibrocystic change practically replaced the old terminology of fibrocystic disease. You know, along the line of that, what they did was, they look at this subtype of benign breast disease, and they looked at the incidence of the occurrence of this entity with relative risk for subsequent development of breast cancer. And they also included family history as a part of the process of, talking, and considering these as another risk factor. The incidence of this benign breast disease fundamentally was predominantly non-proliferative breast disease. And then there is still relative risk is very small, even in the presence of the family history. Proliferative breast disease without atypia are those incidences are slightly less than non-proliferative breast disease, and they have a slightly increased risk, especially if it's associated with family history. The area that became more and more important to really discuss was proliferative disease with atypia. The incidence was small. The relative risk was large, especially if it was associated with family history of breast cancer. And naturally, these incidences right now are very different because these incidences were based on surgical biopsies. Right now, naturally, predominantly, all of these components are done on corneal biopsy, and they are image-detected biopsy concept. So we are seeing more and more of these proliferative breast disease with atypia versus low-grade ductal carcinoma in situ. Therefore, this study showed that intraepithelial neoplasia fundamentally is considered as a morphologic risk factor. And then when you really look at the concept of the continuation of the features from non-proliferative breast disease to hyperplasia, atypia, and in situ lesion, as is demonstrated in here, basically what we are looking at the balance between proliferation and apoptosis. And therefore, in that scenario, relative risk is 1 is in non-proliferative lesions. However, when we look at ER and KR67, we can see that as the epithelial proliferation increases, getting to the status of ER, you can see that the incidence of ER expression is slightly lower, and the degree of proliferation is higher, which it is stated in here. And then there is that imbalance of the proliferation and apoptosis in areas when it gets to atypia and in situ lesion, and that leads to subsequent increase in the relative risk of subsequent breast disease. So that is the history of what we have observed and where are we right now with proliferative breast disease, particularly atypical ductal hyperplasia. Now, what I want to do, I want to spend a small amount of time to talk about morphologically, what are we talking about? When we are talking about non-proliferative breast disease, naturally, morphologically, you're dealing with cyst formation, apochromatoplasia, and some stromal sclerosis. By cytopathology, that we have really described the cytomorphology of these lesions and have developed a Massoud cytology index that distinguishes this concept very clearly for those that are interested. Non-proliferative breast disease by cytology practically manifests itself as clusters of epithelial cells. Some of them, they have apocrine differentiation, as you can see it in here. And the other component, you can see these very nicely situated epithelial cells with no atypia, and it is intermingled with myoepithelial cells. These myoepithelial cells are slender, darker, and they are within the epithelial cells as well as in the periphery of these cells. And therefore, this is just example of a non-proliferative breast disease. Proliferative breast disease without atypia shows a little different picture. What we have in here, you have, breast biopsy, you have these ductal elements, you see proliferation of epithelial cells sort of crossing the line. We have cyst formation, and of course, there's always some degree of stromal sclerosis. By cytopathology, you see that that honeycomb pattern that I just discussed and described and showed it to you is really has changed a little bit. There is a little bit disarray in the way that the cells are reacting to each other. However, the most important things is the presence of myoepithelial cell, as you can see it in here, with epithelial cells. You can see it more in here. Epithelial cells are larger, they're oval-shaped, and they are lighter compared to myoepithelial cells that they are slender, darker, and they're sort of intermingled within epithelial cells as well as in the periphery of the ductal system. And therefore, with that concept, when we look at something like this in cytopathology, that is naturally is a reflection of a proliferative breast disease without atypia. Now, proliferative breast disease with atypia or ADH is sort of different story. You see the proliferation of epithelial cells, and you can see the almost monotonous appearance of these epithelial cells. However, in some areas, you can see the spindle cells. So this is a sort of a transition of atypical ductal hyperplasia, probably, or proliferative breast disease into possibly a low-grade DCIS. In cytopathology, you can see a very high level of proliferation, and you see overriding of the nuclei. They're practically sort of living on the top of each other, on the shoulder of each other. And then there is some degree of lack of anisonucleus, lack of polarity. There is some anisonucleosis here and there. And then you still can see these myoepithelial cells. Now, what about low-grade ductal carcinoma in situ? Can we really diagnose these accurately? The low-grade ductal carcinoma in situ, when you really look at it, you see a distended duct. You see a monotonous appearance of these epithelial cell. You really don't see much of myoepithelial cell around. And you can see this very well-defined lacunae that is a reflection of, in this case, cribriform pattern. When you look at cytomorphology, and if you can use your imagination, you practically see the same thing. These are the epithelial cells. They are monotonous in appearance. If you can see this cribriform pattern that you see in here. And these slides are really produced by a study that I did, and I practically compared the cytomorphology of non-palpable image-detected biopsies by fine needle aspiration biopsy followed with needle localization excisional biopsy of the same site, so that we would be able to really compare the results very effectively. Now, after all of these conversation that we have had, when we look at the literature and the study or the understanding that we have as of now, after all of these years, is the definition of atypical ductal hyperplasia. And that is an entity which has some, but not all the features of low nuclear grade ductal carcinoma in situ. And you can see that this definition by itself opens the way for significant degree of interobserver variability, because everyone is going to be practically interpreting this concept differently. Now, what is in the literature in respect to the definition of low-grade ductal carcinoma in situ. The two individuals that they have contributed to provide a sort of a guideline, provide a system in which this can be diagnosed are Dr. Page and Anderson and Dr. Tavassoli and Norris. And Dr. Page indicates that in order to call something low-grade ductal carcinoma in situ, you have two ductal spaces completely effaced in a single terminal ductal lobular unit. They have to have monomorphic population. They have to have non-polarized epithelium, cribriform bridges without attenuation, and the uniform lacunar spaces as you see it in here. Now, Dr. Tavassoli and Norris, they practically say the same thing in a different fashion. They bring the quantitation of less than or equivalent of 2 millimeter as the cutting point between calling something atypical ductal hyperplasia versus low-grade ductal carcinoma in situ. Now, naturally, these criteria had been there. They had been based on surgical samples and not really corneal biopsies that right now we are sort of working with. And this concept become polarized with the very unbelievably cited and controversial study of Dr. Rosai, who was one of the best surgical pathologists in our time. And then what he did, he sort of questioned and brought the concept of inter-observer variability between these two entities. He provided no standardized criteria, sent 10 cases to 5 so-called breast pathologists. And when the diagnosis was asked for, this is the result of that study. The number of pathologists in exact agreement and on percentage of the cases, you can see there is no agreement between the groups. 4 or 5 agreed in 20% of the cases, and 3 out of 5 agreed in 50% of the cases. So naturally, that wasn't something very promising for anybody really consider as something to really remember. Then Dr. Schneid and his colleagues, they did it a little differently. They did the same study. They provided a standardized criteria of Page. They increased the number of cases to 24. They increased the number of pathologists from 5 to 6. And then they looked at the agreement. And in this agreement, even they show some progress. Again, 6 people agreed in 58% of cases. 5 of 6 agreed in 71, and 4 out of 5 agreed in 92% of the cases. And you can clearly understand that even with this agreement, you cannot possibly try to sell the fact that we know what we are doing, given the fact that no one, no industry, no criteria in the world would accept 50% accuracy in what you do, in what you really report and expect people to follow your sort of course of event in relation to the patient care. So this naturally has stayed and remained to be a problem. Now, lately, there was another study with Dr. Ellimore, and in this scenario, once again, all of these studies are associated with their own shortcomings, but anyhow, in this study, which was almost a few years ago, she conducted a study to assess the degree of agreement among expert breast pathologists and general pathologists. She brought the set of 60 breast biopsies, which were about 240 total cases, 1 slide per case, and then she reported that the concordance rate of diagnostic interpretation of participating pathologies was 75.3%, with highest level of concordance seen for invasive cancer, and lower level of concordance was seen for DCIS and atypia. And once again, this is not something that is very satisfying in respect to the choice of therapy and follow-up for the patients. We did a study to try to see that if morphologically we are not sure as what to call an atypical proliferative change in breast biopsy, could biomarker help us at any point. We selected 100 cases, 25 of each category, and then we subjected the biopsies to assessment of BCL2, ER, PR, DNA ploidy, KR67, HER2 oncogene, and P53, and assessed the pattern of expression of these entities. And again, it was very interesting observation because we realized that the pattern of expression of high-grade breast lesions naturally were very different. These high-grade DCIS cases, they are ER and PR negative, HER2 oncogene positive, P53 positive, aneuploid, and they have high proliferation rate. Whereas low-grade ductal carcinoma in situ, they were ER and PR positive, HER2 negative, KR67, low proliferation rate, and then they didn't have any P53 expression. And interestingly, the pattern of expression of atypical ductal hyperplasias versus low-grade DCIS were practically identical. Intermediate grade, they had a sort of a mixed match of this entity. Therefore, it was very clear to us that, biomarker studies, as we have it, they don't really help us to try to make that distinction between atypical ductal hyperplasia and low-grade DCIS. So the issue that we raised at that point was, is it possible that atypical ductal hyperplasia and low-grade ductal carcinoma in situ are in reality representing the spectrum of the same entity? And this is a question that has been on board for a while, and a lot of other investigators, they have looked at this. And because of that, a different kind of, sort of interpretation or even terminology was proposed. And these are the suggested terminologies. Intraepithelial mammary neoplasia was suggested by Dr. Rosai in 1990s. Ductal intraepithelial neoplasia was suggested by Dr. Tavassoli. Low nuclear grade breast neoplasia family was suggested by European breast pathologists. And we have offered the term of borderline breast disease to try to recognize the difficulty between the distinction of atypical ductal hyperplasia and low-grade ductal carcinoma in situ, particularly in core needle biopsies, and try to offer the fact that these are the cases that you do total surgical excision of the lesion and then better define the extent and the entire characteristic of the breast lesion. And we'll talk about that a little later. So none of these entities right now are things that they are universally accepted and universally done. And everybody sort of pretty much uses the terminology that they would prefer to do. Within our institution, borderline breast disease is a known entity, is recognized by our oncologists and surgeons, and they know exactly what do we mean when we put this one as our diagnosis. And when you really look at the literature and try to really understand where are we with this distinction, again, quoting from Dr. Rosen, who is one of the most unbelievable authority in breast pathology, this is what he states in respect to the distinction between atypical ductal hyperplasia versus DCIS. This is his quote. There is no consensus presently on the criteria that should be adopted and how they should be applied for the distinction between atypical ductal hyperplasia and carcinoma in situ. He sort of follows and talks about that morphological criteria for the diagnosis of ATPL, implying increased breast cancer risk, and in situ carcinoma may be improved when it is possible to relate proliferative lesions to specific genetic or biochemical marker. And of course, we know that at this point, we are not close to finding that magic marker to try to really be able to really use that as an entity to make that distinction. Now, I want to just sort of bring a sort of a different concept to your attention, and that is the fact that this distinction is not something that is relates to the intelligence or ability of the pathologist. I mean, naturally, we are highly trained, highly qualified people that we can follow the criteria and we can make the distinction. However, there are entities that remains as a diagnostic challenge. And the diagnostic challenge between these two entities has been recognized not only in fine needle aspiration biopsy, but in core needle biopsy as well as surgical biopsy. And the way that I look at this entity, this spectrum of changes that we see, is just like a photography. For a good photography to really happen, you not only need to have a good photographer, a good camera, good light, you also need to have a good subject. And this is a subject that we don't really know enough to be able to really make that distinction with 100% accuracy. So let me provide you with the story of a patient. And this story of a patient is something that is being seen in every breast pathology practices, and this is not really unique to this story. This is just reflecting what we really see these days. This was a self-referred, newly diagnosed breast cancer patient who was scheduled to undergo mastectomy and lymph node dissection. And we're talking about almost 10 years ago. The patient was 23-year-old with no risk factors and discovered the mass when she was showering. The breast mass was sampled by core needle biopsy, was diagnosed as an invasive cancer. A palpable lymph node was found and was assumed to represent a lymph node metastasis. The patient was advised to have mastectomy and axillary dissection followed by chemotherapy. So when the patient called and wanted to see me and look at this case for a second opinion very late in the afternoon, where she had the biopsy the next day, naturally I asked for slides to be delivered to me in order to be able to look at it. And this is the core biopsy. And we can see these proliferative changes in here. You can have a collection of, proliferating cells in different areas. You can see very crowded, small gland formation in these areas. And this is what it was called as invasive moderately differentiated ductal carcinoma and low-grade ductal carcinoma in situ. And of course, when I looked at this, the concept that it came to my mind that this small gland formation and a stromal component is more reflection of the adenosis concept, and you see a little bit of more lobular structure of the breast lesion that still is preserved. So I had my dot in this case, and I asked for tissue blocks, and I asked the patient to, for time being, cancel the surgery for the next day until we are through with assessment of this core needle biopsy. And this is the view of the core needle biopsy. You can see it again, it's very crowded, small gland formation in here. You can see these glands very nicely in here. And when we did calponin, and you can do any kind of myoepithelial cell marker, you can see the unbelievable expression of myoepithelial cell marker in a variety of different components of this biopsy, meaning the epithelial cells. And that is reflection of the fact that you're dealing with not a malignant cases. And myoepithelial cells are supporting cells of breast epithelial and ductal epithelial cells. And in a non-neoplastic process, they do not participate in the process of that proliferation and increase, presence of the epithelial cells. When malignancy occurs, the supporting cells would just practically do not participate, and they will just leave the scene. That's the reason we do not see them in neoplastic process of the breast. So fundamentally, what we asked was the fact that let's go ahead and totally surgically excise the entire mass and see what we are dealing with. And this is exactly what happened. And this is reflection of this entity. You can see naturally they are proliferating. There are a lot of glands with various sizes that they are apparent in here. Once again, the myoepithelial cell marker defined that as a proliferative lesion. Basically, that looked like an apocrine adenosis to us. And what we did at the same time, we went ahead and did fine needle aspiration biopsy of the lymph node, which didn't show any evidence of metastatic disease. So when we discussed this with the pathologist who was involved with this case, he practically said, well, why don't we just send it out for consultation with some other people that they're not involved with the case. And I agreed with that. And I even said that I'm going to send it to 2 different breast pathologists, one in East, one in West Coast, and practically see what do they call this, with no history and no other information. We received 2 different diagnoses. One was atypical apocrine adenosis with sclerosis and associated fluorescence diagnosis. The other one is low-grade apocrine ductal carcinoma in situ with focal sclerosis, preductal and radial, involving multiple cores. So as you can see, naturally, we are sort of dealing with 2 different entities in here. So when we look at the whole experience and the patient's experience within a very short period of time, we have put the patient in the roller coaster of having been diagnosed with invasive cancer, predominantly metastatic breast cancer, to in situ lesion to atypia and leading to a benign conclusion. And therefore, we needed to sit down with the patient and try to explain to her how this happens. And again, with that concept, I brought our radiation oncologists and surgeons and the patient and us, and we sat down and talked about that very freely, very openly. And in that scenario, she made a decision to just undergo surveillance. Let us examine you every 6 months or a year, do imaging and see what happens. The patient didn't have any history of breast cancer in the family. Therefore, we were a little bit more comfortable with that. And we tried to get her out of the media and not really make a big deal out of it. However, she was a part of the media, and then she went and studied these cases. And then, one day she came and said that is enough, it's 8 years, and I have been doing all of these, everything that you have told me. I'm fine, I have married, I have 2 children, and I want to bring this story on light. And she went and worked with people in New York Times, and actually they went and found other breast cancer patients that actually have been diagnosed with DCIS when they have gone to another institution for, reassessment. They have found out that they really do not have ductal carcinoma in situ. And in that setting at that time, the patients with ductal carcinoma in situ, they went to cancer therapy of excision or mastectomy, or for that matter, sentinel node biopsy. This was the story sometimes in a few years ago, and I was sort of interviewed with that. And in that scenario, naturally, my concern was the fact that we have a problem in respect to making this distinction accurately. And in many ways, it's just like flipping a coin as we are doing it. And naturally, that wasn't a very politically right statement to make. But this is really the truth of the matter as we speak at this point, that these diagnoses and the diagnosis of ductal carcinoma in situ is something that is casually made, and this is something that we have to pay attention to. So the question that is worth asking is, whose fault it is? Are we overdiagnosing breast cancer? Are we doing what we need to do? And one of the reasons that is difficult to really answer that question is because answering this question requires a long prospective study. Prospective study of the cases that they have this atypical proliferative breast disease. And we ask the patients that we do not excise it, we do not do anything with it, we'll just follow you for 10, 17, 20 years and see what happens to you. And patients really don't stand for that. The patients want, if there is a concern in their breast, they want that out. Therefore, having a prospective study to answer the natural history of progression of these breast cancer precursors to a full-blown invasive cancer is very difficult to do, and it hasn't been done. In a variety of ways, everything that we had is a retrospective assessment and a speculation rather than the true assessment of what we have. Now, along the line of that problem, naturally, with genomics and genetic markers, these are the tools that we have, that there are a lot of people that are working on it, but still, as I indicated, as of now, based on my knowledge, we really do not have that magic marker. Now, this is a story of the practice of breast pathology. Days after days, we have corneal biopsies, and we are confronting with lesions that naturally you see the evidence of proliferation in variety of different form, shape, magnitude, and then partial, complete, And these are the cases that they go from one office to another one. We want to know what they are. Is it just columnar cell change with microcalcification? Is it just lobular neoplasia? I mean, what are these, apocrine hyperplastic papillary overgrowth in here? So what do they mean? And then these are more example of the same things. You can see the degree of proliferation and extension of the proliferative changes in variety of different form and shape. And yet you see this lobular pattern that sort of stays within the confines of the breast units, which may help to some degree to try to be careful not to call these cancer. Now, what do we have in respect to, do we have any tool to help us with that? The only thing that we have right now is high molecular weight cytokeratin 5 and 6 that distinguishes between florid ductal hyperplasia and versus ADH and low-grade ductal carcinoma in situ. So it doesn't really help us in making that distinction, but it helps us to try to distinguish a variety of different florid ductal hyperplasia that naturally exist and provide some diagnostic difficulty. And then we have ecadherin that would give us the way to differentiate lobular lesions versus ductal lesions. So that is all we have right now in a routine practice of breast pathology. Now, this is just an example of cytokeratin 5 and 6. You have a lesion, you have proliferation. Again, look at the lobular pattern, cyst formation, and then you have proliferation in here. Naturally, is it florid ductal hyperplasia or is it something more? And you can see such a nice mosaic pattern of cytokeratin 5 and 6 that will help us to be comfortable that we are not dealing with a morphologic risk factor, we are not dealing with ADH or low-grade ductal carcinoma in situ. On the other hand, this is another case. You have this epithelial proliferation. They have started to have this almost look like a cribriform pattern with some micropapillary lesion in here. And then you can look at the cytokeratin and you can see this area that it doesn't really have that mosaic pattern. So the decision of whether to call this low-grade DCIS or atypical ductal hyperplasia, again, really sort of follows the rule of that 2 millimeter or, 2 ductal, units to be involved. And when in a core needle biopsy, we see just a small one microscopic focus of that, we try to really stay away from really calling it DCIS. We call it borderline breast disease and ask them to remove the entire lesion and let us take a look at all of the issues that is associated with that. Now, when we look at the current status of the practice of breast pathology and look at the diagnoses that are made in core needle biopsies and look at the literature reporting increased rate of malignancy upon excision, you can see in all of these categories, ADH, DCIS, flat ATP, or lobular neoplasia, there is a sort of upgrade of the lesion either to higher in situ lesion or low-grade DCIS or the invasive cancer. So in this process, the concept of suggesting, and we make that in our pathology report to alert our surgeons and clinicians that this patient needs a follow-up surgical excision. So let me start to talk about why that distinction is clinically important. When we call something atypical ductal hyperplasia, we are implying that we are dealing with a morphologic risk factor. It indicates increased risk to both breasts. It is not a precursor for invasive breast cancer and do not need cancer therapy. And that's a huge statement to make. When we talk about ductal carcinoma in situ, it may be a direct precursor to invasive cancer. Rate of invasive transformation is dependent on the grade, and risk of invasion is limited to ipsilateral breast and generally same quadrant at the same site. So the site matters in cases of ductal carcinoma in situ. High-grade lesions are often associated with unfavorable biological markers. Genetic alterations, and loss of heterozygosity at various chromosome loci differ according to the CIS pattern and grade. Low-grade lesions are associated with the low nuclear grade breast neoplasia family. And this is a very important really consideration to make given the morphologic similarities and genomic abnormalities reported that they all fall in the same category. Now, ductal carcinoma in situ is a heterogeneous disease characterized by neoplastic proliferation of ductal epithelial cells with no evidence of stromal invasion. And you can see this is a low-grade ductal carcinoma in situ. You have microcalcification. It's a high-grade ductal carcinoma in situ with necrosis and calcification. Now, the determinant of the biology of ductal carcinoma in situ depends on architectural pattern, nuclear grade, and presence or absence of necrosis. And this is a sort of a garden variety of features that we see in ductal carcinoma in situ. Low-grade lesion, cribriform type, micropapillary type in here. This is another low-grade lesion. We can see the monomorphous appearance and the uniqueness of this cribriform pattern, very regular. You can see ductal carcinoma in situ with necrosis, or this also can be a lobular carcinoma in situ with central necrosis that we have to do eCategory to make that distinction. You have micropapillary, DCIS, and so on and so forth. Why is it important to even make this pattern as a part of the process of reporting that micropapillary DCIS has been recognized, or micropapillary carcinoma of the breast, they have lost their adhesion molecule and they are associated with bilaterality, multifocality, and there are lesions that if it is diagnosed, especially if it's multifocal, maybe consideration should be given to a mastectomy so that we can reduce the chance of recurrence and coming back with patients that ultimately undergo mastectomy. So these determinants are important for us, and these are the ones that naturally we need to report in our breast pathology report. Now, when we look at ductal carcinoma in situ, and what are the treatment options? Local wide excision with and without radiation therapy and mastectomy, these are the treatment options that has been associated with what we are calling is a ductal carcinoma. Therefore, atypical ductal hyperplasia versus low-grade ductal carcinoma, and that distinction is very important. There are truly two different entities that we need to really make sure that they are being diagnosed accurately. Now, I want to bring you to a very important study that it was reported a few years ago by Dr. Narod. And this individual designed a study to estimate 10 to 20 years mortality rate from breast cancer following the diagnosis of DCIS and standard cancer therapy. This observational study used the information registered in the SEER database from over 100,000 women. So it was a very well-studied concept. What he reported was that the risk of dying from breast cancer in these patients was about 3.3%. And this is something that is pretty much very similar to what the general population of mortality is, so it wasn't really significant. At 20 years, this risk was higher for the following patients: younger patient, before age 40, Black ethnicity, high-grade ductal carcinoma in situ, larger size, more than 5 centimeters, ER negative status, HER2 positive status. And these are the patients that they are high-risk ductal carcinoma in situ that they require naturally cancer therapy. So the issue in the question after this study was, do the patients with low-grade DCIS need to undergo cancer therapy? And do we need to abandon the use of the term carcinoma for lesions that may not be biologically malignant? This study or this question still is on the board, and whoever would find a reasonable response to that are going to be very welcome to really participate in the process of expressing their opinion. Dr. Esserman is one of those individuals that sort of shares the same concept with us, and that is what she says. Current data suggests that low-grade DCIS should be considered a risk factor for invasive breast cancer and an opportunity for targeted prevention, meaning hormone therapy. Radiation therapy should not be routinely offered after lumpectomy for DCIS lesions that are not high risk because it does not affect mortality. She goes on and suggests that we should continue to better understand the biological characteristics of the high-risk DCIS, large, high-grade, hormone receptor negative, HER2 positive, especially in very young and African-American women, and test targeted approaches to reduce death from breast cancer. So this is the way that right now is the status of the distinction between DCIS and atypical ductal hyperplasia. I'm going to spend just a few minutes to talk about these issues associated with the current challenges associated with the practice of breast pathology are the issues that we need to pay attention to. Currently, diversity, the issues that we have is the diversity in tissues handling, processing, and reporting is significant. We have insufficient evidence-based correlation between morphology and the patient outcome, significant inter-observer variability in diagnosis and test result, and communication barriers among physicians involved in breast care. A lot of patients that they have their biopsies in imaging centers and they send it to a variety of the commercial laboratories, the communication between pathologists and radiologists is practically lost. There are no uniform guidelines to measure the rate of our diagnostic errors. Error or fear of disclosure and medical legal issues limit the report of diagnostic errors. There are many lookalikes in breast pathology that can mimic cancer. Breast pathology is considered as a component of general surgical pathology, and breast pathology fellowships are not accredited by ACGME. Believe me, I have tried very hard. If you recall, I have established the International Society of Breast Pathology and actually the first breast pathology in the world, simply because I think breast pathology is a very unique experience for the pathologists to become involved in really planning of the therapy for patients. And that's a very good way of trying to participate as a clinical partner in care. And of course, as I mentioned, referral pathology samples to commercial laboratories impairs communication. To acknowledge the challenges associated with the current practice of pathology is very important, and that is our suggestion. And we need to design studies that can appropriately analyze the problems and quantitate their impact on the therapy, patient outcome, and health economy. We suggest that we need to continue to look at the establishment of quality assurance measures, whether they're internal quality measures, by consensus slot conferences, mandatory second review of cancer cases, mandatory adherence to established criteria, or the use of second opinion. The review of outside pathology slides and reports by a local pathologist before the initiation of cancer therapy is really something that we routinely do in our institution. And of course, we have to get into the involvement in external quality assurance measures if they are present. Just give you an example of some of the very small reports in the literature that they talk about the rate of discrepancy when the cases have gone for second opinion. You can see the rate of significant discrepancies ranges between 10 to 20%. So we're really looking at the issue that we need to recognize the significance of it. This is another study that Dr. Newman reported in cancer that they looked at review of both imaging as well as pathology in their tumor conferences, and based on those interpretive changes, you can see the change in the surgical management, 16% by imaging and 9% by pathology. So second opinion is a very important concept in breast pathology. So what do we suggest? We suggest to abandon the term of low-grade ductal carcinoma in situ totally, use the term of borderline breast disease, completely remove the entire lesion, and offer risk assessment and risk reduction options to the patients. Offer the option of wait and watch for borderline lesions or low-grade DCI is similar to what is being done to low-grade prostate cancer. The impact of what we are talking about is reduce anxiety to the patient and family, minimizing unnecessary expenses, and restoring the patient trust that we know what we are doing. And again, this is not an easy process, but I want to remind you of Dr. Hageson many years ago, who ultimately was able to convince the colleagues that let's put put atypical lobular hyperplasia and lobular carcinoma in situ together and use the term of lobular neoplasia and define the varieties such as plumoric lobular carcinoma that they're a little different, and try to make sure that they indicate and they review and then consider lobular neoplasia as a morphologic risk factors, not a cancer that requires therapy. If you recall, a lot of women in the past, they have undergone bilateral mastectomy because of the diagnosis of foci of lobular carcinoma in situ. We practically need to start looking at low-grade ductal carcinoma in situ as an entity that we can do better than call it cancer and produce anxiety and really discomfort and really compromise patient care. And we need to better define the morphologic and biologic characteristic of a spectrum of high-risk proliferative and precursor breast lesions and change the concept, terminology, and the pattern of practice. And of course, that brings me to the last slide of mine, and that is the recognition of the fact that over 1.1 million women are diagnosed with breast cancer each year across the globe. Even if you look at the lowest estimated diagnostic error in breast pathology to be 2%, it appears that a significant number of women will receive under or over treatment. And we need to really bring some measures and sensitivity and appreciation and acknowledgement that we do not have that magic marker yet. And we better be careful anytime that we are going to designate and give a patient a diagnosis of cancer, because it has significant financial, psychological, and family issues that is associated with this cancer. As you know, there are countries in the world that if a woman is diagnosed with breast cancer, that means that the husband can leave that woman. The girls from that family are not going to be really looked at as a good partner in their life, and they lose their opportunity of marrying the other people. So there are a lot of issues associated with that I don't have time to go into that, but please be careful anytime that you want to make the diagnosis of low-grade ductal carcinoma in a patient, and try to look at other alternatives that you can be sure of what is it that you are labeling a patient with. And of course, this concept, this change in terminology is not really going to happen with one person. This really requires an integrated, multidisciplinary team efforts among the people that are interested in well-being of patients with breast cancer. And they're interested in the women health collectively to try to be careful as how do we diagnose, how do we communicate, and how we educate our physicians and also our patients in respect to the lesions that they carry, and make sure that nobody really get into the status of anxiety and make an impulsive decision about going ahead and divorcing their breast by bilateral mastectomies that is becoming a very increasing incidence all over the world. And with that, I thank you for the opportunity, and I hope that I had delivered a message that would be of use for you in your practice. And have a great night or day wherever you are living at the moment. And thank you again.
Thank you so much, Dr. Shala Masood. That was a wonderful speech, and this study once again highlights the commitment and dedication to breast pathology from your end, and it has also shown and highlighted various other aspects like retrospective assessment of breast pathology can make a difference to our diagnosis, and how it helps in choosing the treatment modalities as well. and how the current challenges associated with practice of breast pathology and the issues were mentioned in your presentation. Thank you so much for a wonderful talk, Dr. Shala Masood. Anyone who has questions for Dr. Shala Masood, the platform is open for the questions. Anybody who wants to ask questions? Yes, the platform is open. And Dr. Alvaro has thanked Dr. Masood for a clear conference.
Thank you. Thank you. Have a great day and a great night, all of you. Take care.
Thank you.
Bye.
Bye. So can I expect any questions from anyone? Is anybody having any questions?
Only a small comment, please. I really appreciate a lot the conference of Dr. Masood because emphasize the multidisciplinary study needed in face the breast pathology. The confidence in a multidisciplinary team with the specialists in radiologists, the good clinicians and pathologists, it's very important in this area. Thank you so much.
Thank you.
Thank you, Dr. Alvaro, for your valuable suggestion and feedback. So I shall close the platform for questions, and now I shall call upon our next speaker, Dr. Michael Retzky from United States of America. Yes, Dr. Michael, you can share your screen.
Yes, hello everyone. Thank you for inviting me to speak at this conference. I am going to discuss a research project that's been going on for a very long time, at least 25 years. I'll discuss all that. I have a PhD in experimental physics. I am currently at the Harvard School of Public Health, and I am shortly to switch to Beth Israel Deaconess Medical Center, another Harvard university. Okay, this project was funded by NIH and the Komen Foundation. I have patents pending, and most of what I'm going to discuss is issued. Most of what I'm going to discuss is covered in this paper that I published with my colleagues last year, and I wanted to show you the co-authors in this paper. Dema Kelly is an MD, PhD. Bill Rashevsky is a medical oncologist. Ted James is a breast surgeon. Rick Rogers is a scientist in imaging. Michael Baum is a breast surgeon, retired breast surgeon. Jan Vieta, another breast surgeon. Asaro Erhabor is a laboratory scientist from Nigeria. Patrice Forget is an anesthesiologist. He was in Belgium, he is now in Scotland. So there's a wide variety of scientific and medical knowledge presented here. I published a book. I edited a book that was published by Springer. This is 3 years ago. It was published, but they pretty much ignored it. And then a few weeks ago, it got a lot of attention, and they advertised it on the front page of the New York Times the week after the presidential election. So I guess I'm getting a lot more attention than I was 3 years ago. Okay, this project started in 1993. I was attending a breast cancer research study in Europe, 1993, and there were two databases presented. One of them was from Italy, Romano Demicheli from Milan, and Michael Baum from UK. They were each discussing a bimodal relapse pattern in breast cancer data. I'll show you this in detail, but for starters, it's 1,173 early stage patients with no chemotherapy, just mastectomy only. There was a sharp peak at 18 months and a minimum at about 50 months. And then it started up again with a broad peak at 60 or 70 months, with a long tail extending to over 10 years. This has now been identified in 21 databases from US, Europe, and Asia. There are more than 21, but I stopped counting them. Okay, these are the Milan data for postmenopausal patients presented in relapse hazard. Relapse hazard is the probability of patient undergoing a relapse in a 3-month window if they enter that period relapse-free. So relapse hazard of 0.02 means that 2% of the patients who are disease-free at that period of time had a relapse in the next 3 months. So you can see there's a sharp peak at about 18 months, then a minimum about 4 years, and then this broad shallow peak starts up at 5 years and goes on to past 10 years. We're not sure what that 100-month minor peak is. It could be noise or it could be important. Okay, that's the postmenopausal patients. These are the same thing for the premenopausal patients. And what you see is that first peak now seems to show structure. There's a 10-month event and a 30-month event. Everything else is about the same. And by the way, these Milan data, I have a lot of experience with breast cancer databases, and I trust these data. And it's mainly because of one person, the database manager for the project for this data since its inception, Benucci of Alagusa was the person. Okay, these are the same Milan data, but shown in the more traditional disease-free survival format. This was presented in the New England Journal, 1995. And what you see here is all patients are disease-free at time 0. And then there's a rapid drop-off, and it seems to reach a plateau at about 5 years. And then it seems to start up again. It's sort of like a little ski jump. That's not an anomaly. That's the change in the early relapses and the late relapses that we see in the Milan data. Demicheli and I got together afterwards. We decided to collaborate. And my background is in experimental physics. I have a PhD in physics from the University of Chicago, and I was pretty competent in the use of computer simulation to study cancer growth. So this describes our collaboration. I was going to take the Milan database, the Bonadonna-Valagusa database, and Demicheli's model. Demicheli has an MD PhD. He did a lot of work in analysis of animal model tumor growth. He said that the simplest description of tumor growth is that it starts off as a single cell and it can stay dormant for a variable period of time. Once it starts to divide, it gets to be an avascular micromet, and it can stay at that level for a variable period of time, and then all of a sudden angiogenesis occurs and it grow up to be a detectable tumor and a lethal tumor. So my aspect was I was going to take their Milan data and Demicheli's model and try and understand the meaning of those variable peaks. This has been described as a detective story. Okay, this is what I found after doing some computer simulation of that. I found that the 10-month peak corresponds to surgery-induced angiogenesis. There were patients who had avascular micrometastasis, and something happened at or about the time of surgery to induce angiogenesis, and these showed up as relapses 10 months after surgery. The 30-month peak were single cells that were dormant, and they were induced into division and underwent angiogenesis stochastically and showed up as relapses at 30 months. And then those were all the iatrogenic events. The peak at about 50 months corresponds to when you first see the benefit of mastectomy to reduce probability of relapse. And in quantitative fashion, that 10-month peak, avascular micromets induced to vascularize. This is really prominent for premenopausal node-positive patients. It shows up in all categories, but mostly for premenopausal node-positive patients. 20% of those underwent this relapse mode. It was 5-to-1 node-positive to node-negative, and 2-to-1 pre-menopausal compared to post-menopausal. The 30-month peak were single inactive dormant cancer cells, and they were induced into division and then vascularized stochastically. And the combination of those two relapse events was by far the biggest part of the breast cancer problem. 50 to 80% of relapses were in those first two relapse modes. The late peak, past 50 months, is more or less a natural history of the disease. Just as a side issue here, to show how confident I am in the science that I'm doing, I was diagnosed with stage 3C colon cancer in 1994, just about when this project got going. And based upon my knowledge of tumor growth and what people talked about, comparts and kinetics, I ended up deciding against maximum tolerated chemotherapy. Instead, I became the first person to use metronomic chemotherapy, low dose long-term therapy. This was designed by Bill Rashevsky, who was one of the co-authors, and this was published in ProPublica, the whole story about my use of early of metronomic chemotherapy. These are data from Bernie Fisher. This was another very prominent breast cancer researcher. He died a year or so ago at age 100. These are disease-free survival data for patients with mastectomy only, grouped by nodes positive, no chemotherapy at all. And the curve on top are for the 0 node population, and the curve on the bottom is for those with more than 12 nodes positive. And let me just describe what I saw in the 0 node positive. First of all, simply removing the primary tumor cures 80% of patients. They will not have a relapse. But of the 20% who relapse, about 10% of them relapse in the first 3 years. Then there's a period of several years where there's very little activity, and then it starts up again very slowly with general relapses for the next 10 years. And finally, at 10 years, all 20% of those have relapse. Now, going down to the worst prognosis case, the number with more than 12 nodes positive, the same general pattern occurs, but the magnitude is far different. For example, all the patients relapse eventually. Prognosis of 12 and more nodes is a very serious prognosis, especially before use of chemotherapy. But the early relapses seem to show up in the first 3-year period. Instead of 10%, as in the 0 node patients, they're about 90% for the 12 node patients. And then there's a period of a few years with few relapses, and then it starts to go up again. Now, the timing is exactly the same between the 0 node population, I don't know if you can see my cursor, and the 12 and more node population. It's the magnitude is different. And then there's this period with few relapses, and that's in both cases. This was very helpful information. Okay, I've been studying a lot of cancer data, and I can tell you that I've seen this general pattern in many, many cancer types. I don't think there's one cancer type that I haven't seen this. These are combinations of large databases or case reports, pancreatic, melanoma, lung cancer, prostate, on and on. I think every cancer I've looked at, the solid and the liquid cancers, also something similar to the bimodal relapse pattern. Okay, my colleagues and I were wondering, these effects are so large, they should show up in clinical observations. So we took a careful look at adjuvant chemotherapy. It turns out that adjuvant chemotherapy works best by far for premenopausal node-positive patients. And that makes sense because those are the patients that have the most intense tumor growth right at the time when they discovered that adjuvant chemotherapy works best by far. And the co-authors in this paper, 2004, were Joe Folkman. I was on Folkman's staff at the time at Harvard. Bill Rashevsky, who, as I mentioned, was was the medical oncologist I used, and Gianna Bonadonna, who was the person from Milan, who was very prominent, and he was the first person to use multiple chemotherapy drugs in breast cancer. And this is Panuccia Valagusa, the last author. So everyone seems to agree on this, that this could explain why adjuvant chemotherapy works particularly well for premenopausal node-positive patients. And then looking at mammography, it turns out that mammography works better for women age 50 to 59 than 40 to 49. And we've done a lot of work in this, published a number of papers, and we can quantitatively explain this data. I want to point out one paper. It was published in 2005. This paper was published in a reporter from the Wall Street Journal happened to hear about this, and she wrote a report in the Wall Street Journal that was issued on the same day of this 2005 paper was published, and Harvard issued a press release on the same day. We got a lot of attention. And one thing in particular, I got a letter to the editor from Isaac Gukas. Isaac, who died a few years ago from cancer, originally from Nigeria. He was a surgeon practicing in UK at one of the hospitals there. He said this could explain what they see in Nigeria. And I spent a lot of time talking to Isaac Gukas about this. He said a lot of women, when they first find a tumor, they have known that surgery to remove the tumor causes it to come back very soon, very soon after that. And the word he used was they believe that the surgery provokes the tumor. So what people do in Nigeria is they generally go to an herbalist and get some soothing ointments instead of getting a mastectomy from a surgeon. And so we could quantitatively explain the mammography data from the Milan data, and this also explains the situation in Nigeria. I'll get back to that. There's a racial disparity in outcome. In the US, there's an excess mortality of African Americans compared to European Americans by about 1.5. However, this inverts at age 57. If African Americans are under age 57, they have a poorer outcome. But if they're over age 57, they have superior outcome. So you can't blame this on poor access to quality medical care. It's got to be biological. Published a number of papers on that. And also, breast cancer is considered to be aggressive in young women. Well, from the physician's point of view, they remove the primary tumor and you get a relapse 10 months later, and they say, well, that's an aggressive cancer. But from our perspective, it's clockwork relapse, surgery-induced angiogenesis of dormant avascular micrometastases, showing up as relapses at 10 months. I happened to run across this paper, Irving Ariel, Historical View of Breast Cancer Treatment, and I was sort of surprised to see that Irving Ariel looked at the history of reporting of breast cancer from the ancient surgeons and physicians. He looked up what Celsus and Galen reported 2,000 years ago. And these are quotations, but it's been translated several times, so the wording may not be exact. Celsus first says there's a cacoethes, then carcinoma without ulceration, then the fungating ulcer. None can be removed but the cacoethes. The rest are irritated by every method of cure. more violent the operations, the more angry they grow. After excision recurs, bringing with it the cause of death, whereas by using no extirpation, protract lives notwithstanding the disorder to an extreme old age. That's relative to the lifetime survival in that part of the world. And Galen said something very similar. We have cured this disease often in the first stages, early stages, but after it has grown to a noticeable size, no one has cured it with surgery. So after reading this, it was clear that Celsus and Galen knew all about this 2,000 years ago, but somehow this got lost. This got forgotten. We are latecomers to this very old 2,000-year-old problem. So at this point, I'd say the most important finding was that something seems to happen at or about the time of surgery to precipitate an early wave of relapses, accounting for over half of all breast cancer relapses, and surgery induces angiogenesis of dormant avascular micromets and starts growth from single cancer cells. And this may be a general effect, not just limited to breast cancer. June 2010, a paper was published that opened up a lot of research for us. This was Patrice Forget from Brussels, Belgium. He is now in Scotland, but at the time he was in Brussels. This was at a teaching hospital, so they have to expose all the residents to the various drugs used in anesthesia. And what Forget did, he did a retrospective study. He looked at the last 320 consecutive mastectomy-treated patients, chemotherapy in addition, mastectomy and chemotherapy, treated with one surgeon and given conventional therapy, and grouped the outcome by what drug was given at anesthesia. And to his surprise and everyone's surprise, one drug was far and away superior. That was the only NSAID available that was IV administrable. There are two other NSAIDs available, but at the time that was only one. There was a 5-fold reduction in relapses months 9 through 18 for ketorolac, the only NSAID that they used as an analgesic. Okay, so at this point, we knew something at the time of surgery seemed to cause these early relapses. Something, if you want to prevent the problem, something would be needed to stop these relapses at about the early, before the surgery. But what mechanism could explain that Forget data? And I'm quoting here from a quote from Hiller et al. The perioperative period can be considered a perfect storm of immunosuppression and inflammation in the presence of residual or circulating tumor cells. So we took a survey. These are very involved, very large subjects, and I realized that this was an impossible project. We took a look at these following 6 subjects to see what the correlations are among them. Surgery, inflammation, there is IL-6 elevated for about a week after surgery for breast and colon cancer. Angiogenesis, it's known that platelets actively sequester angioactive factors and they degranulate in the presence of inflammation. VEGF is elevated in serum, platelets are decreased by about 10%. Circulating tumor cells are well known for cancer patients, and it correlates with outcome. The immune system is well known to be compromised with inflammation, and cancer dormancy is a well-known effect in oncology. Just listing a few of these things, Virchow in 1863, chronic inflammation leads to tumor growth. Dvorak in 1986 describes cancer as wound healing gone awry. Weinberg, 2005, cancer usurps the wound healing process. This was an important one. Balkwell et al. In Lancet, 2001. If genetic damage is a match that lights the fire of cancer, then inflammation is a fuel that feeds the flame. So if you want to remember one item from this talk, I would say Balkwell would be it. Krebs and Z, it's well established that cancer patients have circulating tumor cells And the quantity of circulating tumor cells correlates with prognosis. It turns out that daily aspirin reduces risk of late relapse after 2 years of use. I got involved in this. There was a paper that was submitted by El Sagar et al. This was a case report of a gentleman who was diagnosed with inoperable lung cancer. And he was released from the hospital after radiation, had a horrible prognosis. He was driving his car and he bumped his head on the head visor. And within a month, a 7-centimeter tumor grew at that spot. So El Sagar submitted a case report suggesting that this might be what Bacilli and I had been writing about. So I was asked to review this paper, and I was able to look at it, and I came to the conclusion that that case report was not what we described as surgery-induced tumor growth. Something else must be going on. Someone pointed me to this paper of Martins Green et al. This was a paper that described an avian root sarcoma virus in circulation, and they found that the tumor would grow at any site of wounding, and they could prevent this with inflammation. If they allowed inflammation, they could wound the bird anywhere and you get a tumor growth there. If they prevented inflammation, the tumor would not grow there. This is sort of like that El Sagar study, except a virus is maybe 1/100th the size of a cancer cell, so it's not a great correlation. Jones and Rue, 100 years ago, localization of secondary tumors at points of injury has been so often remarked upon, that it's unnecessary to cite specific instances. Cause unknown. This was at a time when people walked around with cancer far more than today. A couple case reports, Walter et al., 2 patients with squamous cell carcinoma of the lung. They had distant metastasis at disease at points of injury. Blood speed in capillaries is 0.5 millimeter per second compared to 40 to 50 centimeters per second in large arteries. So if you have leaky capillary venules, that could be an efficient way for circulating tumor cells to get trapped in a distant organ. Pascal and Perez-Rivest et al. Inflammatory response after resection for colon and breast cancer. IL-6 marker for inflammation. This marker is elevated in serum and decays to baseline after about a week. Metastatic process is highly inefficient. Malignant cell injected into circulation has 10 to the -4 probabilities to result in a growing metastatic site, but inflammation can bypass the need for extravasation through an intact vessel wall. That's a very large effect. Belekas et al. This is an important paper. They were looking at the data from Norway on patients, breast cancer patients, who had reconstruction at variable times after the primary surgery. When they looked at these data, the relapse data, with time 0 set to the original time of surgery, they found that bimodal relapse pattern that we see, but then they set time 0 equal to the time of delayed reconstruction, and they still got the bimodal relapse pattern. So this says it's not the cancer surgery that causes it, but any surgery. Clement et al., I know her from Harvard. Platelets actively sequester angiogenesis regulator and degranulate with inflammation. There's a 10% dip in platelets and corresponding increase in VEGF. This first item was chapter 4 in that Springer Nature book that I wrote I edited with Bacilli. After reading this chapter, these are anesthesiologists. After reading this chapter, I would be surprised if surgery did not cause tumor growth. You can look at that paper that's on my Harvard website somewhere. Neutrophilic extracellular traps. These are webs that are cast out by neutrophils that are triggered, that are induced into extensive growth, extensive numerical enhancement after inflammation or wounding or anything like that. And these sort of neutrophilic cellular traps, These are web-like structures that come out from the DNA of a neutrophil, and they can capture circulating tumor cells. And since neutrophils have the ability to extravasate easily into a tissue, they can carry these cancer cells with them. And that's discussed in that chapter 4 by Hiller et al. And a couple other papers discuss that. This was a animal model study done by MIT, Kral et al. They developed an animal model, a mouse model, where they could inject cancer cells into this mouse model. And if the mouse had an intact immune system, these cancer cells would go into dormant states. If the immune system was not competent, then these dormant states would not happen. But they could operate on the animal on one side and get tumor growth on the other side, and vice versa. This was reviewed in Komaroff in the New England Journal. Another animal model study, this was from Harvard group, Panigrahi et al. This is the first sentence in their paper. Cancer treatment is a double-edged sword, as surgery, chemotherapy, or radiation can induce tumor dormancy escape and metastatic outgrowth by, you can read it yourself. They're saying that all three interventions, surgery, radiation, and chemotherapy can induce dormancy escape. So cancer treatment is a double-edged sword. Recent papers that I found, Lipitz and Harris talked about IL-6 as a prognostic factor for relapse in many cancers. And Kidd et al., it's IL-6 is a prognostic factor for lung cancer, but on post-operative day 1. So if you want to know when these events are important, it's post-operative day 1 is when inflammation is an important factor. I now think I know how to prevent the late relapses. I patent is pending, and I submitted a paper a few weeks ago. It has not been published yet, but that's an extremely simple procedure. Conclusions: the early relapses in breast cancer, which are the majority of relapses, consist of surgery, surges of angiogenesis, and single cell activation. They're triggered by primary surgery. Late relapses are apparently not triggered by primary surgery. The Forget data, retrospective data, suggests perioperative NSAID ketorolac reduces early relapses by 5-fold. This still needs to be confirmed. This may reduce cancer mortality by 25 to 50% at low cost and toxicity. There are mixed reports of excessive bleeding after surgery, but this can be reduced with tranexamic acid, reduced by 39%, and referred to a paper by Ausen et al. In 2015. So these data suggest that transient systemic inflammation is the precipitating factor resulting in angiogenesis and growth of single cells in dormancy. And while breast cancer runs its course in over a decade, most of the events that lead to relapse seem to occur in that post-surgery week. And this says that metastatic progression is amplified 100-fold during that 1 week post-surgery. Protocol is published for a way to prevent this, the Bacilli et al. And there was a second retrospective study done by Belgium group, published Desmet et al. In New England Journal of Cancer, JNCI, Journal of National Cancer Institute. So after 2 retrospective studies, extensive clinical analysis, and 2 mouse models, we think it's time to conduct 1 or more prospective clinical trials with triple-negative breast cancer. We are planning on doing a trial at Beth Israel Deaconess Medical Center at Harvard with Ted James, who is Chief of Breast Surgical Oncology. Cost is a real problem here. The cost is so inexpensive, that's been a barrier to us. Drugs cost less than $5 per patient, and there are 2 million new breast cancer patients per year in the world. So for a lousy $10 million, we could prevent these early relapses every patient in the world. So there's no money in this. That's why we've had trouble getting funds to do clinical trials. The surgery-induced effects are apparently host responses to surgery and little or nothing to do with the cancer cell genotype and not the fault of the surgeon. And this seems to be a general effect based on some recent retrospective studies. Perioperative NSAID ketorolac apparently works in ovarian and colon cancers. These are my colleagues. The upper left, I'm standing behind Rick Rogers, Pat Wood. Pat died a year or so ago. She was the wife of Bill Reshevsky. Sitting next to her, Bill was my medical oncologist. Sitting next to Bill is Romano Demichelli. Above Romano is Panuccia Valagusa from Milan, the database manager. And to her left, to our right, is Gianna Bonadonna. He died also a few years ago. He was the first person to use multiple drugs and adjuvant chemotherapy and breast cancer. To the right, the larger picture is Patrice Forget, the anesthesiologist. Vikas Sukatmi, who was right next to Patrice. The four gentlemen in the center picture, myself on the left, Romano Demichelli, Jane Vieta, and Isaac Gukas. J.N. is a surgeon. Isaac, of course, is dead. He was a surgeon. To the lower left, Osaro Erhabor. He is my main contact in Nigeria. I've visited Nigeria 3 times in the past few years. That lower picture with the 3 gentlemen. To the left is Mike Baum, a retired surgeon from UK, Isaac Gukas, and myself. And to the far right is Judah Folkman. I was on Judah Folkman's staff at the time this project was underway. Thanks for your attention. I'll be happy to take questions.
Thank you so much, Dr. Michael Retzky, and it had been a wonderful speech, a study and analysis that can prevent the oncology linkage for the relapses that can happen due to operations. And I would like to open the virtual platform for anybody's questions that can be asked to Dr. Michael Retzky. Yes, anybody has questions? Does anybody have questions for Michael Retzky? I don't see any questions as of now.
You
Yes,
can email
Dr.
me. You can email questions to me, and I'll be happy to address them. But I would recommend that Black Swan paper, breast cancer in the Black Swan paper that was published last year. Almost everything that I discussed is in that paper.
Okay. So yes, we shall move on to our next speaker, having no questions for Dr. Michael Retzky at the moment. So yes, I shall call upon our next speaker, Dr. Dupender Kaur from India. Yes, Dr. Dupender Kaur, you can go live
just
now.
Just a minute, ma'am, just a minute. Hello?
Yes.
There is some problem with my screen, sharing of the screen.
Yes, okay.
Yeah, it is here.
Okay.
Good evening to all the eminent pathologists, research scholars, keynote speakers, and I'm very thankful to the organizers to organize such a virtual conference during the times of pandemic. And I'll be speaking today on my research work, histopathological study of gallbladder malignancies with special reference to P53 expression. I'm Dr. Dupender from India. Hello?
Yes,
Hello?
you can go on, Dr. Dupinder.
My screen is visible?
Yes, you are visible and you are also audible. You can go on. Go ahead.
Okay. Okay. So talking about the carcinoma of the gallbladder, carcinoma of the gallbladder overall is the most common cancer of the biliary tract and one of the highly malignant tumors with poor prognosis. It is the fifth most common gastrointestinal malignancy following colon, pancreas, stomach, and esophagus. Incidence increases with age. Almost 90% patients are older at the time of diagnosis. It is more common in females than males with a ratio of 3 to 4:1. The incidence of gallbladder parallels the prevalence of gallstone disease, large and long-standing gallstones being associated with a high risk of gallbladder cancer. The risk of gallbladder cancer in patients with gallstones has been reported to have increased 4 to 7 times by Tyagi et al. In 2008. The association between an abnormal pancreaticobiliary duct junction, a porcelain gallbladder, and other biliary disorders such as choledochal cyst, primary sclerosing cholangitis, Meniere's syndrome, and gallbladder cancer has also been recognized by Pandey et al. In 2003. The primary carcinoma of the gallbladder is an unexpected histopathological finding in 1 to 3% specimens after elective cholecystectomy for benign gallbladder disease. And the overall prognosis has remained dismal, with the 5-year survival of 5 to 10% cases due to the late detection of the disease. And prior to the era of ultrasonography and CT scanning, the rate of the correct preoperative diagnosis was only 8.6%, which has improved considerably to 75 to 88% with the use of the newer imaging techniques. But still, a preoperative diagnosis of early carcinoma of the gallbladder is seldom made, where the 5-year survival is 91 to 100%. So talking about the most common symptoms which we come across in the patients of the gallbladder, they are the right upper quadrant abdominal pain and anorexia. And the most common abnormal laboratory finding is elevated alkaline phosphatase level. So grossly, the gallbladder carcinoma presents as a diffusely growing in 70% cases or polypoidal mass in 30% cases. And the most common cancers, they originate from the fundus in the gallbladder. And mostly the gallbladders, they also contain calculi. 80 to 90% cases have been reported which come with calculi, and they exhibit marked fibrosis of the gallbladder wall. The fact that some gallbladder carcinomas are not obvious on gross examination indicates the need for microscopic examination of every excised gallbladder. Talking about microscopy of the gallbladder, mostly we come across 80 to 90% cases of gallbladder carcinoma, of adenocarcinoma, which can be further classified into papillary, tubular, mucinous, signet cell type, clear cell type, and the less common, they include undifferentiated or anaplastic carcinomas, 2 to 7%, squamous cell carcinoma, 1 to 6%, and adenosquamous carcinoma, 1 to 4%. The carcinoid tumors, small cell carcinomas, malignant melanomas, lymphomas, and sarcomas are reported very rarely. So in the search for prevention, diagnosis, and treatment of the cancer, the genetic changes involved in the origin of gallbladder carcinoma should be determined. Most studies have focused on mutations of oncogenes, KRAS or tumor suppressor gene P53, FHIT, P14, P16, and P63. So of all these alterations in the tumor suppressor gene, P53 is commonly observed in most human cancers. Talking about P53, the P53 gene, a tumor suppressor gene located on short arm of chromosome 17, encodes a 53 kilodalton nuclear phosphoprotein, which acts as an inhibitor of cell proliferation. Mutations in p53 gene are the most common genetic lesions found, which lead to gallbladder carcinoma. These mutations play a key role in the multi-step process that leads to carcinogenesis. Most mutations described are missense mutations, resulting in an abnormal protein that accumulates in cells by virtue of an increased half-life. These mutations are generally thought to alter the functional capabilities of the cell. These intranuclear accumulations are easily detected by immunohistochemistry. So overexpression of p53 is an important early event in gallbladder tumor formation and progression, and is reflected in the biological behavior and prognosis of the cancer. So the aim of my study was histopathological study of gallbladder malignancies with special reference to p53 expression. Material and method: a total of 80 histologically proven cases of gallbladder malignancies from January 2014 and December 2019, which were received in the Department of Pathology at SRMS IMS Bareilly, were included. All these histopathologically proven cases of gallbladder malignancies were examined for p53 expression immunohistochemically. So we applied the IHC on all these 80 cases, which we received in our Department of Pathology. The procedure was followed as IHC was performed using mouse monoclonal primary antibodies for p53, using labeled streptavidin biodine peroxidase method. 3 to 4 micrometer thick sections after deparaffinization in xylene were rehydrated in graded alcohol. Antigen retrieval was done using microwave pretreatment in citrate buffer with pH 6. These sections were incubated with primary antibody for 1 hour at room temperature. After washing, the sections were treated with biotinylated secondary antibody for 30 minutes. A streptavidin HRP, that's horseradish peroxidase conjugate, was applied for 15 minutes. The reaction was visualized by using diaminobenzidine as chromogen, and the counter staining was done by Mayer's hematoxylin. And a positive control was used simultaneously. So how did we evaluate the p53 immunochemical staining on all our cases? We adopted a semi-quantitative scoring method as described by Vistuba et al. The intensity was graded as the following. Scoring was done by us. In cases which were we reported as absent, score 0, mild, score 1, moderate, score 2, intense, score 3. And simultaneously, we also did the percentage of the nuclei stained microscopically, and it was characterized as equal to or less than 5, score 0 was given, more than 5%, less than 10, score 1, 10 to 50%, score 2, more than 50%, score 3. And the staining score was obtained in the range of 0 to 6 by adding both variables, the intensity and the percentage of the nuclei stained. In this semi-quantitative method, a score more than or equal to 3 was considered as a positive overexpression of p53. So coming to our results, the present study included 80 cases of histopathologically proven cases of gallbladder malignancy. And in our study, it was observed that out of 80 cases of gallbladder malignancy, 30, that is 37.5 cases were p53 positive, and 50, that is 62.5, were p53 negative. This is a table showing number of the cases which were positive. This is the positive cases, and these are the negative cases. So in a similar study conducted by Gros et al. On 41 patients of histologically proven cases of gallbladder cancer, 29 showed p53 positivity. And Roa et al. In a study of 157 primary gallbladder carcinoma found p53 expression in 45% cases. In an Indian study conducted on 78 patients of gallbladder cancer by Chaube et al., p53 positivity was found only in 20% of the patients. So grading of the malignancy in adenocarcinoma. In our cases, 4 cases were well differentiated. 12 were moderately differentiated, and 14 cases were poorly differentiated out of the 30 cases. And in 53 negative cases showed 20 well differentiated cases. Moderately differentiated cases were 42.9%, and 4 cases were poorly differentiated. This difference was found to be significant, that is 0.003. This suggests an inverse relationship between differentiation and p53 expression. Assuming that poorly differentiated tumors behave more aggressively, p53 expression may correlate with the aggressiveness of the disease. In a similar study by Rowe et al. Of 191 cases of gallbladder malignancy, they observed increased p53 expression with grade of the tumor. A study by Ghosh et al. On 80 cases of gallbladder cancer also found that low-grade tumor that is well differentiated shows low expression of p53 in comparison to that in moderately differentiated, that is 62%, and poorly differentiated tumor only show 66.7% cases. Now talking about the staging of the tumor, in our study, most of the tumor were in stage 3 and 4, as you can see in this table. Among the p53 negative patients, also more number of patients were in stage PT3, 3, 4, that is 26. These are 26 cases, total 72%, as compared to stage 1 and 2, which were only 4. p53 score showed no significant difference with the stage of tumor. According to a study conducted by Ghosh et al. On 80 patients of gallbladder cancer, 36 had stage 1 disease, and 40 cases had stage 2, and 4 cases had stage 4 disease. In a study conducted by Viscuba et al. On 52 cases of gallbladder cancer, 34 showed p53 expression, and no association was observed with correlation between p53 overexpression gallbladder and stage of the tumor. These are the pictures showing the scoring method we applied. This is a micro photograph showing p53 score, and score 3 has been given. This is again a micro photograph of the staining, and it shows score 5. Here score 6 is given. So the conclusion of our study: out of 80 patients of gallbladder carcinoma evaluated for p53 overexpression was detected in 37.5% cases. There was statistically significant difference between the histological grade of p53 positive and p53 negative adenocarcinomas, with significantly higher number of patients of p53 overexpression presenting with poorly differentiated adenocarcinoma. The p-value was 0.003, and p53 overexpression showed inverse relationship with the grade of tumor in our study. So, however, p53 expression did not correlate with the depth of the tumor invasion or the stage of the tumor in our cases. These results may indicate that p53 has a role in gallbladder carcinogenesis and its progression of the cancer from low grade to high grade, but not in tumor invasion. Thank you.
Yes, thank you so much, Dr. Dupinder Kaur, for your talk on the gallbladder malignancies and the findings of p53 and its inverse relationship with the grade of tumor and its role in cancerogenesis.
Thank you, ma'am.
Yes, the virtual platform is open for questions, and if anyone would like to ask, you can come forward for the questions. And Dr. Beatrice had extended her thanksgiving to Dr. Michael Retzky on sharing his wonderful theme prior to Dr. Dupinder Kaur's speech. And she also mentioned that the theme was very interesting, and thank you for sharing the findings of his articles. And so, yes, the questions can be asked to Dr. Dupinder Kaur. Anyone would like to ask anything regarding the gallbladder malignancies? If there are no questions as of now, we can go on with the next speaker. Yes, thank you, Dr. Dupinder. We can, I shall call upon our next speaker, Dr. Zeev Lefer from United States of America. Yes, sir, you can share your screen, and our participants are waiting to hear from you.
Let me get the share up.
Yes, we can see your presentation.
Good.
You can go ahead.
First of all, let me say good morning, good afternoon, good evening to each of you, wherever you may be located. Secondly, thank you very much to the organizers of this excellent conference for the invitation and for programs that have been presented. The title of this talk is Lookalikes, Pathologist's Challenge, Parasite or Tumor, a brief literature review and discussion. You can see my background and current activities. The hero of the story, or the villain, is the Echinococcus. Hero in the sense that, first of all, as we will see, it's important. Villain in two ways. First of all, as a source of pathology and a problem in its own right. And secondly, because of the confusion and the possibility of misdiagnosis, as we shall develop. Echinococcus is a worm, Spirillum platyhelminthes, which are the flatworms as opposed to the roundworms. And it's fairly short, a couple of millimeters, 5 or 6 millimeters generally. The big tapeworms that we're familiar with can be 20 or 30 feet in the gut, so it's a very different story. Generally speaking, has this appearance. This is the part where eggs are developed. This is the part of attachment. Other pictures will show various labels for the different subsegments. But this is, as I say, the hero of the story. Organism, it's Echinococcus granulosus. There are other species. Definitive host is the dog. And it goes through a normal life cycle. When your feces are released and you have ingestion by an intermediate host, usually a sheep. And then offal material usually presented to the dog as food, whether by the farmer or naturally. And you have sort of cycling back and forth in this sense. Looking at it from the organism point of view, we'll start here with the dog. You have the adult form in the small intestine. When it comes out in the feces, you have embryonated eggs. The eggs will develop into an oncosphere, which hatches. And it's this form which will penetrate the intestinal wall of the next animal host. And there in this organism, you will have what's called a hydated cyst. We're going to refer to this many times. It means essentially a cystic structure, fluid-filled, larval forms within, usually in the liver and the lungs. And these are released when you go through developmental stages, gets into the original definitive host, back to the dog. As we said, protoscolex developing from the cyst, attaches to the intestine, development into fully adult form, and the process goes round and round. except that sometimes these embryonated eggs can be ingested by humans, either in contaminated food, contaminated water. And then you set up a similar process. You have oncospheres released and hydrated cysts formed in various organs, depending on where they end up, and pathology results, which is of our primary concern, unless you happen to be a veterinarian, in which case you worry about the dogs. I also worry about the dogs in terms of spread, as we have discussed. In people, pathology is known as echinococosis. Shows up primarily in the liver and the lungs, but can also be found in a number of other organisms: kidney, spleen, heart, bone, and others. As we mentioned, it forms these hydrated cysts. And pathology results when the cyst itself simply physically grows large enough to impinge on other organs and cause damage to other organs. And furthermore, sometimes the cysts rupture and you have a host reaction to the released cysts, which can show up as fever, eosinophilia. More seriously, you can have anaphylactic shock. And in a slightly different sense, rupturing of the cyst results in dissemination. It can start in one organ and end up in a different organism, and that itself obviously is a problem. This organism and its concomitant pathologies are found extensively in the Middle East, but not only, found in Africa, Asia, Eastern Europe, South America, Central Asia. Relatively speaking, rarely in the United States, rarely in Western Europe. So there's a geographical message in the story, which I'll come back to. In terms of diagnosing a case of hydrated cyst or echinococcal disease, at the physical level, you can detect a cyst-like mass, especially in a region where you might expect it, where it's endemic. There are imaging strategies. You can have CAT scan, you can see it by MRI, you can detect it by ultrasonography. There are serological tests which can also show its presence. And ultimately, there is histopathology. Take a sample, you make a biopsy, you look at it, and you can find either eggs or parts of the organism and make a diagnosis on that basis. Having mentioned histopathology, let's pause on that for the moment. Classically, everybody knows we make a biopsy, prepare a slide, pass it over to the pathologist. He looks at it, and he will use what I'll call old skills to analyze a slide. You know the difference between normal and abnormal. You scan the whole slide to find it. You find the area of pathology and you make your diagnosis. I'm using the word graded. Graded means stage it. Graded means depending on the particular pathology, it's benign or malignant, or somewhere in between. It's melanomas, you have Clark levels, and you have, if it's prostate tumors, you have Gleason scale, and so on, each one in its own terms, but you make that diagnosis. Today we have digital pathology, which means the same biopsy, the same preparation of a glass slide, only now you have a step whereby you digitize the slide, you convert it to a digital form, and you use it, you view it. You need a special viewer, computer, where the computer acts like a microscope, and the computer will be able to zoom in. In other words, a JPEG, the closer you get in, the more you magnify it, it gets fuzzy. Here, you were able to zoom in from 4 to 100, let's say, and still have your clarity from whole tissue down to nuclear level, and all on the computer. But what is new about the use of the digital pathology methodology, you can do all kinds of other things. You can annotate the slide, draw a circle around it, underline it, put in a label, put an arrow to the area of interest. You can save it, you can archive and retrieve instead of mountains and sometimes, dare I say, tons of glass slides on trays in rooms. Now it's all on the computer and you can bring up the slide at will. It also has advantage in teleconferencing, where you can now have a second opinion, a diagnosis. You're in Africa, you're in Asia, you want to get an opinion from the Mayo Clinic in the United States. In 2 seconds, two people can be hooked up to the same slide and look at it. So you don't have to wrap and pack a glass slide and send it across the country or across the world. And you can make your diagnosis. You can also have two people at the same time looking at the same slide, and one or the other has control of the pointer and the panning and zooming and work together on that basis. And then you have what I'll call newer skills. This includes computational pathology, where you can now make measurements. You can measure the distance between two structures or two cells. You can determine the perimeter, you can determine the volume, and so on, howsoever that is relevant to your diagnosis. Multiplexing refers to use of antibodies hooked together with various dyes and stains that are either chemically detected or detected by fluorescence. And now you can have 40 or so different proteins in the same slide identified and characterized. Depending on the pathology and depending on your need, we'll identify tumor versus stroma versus immune cells and so on. And now you have artificial intelligence, whereby you are training the computer to recognize normal versus abnormal, training the computer to make the identification. Not quite ready, not this year, maybe next year, which is to say it's a cutting edge in a field that's very much in process. But an important observation in this regard is that if you have 10 pathologists, one slide, 10 pathologists trained and experienced, the observation is you don't get the same diagnosis. Very rare that 10 out of 10 will not only stage it differently, but even plus minus normal or abnormal, which of course means how are you going to train the machine if the people don't agree? Having said all of this, we have all these, and this is background information, we come back to old skills. And old skills means the trained scientist looking in the microscope or even looking on the computer and looking at the tissue and making his diagnosis and determining what he sees with the sum total of all his years of experience and all his other knowledge of the rest of the case and putting together all that information to interpret the disease. Having said that, we come to the problem of lookalikes. It's always a problem. Whatever the pathology, you will have other conditions that may mimic it, and it's sort of built into the question of diagnostic pathology. But in our case, we want to look at the case of hydatid cyst versus tumor. What's going to follow is a brief sampling of the literature. The general theme is what we thought it was and what it turned out to be. All of which is to make the general point that in many cases, what was thought to be a cyst turned out to be a tumor. What was thought to be a tumor turned out to be a cyst, and all of concomitant problems. Example number 1. Here is a case in the kidney. We thought it was a tumor, turned out to be a cyst. Authors are from Korea. Here is the paper, Korean Journal of Parasitology, primary renal hydatid cyst, misinterpretation as a renal malignancy, Choi et al. And I'm going to show you the abstract. I don't intend for everybody to be able to read this, but the bolding is mine, just to make certain points. Paper I said is from Korea, but the patient was from Uzbekistan in terms of where this pathology may have originated. You have a CAT scan, check the mass. Original diagnosis was that this was a renal malignancy. All right, mass was removed. Histopathology was carried out, and the final diagnosis was cyst. Right? However you want to call it, mistaken diagnosis or expanded diagnosis or rule in and rule out, but it looked like one and turned out to be the other. All right, in the microscope here is some of the cystic material that was detected that confirmed the diagnosis and different from what they got from the CAT scan and from palpation of a mass and so on. Case number 2, again, kidney. Again, thought it was a tumor, turned out to be a cyst. Pathology was in India. This is Kadri et al. Isolated cystic echinococosis of the kidney, burlesquing as a renal cell carcinoma, a diagnostic pitfall. So pitfall tells you to be careful. Burlesquing means this look-alike issue. Annals of Parasitology. And again, you had a cystic structure. You had some clinical pictures, pain, fever, hematuria. You had a CAT scan. Diagnosis was renal cell carcinoma. And by the end of the trail, you came to histopathological examination that you found hydatid cysts, and the diagnosis was changed to echinococosis. Again, the message, beware and be prepared. Case number 3. Here is tumor in the pancreas, thought to be a tumor, turned out to be a cyst. Case was found in Iran. Hydatid cyst of pancreas mimicking, again, that's keyword, neoplasm. Kashmoabat et al. You go through the whole history. Point that they want to make is that hydatid cyst of the pancreas is rare. So that's Now, it wasn't on the original list that I gave of where it's usually found, and even sometimes found. Here is something which is rare. You wouldn't expect to find it, so it emphasizes the observation in this paper that even though it's rare, sometimes it is found, and again, be conscious and prepare for it. There's another case of pancreas, originally thought to be a tumor, turned out to be a cyst. In Iran, primary hydrated cyst of pancreas, again mimicking neoplasm. Sam Ibis et al., Southern Medical Journal. And here too, follow a trail, beginning to get familiar with this. At the physical level, you have a mass, you do the routine things you might expect, ultrasound, CAT scan. The primary assumption that it's a tumor. Take it out, do the histology on it, histopathological evaluation showed that in fact it ended up to be a cyst. And again, rare in the pancreas, so don't overlook it. Next, we have pathology in the lung. Note that now it goes the other way around. It was originally thought to be a cyst, ended up to be a tumor. Singh et al., lung carcinoma mimicking hydrated cyst, medical oncology. By CAT scan, you've got something to worry about. Serology was positive for Echinococcus granulosus, take note. Finally, at the end of the trail, histopathological evaluation of the excised specimen showed large cell carcinoma. All right, bolding again in the red is mine, but what they say is the case highlights the fact that a lung carcinoma may rarely have clinical rarely means not too often, but it does happen. I mean, sometimes. Have clinical, radiological, and serological features similar to those of pulmonary hydrated cyst. All right, so at the clinical level, it looked like a cyst. At the radiological level, it looked like a cyst. Even serologically, they had indications that it was a cyst. In the end, it turned out to be carcinoma in the lung. Last case shows pathology in the liver. Again, thought it was a cyst, turned out to be a tumor. Case was in Turkey. Oral et al., case of undifferentiated embryonic liver sarcoma mimicking cystic hydratic disease in an endemic region of the world. This is largely a review of various possibilities in the diagnosis. But the possibilities are undifferentiated embryonic liver sarcoma versus cystic hydratic disease. Read the paper and you go through all the details, but their bottom line message is surgeons who operate in endemic regions must be aware that not all hepatic cystic masses are necessarily hydratic disease, and maybe other more rare malignant diseases such as liver carcinoma. So, why is this all important? So we'll break it down as follows. First of all, for doctors in endemic areas, all those geographical regions that I mentioned earlier, you have to be aware of everything we just said, possibility of mistaking one for the other, seriously, legitimately, basis of evidence, that confuses things. Obviously, it makes a difference. It makes a difference in terms of treatment. If it's a tumor, then a certain kind of surgery is done, radiation is done. Radiation has a problem of damaging peripheral tissue, normal tissue, unless you're extremely focused and so on. Chemotherapy has toxic side effects. That is the bane of all patients taking chemo. On the other hand, if it's a cyst, again, many of these cysts are dealt with by surgery, but it's a different kind of surgery and perhaps less of a concern about getting it all out in every last cell. Chemical treatment, praziquantel, is very often the drug of choice. You wouldn't use that if it was a tumor. So you have to know the diagnosis in order to know how to treat. And one might argue that the prognosis is certainly different. You have a diagnosis of carcinoma, you start to make out your will and so on. And if it's a cyst, you worry about it less. So that's the concern. This is the same. Starting here, doctors, this is doctors in endemic areas. Now we're shifting to doctors in non-endemic areas. Like I mentioned, United States, other areas where you don't see echinococosis all that often. The problem is that it's not expected. Right, so if you're in Asia, Africa, Middle East, you come across these cases, you expect it, you look for it. Where you never have it, you don't expect it, but it could happen. And you have to recognize it, you have to differentiate it from other pathologies. The problem is more complicated because I'm calling it today, in our generation, as it were, compared to previous ages, decades. Travel is much more extensive, whether for tourism, whether people relocate, and so on. And you may bring back conditions, or people coming in may bring conditions. They bring their pets, and the pets may have these infectious diseases. And you have the patient themselves who's coming in from some of these other geographical regions to the United States. You have to know how to treat, or to Western Europe and so on, places where it's not usually found. From a little different perspective, and from my own frame of reference, particularly critical, medical education, particularly in non-endemic areas. And here I'm getting on my soapbox to make the point that as properly trained doctors, you can't just know what you're likely to see in your local area, right? You may never see a case of echinococosis routinely in Brooklyn or New York or United States and so on. But you might. And the message that I want to give over is to teach, at least at the postgraduate level, residency and beyond, the pathologies of other countries. We tend to be sort of generally isolated, and there's obviously a logic to it. You teach what the students are likely to see as doctors. But I'm looking to expand that consciousness to suggest that you should know what pathologies are found, especially if you know that your patient is from the Middle East or from Asia or from Africa and so on. What kind of things might they carry that you don't know from your experience locally? I'm going to make just a side comment. Teach microbiology amongst other things like pathology, and I give a lecture on bioterrorism. And we talk about the pathogenic organisms, and obviously that's a major concern. Pathogenicity, mechanisms of disease causation, lethality, spread, and so on. But I also make the comment to the students that NIH list, CDC list, those organisms that are sort of selected as bioterrorism weapons One of the reasons is because they're pretty much what I'll call oddball organisms, which means you only find them in animals, you only find them in certain limited regions, which is to say things that doctors would not be expected. But my point is you need to recognize them. In other words, most doctors never saw or never will see a case in their practice in 50 years. We're never going to see anthrax or smallpox, tularemia, or plague. But then we hope it never happened. But in preparation of the possibility that it might, you need to recognize it when they come across it. And my point here is to carry over this concept to the cyst tumor story we have been discussing. You may not see it where you are currently practicing, but your patient may have it, and it's your job to recognize it. Bottom line is, know your field well enough so you won't be fooled by lookalikes. Thank you very much.
Thank you, Dr. Zev Leifer, for such a wonderful potpourri of cases that we have had so far, and a nice compilation of all the cases put together, where cystic lesions were thought to be as tumor and tumor lesions were thought to be cystic. It was wonderful, and it kind of creates that sense of awareness for the endemic as well as the non-endemic country participants who are present today to even look at it in this way. Thank you so much, Dr. Zev Leifer, once again for the speech and for the insightful talk on it. And I would like to call upon the next speaker. But before that, if anyone has any questions for Dr. Zev Leifer, you can ask. The platform is open for questions. If anyone would like to ask questions, I don't see as such questions. Okay. Thank you, Dr. Zev Leifer. I don't think anyone has questions for this potpourri of cases that you have shown. I shall move upon the next speaker that I can call Dr. Pradeep. Dr. Pradeep Kumar, yes, you can share your screen, and we are all waiting for your talk.
Yeah.
You can share your screen, Dr. Pradeep.
Yeah, just a second. I'm doing.
So today, Dr. Pradeep Kumar from India is going to talk about the study of pathological significance of pap smear in the diagnosis of epithelial lesions in the age group of postmenopausal women.
Yeah, thank you very much for giving me an opportunity to present a paper. So the title of my study is a study of pathological significance of pap smear in the diagnosis of epithelial lesions in postmenopausal women. I am myself Dr. Pradeep Kumar. I am working as an assistant professor in Shimoga Institute of Medical Sciences, Shimoga in India. I have done MBBS and MD, MBBS from Bangalore Medical College and MD in pathology. So coming to the introduction, cervical cancer is one of the major life-threatening malignancies in women, which can be prevented in the majority of the cases. It is the
Dr.
common.
Pradeep?
Yeah.
If I may interrupt, can you please share your screen? We cannot see your screen.
Yeah,
of the presentation?
yeah, I'm very sorry. Yeah,
Yes, we can see your
is it
screen
visible?
and you are also audible. Yes, you
Yeah,
can go ahead.
yeah, thank you. Yeah, cervical cancer is one of the major life-threatening malignancies in women, which can be prevented in majority of the cases. It is the commonest malignancy causing mortality among women in developing countries like India, Bangladesh, Pakistan, and Nepal. In India, every year about 2.2 lakh women are diagnosed with the cervical cancer, and about half of them succumb to it. National Cancer Registry Program of India shows that the cervical and the breast cancer are the leading malignancies in Indian women. The peak age of cervical cancer in India is 55 to 59 years, that is peri and postmenopausal. As there is a well-defined natural history and a long preclinical phase to diagnose the disease, the mass screening program can be undertaken to control it. As we all know, the cervical malignancy progresses initially from cervical dysplasia, which begins as a mild dysplasia, then CIN 1, 2, 3, or what we call it as LCL and HCL, and then it will progress to the malignancy. So there is a long time gap between the dysplasia to malignancy. So any point of time we can interfere and we can stop the progression to the malignancy. However, the older and the poor women are less likely to undergo screening, who are actually at the higher risk of getting the disease. Most of the cases, that is approximately 85% of the cases, present at late or advanced stage where the treatment won't work and the treatment will be very expensive. The women during menopause or postmenopause are at higher risk of developing cellular atypia that could ultimately lead to cervical cancer. So it is important to create awareness regarding periodic screening of the postmenopausal women. So in India, most of the postmenopausal women won't come to the gynecologist because most of the cases of malignancy won't be having any symptoms, and most of the elderly populations will be neglected by the peer or the children. So one of the major etiological factors for cervical cancer is human papilloma virus, which can be sexually transmittable. Any women could have exposed to it during the active sexual phase of life. The associated risk factors like early age of intercourse, multiple partners will increase the chances of infection. A periodic pap screening recommended will help the early diagnosis of epithelial abnormalities, which is useful to prevent the progression of epithelial lesions to malignancy. The aims of the study is to study the incidence of different types of epithelial lesions on pap smear in postmenopausal women. We have taken it as a descriptive study to see how many cases of the postmenopausal cases we have seen it and we have diagnosed as the epithelial lesions, beginning from the inflammation till the malignancy, only in the postmenopausal women. A 2-year retrospective study was carried out in the Department of Pathology in a tertiary care hospital of South India. All postmenopausal women with clinical symptoms are included in the study. Known cases of malignancies were excluded from the study. Conventional pap smear received at the Department of Pathology was stained with the pap stain according to the standard operating procedure and were reported using the standard Bethesda system. The different kinds of epithelial lesions were noted and the incidence pattern of the lesions were studied and tabulated, and this was done independently by the two pathology by double-blinded method. So moving on to the results, a total of 2,375 pap smears were received in a duration of 2 years, out of which 536 cases were of postmenopausal women. Their age ranged from 48 to 70 years with a mean age of 59 years. The smears were reported as per the Bethesda system. 84.8%, that is 455 cases, the smear showed satisfactory cellularity. No significant abnormalities were seen in 192 cases. So if you go through this table, the epithelial abnormalities which we made out in our routine pap studies were the non-specific inflammations were seen in 96 cases, that is 21% of the cases. Ascus was seen in 23 cases, which is 0.5%. Atypical glandular cells NOS seen in 8 cases, which is 1.7%. and atypical endocervical cells seen in 7 cases, that is 1.5%. Atypical endometrial cells were seen in 6 cases, that is 1.3 cases percent. LCIL was seen in 68 cases, that is 15%, and HCIL was seen in 48 cases, that is 10.5%. Squamous cell carcinoma seen in 5 cases, that is 1.1%. Adenocarcinoma in 2 cases, that is 2.1%. The total epithelial abnormalities we saw in 263 cases, that is totally 57.8% of the postmenopausal smear showed epithelial, one or the other epithelial abnormality. Here, if you see the percentage wise, we diagnosed most of it, almost around 25% of the cases as LCIL and HCIL. So the early diagnosis and early intervention will minimize the progression of LCIL and HCIL to the squamous cell carcinoma, which will reduce the mortality and morbidity in postmenopausal female to a greater extent. Out of 455 cases found to be satisfactory, 57% cases showed epithelial abnormalities with the predominance of non-specific inflammation with 21%, followed by 15% LCIL and 10.5% HCIL, which will most often lead to carcinoma. 5 cases were diagnosed with squamous cell carcinoma and 2 cases with adenocarcinoma. The diagnostic efficacy of pap smear with 57.8% cases diagnosed with the epithelial abnormalities is very much significant, as the other cases only were not having any epithelial abnormalities. So any of these epithelial abnormalities would have led to this squamous cell carcinoma, which we have prevented by the mass screening method of pap screening. Pap smear is a non-invasive, painless, easy to perform, rapid and patient-friendly screening, which can have a significant impact in the diagnosis of cervical cancer at the earliest. So as we know, the pap smear, it can be done as a mass screening procedure, and it is non-invasive, and it won't cause any pain to the patient, and the procedure is very easy to master, and the staining procedure is also very easy, and it's not expensive also. So moving on to the discussion, the percentage of this smear found satisfactory for evaluation in various studies were like 0.5% in Reddy et al. Study, and 0.73% in Mosa et al. And 18.94% in Gupta et al. In comparison, our study showed 15.2% smears as unsatisfactory. So as our study is only on the postmenopausal smear, our study results were close to the study done by Gupta et al., who had included all postmenopausal women. The study of Mosa et al. Also showed that the postmenopausal smears were likely to be inadequate because of the estrogen deficiency, which will cause the vaginal atrophy. So the cellularity might be inadequate as the epithelial atrophy has taken place due to the estrogen deficiency. The age range from 48 to 70 years seen in our study in comparison to the other studies, we showed 51 to 60 years as it in Mosa et al. The present study is on par with the other studies in the diagnosis of various epithelial lesions in postmenopausal women, which helped in the early diagnosis and treatment of the disease, which in turn results in the reduction of mortality and morbidity. So to conclude, pap smear is a most feasible, cost-effective, non-invasive diagnostic modality, which helps in early detection of malignancy and any other epithelial lesions which may lead to the malignancy, and which in turn reduces the morbidity and mortality in postmenopausal women. These are my references, and I thank everyone for peaceful listening and giving me an opportunity to present in your conference. Thank you.
Thank you, Dr. Pradeep Kumar. That was extensive research done on the use of pap smear to reduce the mortality rate in postmenopausal women by picking up lesions at an earlier stage. Thank you. Yes, anybody would like to ask questions? The platform is open for questions. We are running ahead of time right now, so we can actually allot some time for questions if anybody has. Yes, if anybody, I don't think, Dr. Pradeep, there are questions for you. And if
Yeah,
there
thank
are questions, it shall be, you can mail us at any time. The emails will be provided to all the participants. Yes. So thank you, Dr. Pradeep. I shall call upon our next speaker, Dr. Fabia Ocampo Acosta. Uh, hello. And
Hello.
he is going to present on the topic myofibroblasts in odontogenic cysts and tumors and the stromal interaction and its role in aggressive behavior of these entities. Yes, let's start with your presentation. Dr. Fabia, you can share your screen. All our participants are eagerly waiting to have a glimpse of your
Really?
presentation.
Okay.
Yes.
Thank you. Thank you. Well, good morning, everyone. Here in Mexico is still 10 a.m.
Okay.
Okay, this is the presentation. Okay.
Yes, you can
I'm
go ahead, Dr.
okay.
Fabia. You are
Okay.
audible and visible. Your screen is sharing. Yes.
Okay. Thank you. Let me close this. Okay. I am Fabián Ocampo Acosta, oral pathologist. I'm working in the dentistry school in the Universidad Autónoma de Baja California, Tijuana, Mexico. My co-worker is Dr. Jorge Paredes Vieira, and we are going to speak about myofibroblasts in odontogenic cysts and tumors with that's its stromal interaction and its role in aggressive behavior of these entities. Thanks to the organizing committee for letting me share this study with all of you. Okay. As a background, odontogenic cysts and tumors share the same tissue sources, the odontogenic remnants, although they differ in their biological behavior and degree of aggressiveness. They appear exclusively in jaw bones or in the oral mucosa when they are peripheral. And the most recent World Health Organization head and neck tumor classification was released in 2017, in which are a chapter of odontogenic and maxillofacial bone tumors. Okay, in general, this schematic view approaches to how these lesions are classified. In the top of this schematic view, we had the odontogenic tumors, and this could be either malignant or benign. The benign are classified according to the predominant component that can be epithelial, mixed epithelial mesenchymal, or only mesenchymal. In the bottom, we look for the odontogenic cyst. There are other maxillofacial cysts, sorry. But in this case, they are of odontogenic origin and it could be inflammatory, like the most predominant inflammatory cyst, like the radicular cyst, or the inflammatory collateral cyst. And could be also developmental. The most prevalent developmental cysts are dentigerous cysts. Also, odontogenic keratocysts and orthokeratinized odontogenic cysts, among others. But we have to highlight this specific odontogenic tumor because of its aggressiveness, because of its frequency. We're going to highlight amyloblastoma, either conventional, solid, or unicystic, and these three odontogenic tumors for the same reason. As we can see, this is also my background image. They took almost the same in the initial stages. It could be anyone, so differentials has to be made along with clinical pathological correlation. With time, can achieve this appearance and classical fashion of bone destruction, teeth displacement, cortical expansion, etc. Like these ones. These are clearly examples of those odontogenic cysts. Histologically, they are without a doubt of odontogenic origin, but we can use some immunohistochemical markers in case of hesitation, like in this one of odontogenic keratocysts. Similar characteristics can be observed in lesser aggressive entities, such as this orthokeratinized odontogenic cyst. But with time, we can it can cause a major bone defects. In this case of odontogenic tumors, the epithelial component can cause to have huge sizes, and the conventional treatment of that is large bone resections, like in this example of conventional ameloblastoma. So these qualities are attributed to various characteristics that the epithelial component acquires during the development of the lesion. There are a few studies on the non-epithelial component that could contribute to diverse biological behavior of different odontogenic cysts and tumors. Well, the myofibroblasts were first described by Gabbiani as a fibroblast with smooth muscles characteristics. As paracrine cells, they can take part in the development of repair and normal tissue, as well as in various diseases processes, such as inflammatory bowel diseases, asthma, nasal polyps, hypertrophic scarring, and desmoplastic reaction to various types of cancer. The types of protein filaments contained in its cytoskeleton are defined by morphological and immunological criteria, being fundamental aspects of its phenotype. The simplest definition of myofibroblast is a smooth muscle cell-like cell, primarily by expressing alpha-smooth muscle actin in its cytoskeleton. However, it is suggested that myofibroblasts represent a state of differentiation of the fibroblast itself. A number of cytokines included platelet-derived growth factor, interleukin-4, insulin-like growth factor, and transforming growth factor beta could be involved in differentiation from fibroblasts to myofibroblasts. This schematic view of differentiation of myofibroblasts from stromal cells, mainly fibroblasts, shows focal adhesion mediating by integrins, by mechanical tension, having the cytoplasmic actin become a smooth muscle actin, and in the outer side, fibronexus attach fibronectin, and could be the transforming growth factor beta, the main growth factor that by these cells get this new phenotype and becoming myofibroblast. We don't know for sure if they can regress to a fibroblast. What are the functions? Well, in normal physiological conditions, we can have scarring, synthesis, remodeling, and repair of the extracellular matrix in non-scar tissues, can produce various molecules of the extracellular matrix, such as collagen, elastic fibers, glycosaminoglycans, tenascin, and fibronectin, among others, both at the interstitial level and in the epithelial and endothelial basement membranes. The accumulation of fibroblast-like cells, including myofibroblasts, are frequently seen in association with the age of an actively expanding tumor mass. Lewis demonstrated that stromal cells in squamous cells carcinomas in vivo express SMA, indicating a myofibroblastic phenotype. Myofibroblasts upregulate the secretion of large number of growth factors, chemokines, and cytokines, as well as extracellular matrix proteins and proteases. Many types of odontogenic lesions, particularly odontogenic keratocysts and solid ameloblastomas, although classified as benign, they locally demonstrate aggressive behavior and potentially lethal nature. Beret evaluated odontogenic cysts and tumors, and the stroma of these lesions harbored myofibroblasts as reflected by the SMA positive cells. Kosoltani studied the relationship between the presence of myofibroblasts in the capsular stroma of different cysts and odontogenic tumors, finding, for example, 86% positivity for odontogenic keratocysts, 53% in the integer cyst, 80% in unicystic ameloblastomas, 93% in solid ameloblastomas, and so on. On the contrary, Smith analyzed the presence of myofibroblasts with SMA in solid and unicystic ameloblastomas, concluded that although there were strong immunoreactions, the irregular distribution and the decrease of them in the stroma of solid ameloblastoma demonstrate that by themselves, myofibroblasts do not have an important role in aggressive behavior of the neoplasm. I believe the contrary. Anigoda found significant differences when comparing the presence of myofibroblasts with SMA between ameloblastomas and integer cysts, and between odontogenic keratocysts and integer cysts, without finding significant differences between ameloblastomas and odontogenic keratocysts, partially corroborating the action of myofibroblasts in the aggressive behavior of these entities. Well, the aim of this study was to correlate the presence of myofibroblasts with the aggressiveness of certain cysts and tumors of odontogenic origin. Well, the materials and methods was we took selected odontogenic cysts, 11 dentiger cysts, 16 odontogenic keratocysts, 2 orthokeratinized odontogenic cysts, and 5 unicystic ameloblastomas and 5 conventional ameloblastomas. They were all prepared for conventional process for immunohistochemistry for immunoreaction to SMA. According to the positive control in this slide, which was cecal appendix, the immunoreactions and the intensity were determined. Well, which was the results? Okay. In this picture, we looked the stromal aspect in the cyst, and in the solid area of ameloblastoma for reaction using positive controls, like in the left upper side is the cecal appendix. And we compared, for an example, in the dentigerous cyst or all the cysts of odontogenic origin, looking for this reaction in capsule or in the solid areas of ameloblastomas. Surprisingly, dentigerous cysts had mild and moderate intensity in all cases. Odontogenic orthokeratinized cyst was lesser, although one of them was had an intense reaction. Ameloblastomas, cystic and solid, behavior similarly between them, and odontogenic keratocyst shows the most intense reaction to it. Here are the percentages of the frequency of this immunoreaction, being the odontogenic keratocyst, which was showed the most intense and constant immunoreaction along the study. And the mean and the standard deviation shows that only the odontogenic keratocyst has a p-value which is statistically significant. Well, these results showed that there was no significant difference according to the diagnosis, only in odontogenic keratocysts. In contrast with those of results of Barrett, in which, according to the diagnosis, there was a different immunoreaction, being less in odontogenic lesions that do not show an aggressive behavior, such as the dentigerous cyst, orthokeratinized odontogenic cyst, and ameloblastic fibroma. And much higher in odontogenic keratocyst, cystic, solid ameloblastomas, even when with immunoreaction similar to the invasion front of intraoral squamous cell carcinomas. On the other hand, Ramos in 2014, when conducting a similar study, increasing the immunohistochemical test for Ki-67, MMP-129, showed that there was also no significant difference in immunoreaction with the SMA in odontogenic keratocysts associated or not with Gorlin syndrome when compared to dental follicles. It is proposed that the epithelial transformation of odontogenic cysts and tumors can generate recruitment to generate a favorable microenvironment in the successful development of these lesions, regardless of the biological behavior of each one of them. What could be concluded in this study? Well, that there are diverse and multiple evidence regarding the presence of myofibroblasts in the capsule or in the front of invasion of these entities, with most of it pointing towards the partial interference in the aggressiveness of such lesions. And we can identify therapies aimed at reducing dimensions or even curing aggressive odontogenic neoplasms in the use of mutilating surgeries associated with late diagnosis and the aggressive nature of certain entities of odontogenic origin. Where we have to move forward? Well, not only looking for SMA in the capsule or in the stroma of these kind of tumors, but also look for WNT pathway, beta-catenin, more making a correlation with transforming growth factor beta, and also STAT3. We can look also for some kind of software for scoring immune expression more accurately, and always looking for genomics, epigenomics, or proteomics of these entities, which are running right now. Here are some references, and I want to thank some of my friends, some people like Douglas Knepp, like Lester Thompson, like Dr. Beatriz Aldape, which are people who inspire me to be more, to be like them, to be better. And I want to thank my family. I think my daughter and son are looking at the conference. Hola Fatima, hola Fabián, hola Milan. And thank you again to the organizing committee, and that's all.
Thank you, Dr. Fabian, for a wonderful talk on odontogenic cysts and tumors and the role of genomics, proteomics in all of this. Yes, the platform is open for questions. If anyone would like to ask questions to Dr. Fabia, he's free to answer it. So, Dr. Fabia, I don't see any questions so far, but if any questions would be asked, they can be mailed to your email ID.
Yes,
Thank
of
you so
course,
much.
of course.
Thank you, Dr.
Thank
Fabia.
you.
And the last speaker for today's session, I would call upon the speaker, Dr. Claudia Angelica Pena from Mexico.
Hi, how are you? I am Claudia Peña, medical pathology and PhD in cytology from Colombia. Thanks. The video presented?
Okay. Das ist ja wie beim Mm. Hello.
Hi, please the video and song.
Dr. Andreas, I think you will have to play. Dr. Andreas, you need to play.
Yeah, I just called.
Yeah.
So, and I know everything. So I tried to share my screen for you, which should be easy, I hope. That is. Let's take this one. So you should be able to see it. There it goes.
Yes. Dr. Andreas, Dr. Andreas, we cannot actually hear the presentation. If you can turn on the volume. Can you hear it?
So I hear it loud and clear.
Okay, because we are not able to hear the participants as well.
Okay. I try something.
Yes. Can you play it? Unable to hear Dr. Andreas.
Okay. So, I just need to interrupt. So you cannot hear the audio of the presentation?
Okay. No, we cannot hear. The
Okay.
participants are also unable to hear.
So, well, I can't. So I played it in my browser, and I can hear it.
Okay.
So
the team is saying that they will play. The UCG conference team is saying that they will play it. To see if
wait a moment. I have an idea. So let's see. I tried to play it on my mobile.
Yeah, okay.
In parallel, so we can hear it from the mobile, and then you get my audio into the presentation, and then just need to synchronize.
Yes, we can try that, Dr. Andreas. We can try.
So this is good. So.
Mental maps, glandular epithelial anomalies, and
yes, we can hear it.
Diagnostics.
So So I go back and start over.
Yes, you can start it over. Yes, yes. Thank you.
So and here we go.
Anomalies and importance of differential diagnostics. Dr. Claudia Angelica Peña Peña, pathologist graduated from San Jose Hospital, Bogota, Colombia.
Yes, we can hear.
FUCS, PhD in cytology. Visit my website www.educandome.co. Mind mapping is necessary to diagnose mainly differential diagnosis in medicine, pathology, and cytology. The presence of glandular epithelial abnormalities, unconventional as well as liquid-based cervical cytology, often causes difficulty for morphological interpretation. For these anomalies are associated with various benign and malign processes of the epithelium of the endocervix. Amongst endocervical lesions, there is a benign group with morphological, architectural, and cellular similarities with neoplasia, adenocarcinoma. Help in its differential diagnosis and to show the course followed by this topic research. Here we review neoplasia-like lesions, endocervical dysplasia, and in situ adenocarcinoma. Glandular lesions. Let's review the facts. GC comprises a very small percentage of all PAP results, 0.05 to 0.8%. AGC on a PAP test represents a significant risk of a pre-neoplastic or neoplastic lesion, 10 to 39%. AIS, glandular counterpart of CIN3 and the direct precursor of invasive endocervical adenocarcinoma. Precursors of AIS, i.e. low-grade glandular dysplasia, is not well defined and thus not accepted as a distinct histology or cytology entity. Atypical glandular cells. Quality control, quality assurance. 1. Prevalences of AGC, less than 1%. 2. Clinical history. 3. Communication. 4. Criteria application. 5. Retrospective review. 6. Cytology, histology correlation. Glandular epithelial anomalies. Specify if endocervical, endometrial, or glandular cells. Specify endocervical and glandular cells with qualifier, favor neoplastic or NOS, or add a comment. Cervical adenocarcinoma in situ, AIS, adenocarcinoma, Cervical endometrial straturin, NOS. Here we have images of normal endocervical cells. EC adenocarcinoma in situ. 1. Hyperchromatic crowded groups. 2. Increased nucleus to cytoplasmic creation. 3. Nuclei large, 75 UM2. 4. Even chromatin with coarse granularity. 5. Micronucleoli. 6. Rosettes. 7. Feathering. 8. Strips with pseudostratification. 9. Mitosis. Apoptotic bodies. 10. Amphophilic granular cytoplasm. 11. Clean or inflammatory background. Adenocarcinoma in situ. Here we have images showing you the adenocarcinoma in situ. First image, histology or AIS. Second one, loss of honeycomb feathering. Next one, rosette with coarse granular chromatin. Down to the left, palisading on LBP, then Bird's tails on LBP, and last one, rounded endocervical cluster on LBP. Endometriode AIS, smaller cells than usual type AIS, absence of EM, stroma and stromal fragments, most commonly missed AIS. AGC is acceptable. Now we are going to compare HSIL versus AIS. So let's look at the features. Strips and rosettes. They are absent on the HSIL and present on the AIS. Gland forms absent on the HSIL and present on the AIS. Feathering absent on the HSIL, present on the AIS. Polarity is lost in the HSIL and maintained in the AIS. In U shape, irregular in the HSIL and oval cigar on the AIS. Chromatin is coarse on the HSIL and even in the AIS. Cytoplasm is dense in the HSIL and even in the AIS. And the background, we have isolated cells on the HSIL and rare ABS on the AIS. Invasive EC adenoca. Abundant abnormal cells, many features of AIS, macronucleoli, cytoplasm, finally, vacuolated necrotic tumor diathesis may be present. In LBP, we have 3D cluster more common. Isolated cells seen, chromatin more open, clinging diathesis. Biloglandular adenocarcinoma usually occurred in younger population. Their mean is 35 years. 62% history of oral contraceptive use, usually well circumscribed, minimally invasive, behavior favorable, LN metastasis rare, conservative management gone only for pure GR1 lesions with minimal invasion, LBI margins, atypical endocervical cells, NOS, endocervical type cells with nuclear atypia that exhibits obvious reactive or reparative changes but lacks unequivocal features of AIS or invasive adenocarcinoma. No neoplastic processes that may show atypical changes include repair, inflammation, IUD, radiation changes, endocervical polyps, tubal metaplasia, lower uterine segment areas, stellar reaction, microglandular hyperplasia, UD, atypical endocervical cells. Atypical endocervical cells favor neoplastic. Endocervical type cells in which cell morphology, either quantitative or qualitative, fall short of endocervical AIS or invasive adenocarcinoma. Arrangement sheets, strips, cluster of cells. Columnar cell shapes. Polarity maintained in cell cluster. Palisading pseudo-stratified nuclei with feathering hyperchromatic nuclei with evenly distributed coarsely granular chromatin. Mitosis, apoptotic bodies, and C ratio increased. Cytoplasmic mucin decreased. Clean background. Samples of atypical endocervical cells favor neoplastic. Process of AGC, sampling device, voracity of the sample, anatomic consideration, benign pathology processes, neoplastic processes. Cytology mimickers of AIS AGC. 1. Abundant normal endocervical cells, proglandular hyperplasia. 3. Tubal metaplasia. 4. Ischemia neoplasia. 5. Endocervical polyps. 6. Directly sampled endometrium. 7. Intertwined device effect. Benign reactive reparative endocervical cells. Sampling device effect. Hyperchromatic crowded groups. EC cells may be pleromorphic. Repaired adenocarcinoma. Repair can show one or more reactive cellular changes, can involve ischemias or columnar epithelium, a sheet-like pattern with distinct cytoplasmic outlines, streaming polarity, and typical mitosis distinguished from high-grade lesions, nucleoli often seen, LBPs, rounder cell groups, less streaming, nuclei are more prominent. Tubal metaplasia, benign metaplasia of EN and upper EC canal, architectural mimicker of AIS, planned nuclear features, columnar endocervical cells in small or often pseudostratified groups, nucleate, round, oval, chromatin evenly distributed, nucleoli no prominent, mitosis rare, presence of cilia, terminal bars characteristic, P16, Ki67, NEG or spotty plus. Tubal metaplasia cytology features. 1. Incomplete feature of AIS. 2. Chromatin texture distribution. 3. Nucleate washout. 4. Nuclear pleomorphism. 5. NC increased. 6. Mitosis. Rare apoptosis. 7. Large strip nuclei. 8. Cilia, terminal bars. Schemas neoplastic mimickers. 1. Most common cause of EC atypia. 2. Most common with brown brush. 3. Involvement of EC gland necks. 4. Learning curve. Schemas neoplastic mimickers may see 1. Groups of cells with glandular architecture, palisading pseudocolumnar. 2. Nucleoli. 3. Granular cytoplasm. Look for 1. Syncytoid groups. 2. Opaque hyperchromatic nuclei. 3. Glassy eosinophilic cytoplasm. 4. Individual dysplastic ischemic cell. 5. Lack of typical EC architecture. Cervical polyps. Common symptoms of bleeding, surface ulceration, EC proliferation, abundant cellularity, HCGs, reactive changes, enlargement, nucleoli, mitosis, inflammation, reparative changes, degeneration, abnormal chromatin can mimic EC or EM neoplasia. Directly sample endometrium. Type groups ACG or two-dimensional sheets, small reniform nuclei, small nuclei, wispy glandular cytoplasm, cytoplasmic vacuoles, rare, tubular gland formation, mitosis, apoptosis, cell size smaller than AIS, reactive cellular changes associated with IUD, glandular cells simply or in cluster resemble a normal endometrium, three-dimensional vacuoles, enlarged nucleoli, breakdown, cytoplasm variable, often ring, nuclear degeneration, nucleoli, calcifications, metastatic tumors, rare metastatic malignancies, ovary, endometrial, breast, small cell carcinoma, squamous, neuroendocrine lymphoma, other serious carcinoma, adenoid, cystic colon. Background clean unless there is direct extension of tumor. Thank you for your time.
Thank you, Dr. Claudia, and thank you, Dr. Andreas, for playing this. I would, without waiting further, and I would like to say that all the posters are available on the official website of the 5th Emirates Pathology Conference. The complete conference session video will be available on YouTube and other broadcasting sources. The certification will be provided to you on December 4th, 2020. UCG is organizing the 6th Emirates Breast Pathology and Breast Cancer Conference on February 9th and 10th, 2021. I hope we will all meet again with new research and innovation in the field of pathology. Mark your calendar dates. And now, the closing ceremony shall proceed. Dr. Sophia, we shall start with you firstly.
Thank you so much, Dr. Neetu. An excellent sharing session by both Dr. Archana and Dr. Neetu today. Wonderful job. We had an academic feast today. I think everyone will agree with so many cases and presentations from all over. I would like to thank all the accomplished speakers, the delegates, organizers, and my wonderful fellow chairpersons for a very well-organized and smooth-running event. We hope you enjoyed the sessions, and thank you for staying with us through the entire 2 days of the conference. I now invite Dr. Andreas to say a few words.
Thank you, Dr. Sophia. Well, we all seen very high quality speeches, and apart from that, I met a lot of interesting people virtually, which are very sympathetic and which I wouldn't have known without this conference. An advantage of this virtual event is that it's a very easy way to get in contact with people from around the world. And I really enjoyed this familiar atmosphere. And at this point, I would like to thank the UCG organizers to make this possible. I'm looking forward for the upcoming meetings, and hopefully I can meet all of these nice and interesting persons in person. Yeah, I'm very happy that I could be a part of it, and thanks to all of you. And now I can forward to Dr. Archana.
Well, thank you, Dr. Andreas. I'm truly thankful to all the speakers, delegates, chairpersons, and other participants at this Emirates Pathology Utilitarian Conference Gathering 2020 for making it a grand success. This conference has provided a platform for various pathologists around the globe to come together to share their subject knowledge, keeping us motivated to update ourselves in the field of pathology. Also, it is really inspiring to see everyone volunteering in this conference and devoting their valuable time. And lastly, I would like to express my appreciation to the committee members as well, who made things clear for us and supported us throughout the conference. And thank you all for your hard work and effort during this difficult time. I'm looking forward and hoping to see you all during the breast pathology and breast cancer conference to be held on February 9th, 10th in the year 2021. And last but not the least, stay safe and take care. Bye. Over to you, Dr. Neetu.
Yes, thank you, Dr. Archana, Dr. Sophia, Dr. Andreas for chairing the sessions and coordinating very smoothly. Thank you so much for all the delegates and the speakers and the participants who had contributed a lot of knowledge sharing that had happened in this knowledge conquest for past 2 days. So it is my privilege to have been asked to propose a vote of thanks in an international academic fest like this. And an event like this cannot be possible without the rolling of this from weeks before. So this kind of event cannot happen overnight, and it requires a lot of planning, which our backup team, the crew, the UCG Utilitarian Conference members, organizers had made it run smoothly. Thanks to them. And all your presence had only shown a stronger commitment to our work. Thank you.
Thank you all.
Thank you, one and all.
Yeah, thank you, one and all.
Okay, good evening and good night, everyone.
Yes,
Goodbye.
good night.
Yeah,
Good night.
Nice knowing all of you.